So we had covered around 15 questions yesterday. We will try to cover maximum possible today. And if at all we are not able to complete the remaining questions in today's session, because like as I have already told you, my goal is to touch upon or touch around the important topics, not just the questions. So we will go a little here and there about the topic, so that even if something twisted is asked from the topic, you will be able to answer. If there is a need for one extra session, I will request the PW team to create one more session so that we will complete all the essential points from medicine. Okay, this is what we were discussing yesterday. We were discussing the ulcers, right? This was the last question that we had wound up our discussion. Now, question is, Cushing's ulcers are associated with which of the following condition? And all of you had given the correct answer. That is your head injury. Basically or typically we see Cushing's ulcers whenever there is raised intracranial tension, regardless of the cause. It could be head injury or it could be a large space occupying lesion. Whenever there is raised intracranial tension, we can have Cushing's ulcers. These are also basically stress ulcers, right? When it occurs with burns, we call it as Curling's ulcers. But broadly speaking, all these ulcers are stress ulcers. Okay. Now, can anybody tell me in what other conditions you can get stress ulcers, or more commonly in what setting you see stress ulcers? Do you think the Cushing's or Curling's ulcers are very common, or you're likely to encounter stress ulcers much more common in other settings? What is the setting that we are talking about? What is the setting we are talking about? Which patients are more likely to have stress ulcers or develop stress ulcers? Mostly stress ulcers are more commonly encountered in patients who are suffering through critical illness, right? Critical illness, those who are in the ICU. Critical illness, those who are in the ICU. So it is one of the complications of critical care medicine, one of the complications that patients being treated under ICU experience or suffer, and it is our duty to prevent occurrence of the stress ulcers, right? Okay, so that also means that we should know how do we prevent. Point number one, what is the drug of choice for prevention of stress ulcers in critically ill patients? Okay, those who don't know why stress ulcers occurs, it is believed that when we are going through stress, there is upsurge of inflammatory cytokines which can be injurious to the gastric mucosa, and that is how the stress ulcers occur. Stress ulcers more commonly occur in the stomach and very rarely they occur in the duodenum. Okay, so that point is clear. Stomach is where we are looking at, or gastric is where we are looking at for the stress ulcers. And now if you have a patient, like say, let me give you an example. There is a patient with sepsis with multi-organ failure. He is in the ICU now. How do we prevent him from developing stress ulcers? What is the drug of choice? Okay, how many of you are thinking between PPIs and how many of you are thinking of PPIs versus H2 receptor blockers? What is the current standard? We have two options, right? We can give the like H2 blockers, or we can give PPIs. Which one is preferred? H2 receptor blockers versus PPIs. Which one is superior in terms of prevention of stress ulcers? Which one is superior? Okay, best cock base with link, ranitidine. Superiority wise, I think all of us agree that PPIs are superior, right? They're definitely more potent than your ranitidine or any other H2 blockers. But until recently, like last couple of years ago, like till that time, the preferred agent used to be H2 receptor blockers, because we had some concerns about use of PPIs in the ICU. Can anybody tell me what those concerns were? What are the side effects of PPI that me as an intensivist would be really worried about when I'm using PPIs in the ICU? What those concerns would be? Good. What those concerns would be? Okay, see, ICU care is all about prevention of complications and supporting the major organs till body recovers from the insults that it is going through. Sepsis, antibiotics is taking care of the infection, but as an intensivist, my job is to support the organs which are failing And also make sure that you don't develop complications. What complications in ICU we are expecting? One is stress ulcer that we are talking about, development of DVT, right? Hospital acquired infections, bed sores. All of these are the complications. So prevention of complications, supporting the organs. That is the primary objective of ICU care. Rest of the things like infection, sepsis, antibiotics are taken care of. Head injury, brain edema, the neurosurgeon is taking care of. Right? This is going to be my objective. Now, in achieving these objectives, right, why PPIs are going to become a roadblock? PPIs have renal toxicity. Okay. Does anyone know that is there any link between respiratory infections and use of PPIs? Is there any link between respiratory infections and use of PPIs? Yes, PPIs best cock base with link, right? Awesome, good. So it was observed that use of PPIs was associated with increased risk of hospital acquired pneumonia, especially on ventilated patients. So ventilator associated pneumonia, even on a non-ventilated patient, there was higher risk of respiratory infections or pneumonias, and also the risk of aspiration pneumonia. Various hypotheses exist why that happens, but at least the observation is PPI use was associated with higher risk of respiratory infection. That was the first problem. Second, yes, it interferes with the, yeah, basically by altering the gut microbiota, one of the hypotheses. Okay, so that observation was the main reason why PPIs were not preferred. So if you look at the previous edition of Harrison, it mentioned H2 receptor blockers as the preferred treatment for prevention of stress ulcers. But even then, the studies were very clear. Studies when compared with H2R plus the PPIs were superior in prevention of stress ulcers. But now we use PPIs as the preferred mode of prophylaxis for stress ulcers. But it is recommended. Previously, it's like all patients who are landing in ICU, give them a stress ulcer prophylaxis. Just give them. Like you're admitting with a trauma, you're admitting with sepsis, you're admitted with CKD, whatever is the cause, all patients we used to give a stress ulcer prophylaxis. And in those settings, this used to be a more logical choice. But now the guidelines are revised. Now what is recommended? The stress ulcer prophylaxis is not routinely recommended for all patients. Not for all patients, only high risk patients. And there use PPIs, don't need to go for the H2 receptor blockers. What are the high risk patients? Burns are more prone for developing stress ulcers, give them. Head injury, high risk of developing stress ulcers, give them PPIs. Okay. Patients with uremia, CKD or acute kidney injury with urea being high, give them. Patients with active inflammatory cascade like sepsis, high risk, give them. For all other patients who are in ICU for varied reasons, you don't need to give them a stress ulcer prophylaxis. Clear? So previously, because we were giving every patient, the risk benefit analysis favored that use a safe drug, H2 receptor blockers. Now that we are very selective, there the risk benefit analysis clearly says that PPIs are much more better drugs to give in terms of risk benefit profile. So now PPIs are the preferred agent, but not for all patients. Okay, good. Now let's move to the next question. Identify the feature of paroxysmal nocturnal hemoglobinuria. Which of this is a right statement about what we call as PNH, paroxysmal nocturnal hemoglobinuria? Inherited defect in PICA, deficiency of CD55 and CD59, extravascular hemolysis, microcytic anemia. Which of this is a right statement? Yeah, history of ulcer, the guidelines do not mention it, to be very frank, but I think we should take it as a risk factor, especially if it is non-H. pylori ulcer, we should take it as a risk factor. You know, when we talk about peptic ulcers, you can have peptic ulcers which is caused by H. pylori or which is caused by NSAIDs. You know, for both of these patients, like, okay, let me put this point in. So peptic ulcers or peptic ulcer disease can be caused by H. pylori infection. It can be caused by NSAIDs. And the third set of patients where it is non-H. pylori, non-NSAID induced. Okay. For how many days do you give the PPIs for these patients? Like H. pylori infection, how many days you are going to give the PPIs? NSAID induced, how many days you are going to give the PPIs? How many days you are going to give the PPIs for H. pylori infection? You are going to treat them with the antibiotic kit or a combination of antibiotics, right? Plus you are giving them PPIs for facilitating the ulcer healing. How many days? Not 2 weeks, not 4 weeks, not enough, not enough. 2 weeks you give antibiotics, 10 to 14 days is the recommended duration of antibiotic therapy. Mostly that 10 to 14 days you are giving a combination of a PPI plus antibiotics, right? Currently we use a 4 drug combination. Okay, so the recommendation is 4 to 8 weeks. 4 to 8 weeks in both cases, NSAIDs as well as H. pylori infection. But in case of NSAIDs, if there is need for continued exposure to NSAIDs, then as long as you are continuing the exposure to NSAIDs, you need to give a PPI. NSAID induced, if you're able to stop the NSAIDs, then you give 4 to 8 weeks for healing of the ulcer. But if there are certain conditions where there is no way, but you have to continue to give NSAIDs to the patients, in those cases, as long as NSAID exposure is continued, you need to give. But the duration of PPI therapy for non-H. pylori, non-NSAID ulcers. No, 8 weeks is max, that is adequate for most patients. 8 weeks or 2 months is adequate for most patients. By that time, the ulcer would heal if there are no other causes for the ulcer to persist. 4 may be adequate, but 4 to 8 weeks is roughly 8 is what we can take as number. Okay, so there is no H. pylori infection, there is no NSAIDs. Such patients, how long we should give? Good evening, Tiwari. So what is currently recommended is for these patients, it is generally lifelong. Because in the first two settings, which account for 95% of overall peptic ulcer cases, right, H. pylori infection and NSAIDs, we have addressed the underlying cause. We knew what was responsible for the ulcer, we have addressed it, right, and we have helped the ulcer to heal by giving PPIs. But in these patients, we don't know what has caused it. There may be factors, there may be metabolic factors, or there may be something else, the causes that we don't know. We're not addressed it, so because of that, these patients require lifelong. So these patients are definitely considered as high risk for stress ulcers also. So if they'll end up in hospital, if there is a previous history, we should definitely consider them as high risk and we should give them PPIs. Okay. On the other hand, this set of patients, if we are not giving NSAIDs anymore, if they have healed well from the previous ulcers, may not be considered as high risk. Okay. H. pylori, if you have documented that the infection is eradicated and the ulcer is healed, need not be considering these patients as high risk. So need not give them the prophylaxis. Okay, one last point. How do you lifelong? Yes, use of PPIs is associated with complications. So it is always about risk benefit balance, right? Yes, long term use of PPIs is associated with complications, hypocalcemia, right? Impairs with the vitamin B12 absorption. It is associated with complication. And there are some recent studies which have shown that PPIs, especially pantoprazole, in a long term use for several years can cause hyponatremia also. Hyponatremia also. So there are links with complications. So nothing is free of complications, right? Okay. Now coming to this next question. Identify the feature of paroxysmal nocturnal hemoglobinuria. Okay. The name says paroxysmal nocturnal hemoglobinuria. So that means the patient intermittently in the night he is going through some hemolysis and passing hemoglobin in the urine. That's what sense the name makes. Okay. Now the first question is why there is hemolysis? Why there is hemoglobinuria? Okay, paracetamol chemically is an NSAID, but its behavior in human body is so different. Chemically, it is a non-steroidal anti-inflammatory drug, but it doesn't behave like any other class of NSAIDs. So it is dealt as a different entity because chemically, yes, if under the pharmacology, if you're classifying, you are classifying it under NSAID, but it is so different from all other NSAIDs. It is different from the ibuprofen, diclofenac. Paracetamol as such doesn't cause you much of the gastric ulcers. So we use paracetamol as an alternative when we cannot use NSAID. Right. So in paroxysmal nocturnal hemoglobinuria, there is intravascular hemolysis. Hemolysis. So inside the blood vessel, RBCs are being lysed. Why they are being lysed? First of all, RBCs are protected from the own immune attack. Our RBCs are protected from our own immune system by presence of the CD55 and CD59. CD55 and CD59. These act as a protection against the attack by our own immune system. What component of the immune system is attacking our RBCs? It is the complements. So complement mediated RBC lysis is inhibited by the presence of these. These are our defense mechanisms. When these levels go low, or when these CD55 and 59 are not expressed on the RBCs, that means the RBCs are now vulnerable for complement mediated lysis. So complements will destroy the RBCs. Right? That is why inside the blood vessel the lysis is occurring. It is not that spleen is removing these RBCs. Inside the blood vessel they are being lysed by complement mediated attack. So it is not extravascular hemolysis. You don't see the microcytic anemia and you don't see the PIK-A mutation. It is the deficiency of CD55 and 59 which is responsible for paroxysmal nocturnal hemoglobinuria. Now in terms of one more point, is there any link between paroxysmal nocturnal hemoglobinuria and what you call as aplastic anemia? Is there any link between aplastic anemia and paroxysmal? Yeah, DAF and MIRL are the other names for CD55, 59. Yes, PIG, not PIC, right. Tarakandras, right. Is there any link between, yes, anemia is going to be normocytic. Is because the bone marrow is able to produce normal RBCs. The RBCs will be normocytic, normochromic. The RBCs which are in circulation are getting destroyed. It is not the defect of hemoglobinization of RBCs. So adequate amount of hemoglobin is put into the RBCs. Okay, is there any link between the aplastic anemia and paroxysmal nocturnal hemoglobinuria? Yes, these conditions are strongly associated with each other. So patients who are having the paroxysmal nocturnal hemoglobinuria are at high risk of developing aplastic anemia, and those who have been diagnosed with aplastic anemia, they may later on develop paroxysmal nocturnal hemoglobinuria. So it means that if you have one, the risk of developing the other is increased, right? So there is risk correlation between aplastic anemia and PNH. Okay, now coming to its treatment, how can we treat these patients? Should we give them the transfusions, or is there any better way of treating these patients? What have we learned? There is complement mediated lysis of RBCs. Right now there is no gene therapy that will make our RBCs to express CD55, 59, DAF or MIRL. There is no gene therapy, right? In the absence of gene therapy, what are our alternatives? One is we can target the complement system. Second is you can do a bone marrow transplantation where the transplanted marrow will produce RBCs which have CD55 and 59, right? Those are the only two strategies we can follow, right? If anemia is severe, as an emergent measure, you can think of transfusions, but that's not a long-term solution. So treatment wise, we have two options. Option number one, we can try to target the complement system. Right, eculizumab is the drug. It's the monoclonal antibody against the complement system factor 5, C5, right? Monoclonal antibody against C5, which is eculizumab. That can be used. This is an important MCQ point, so please remember this. And second thing is bone marrow transplantation, right? What is the definitive treatment? The definitive treatment is bone marrow transplantation. This is the definitive treatment. Okay, so that's about the paroxysmal nocturnal hemoglobinuria. Point to remember, it is an intravascular hemolysis. It is not extravascular hemolysis. Most of the questions that have appeared on this are mainly trying to trick you between intravascular, extravascular. Then there is deficiency of CD55, 59. There is complement mediated attack on the RBCs. Treatment wise, we give a monoclonal antibody against the complement, which is eculizumab, and the definitive treatment is bone marrow transplantation. Okay, good. Now let's move on to the next question. Question number 18. Methotrexate and low dose corticosteroids were advised to a rheumatoid arthritis patient 4 months ago. Okay, from the statement, my understanding is that he was diagnosed with rheumatoid arthritis 4 months back and he was started on methotrexate and low dose corticosteroids. Okay, and the disease was still progressing. So 4 months ago, he was diagnosed with rheumatoid arthritis. They started with methotrexate and low dose corticosteroids. 4 months later, when now they are following up with the patient, the disease is still progressing. And they're asking what is the recommended further management of this patient. Options are stop oral methotrexate and start parenteral methotrexate. Start oral methotrexate and stop oral methotrexate and start parenteral methotrexate. Is that the right thing to do, or start only TNF alpha agents, monoclonal antibodies, TNF alpha blockers, or continue corticosteroids and methotrexate? Just stick to same. Okay, or add sulfasalazine and hydroxychloroquine. Tropical Capricorn, yeah. So rheumatoid arthritis is one complex zone. If you look at Harrison, now he is leaning towards triple therapy using 3 drugs. Okay, there are some professional bodies including ACR which are still not pushing for starting with 3 drugs. They are still recommending that stick to 2 drugs. Okay, so it is going to be a bit controversial, but it is better to stick to the ACR guidelines for the management of rheumatoid arthritis rather than an author's view. See, right now Harrison textbook has become, which is not relying much on the guidelines, which is mostly following the author's views, right? What author thinks would be the appropriate way of managing the cases rather than guidelines. Guidelines are the simplest way to be part of the herd. Whatever is the whole population is doing, we'll also do the same. Legally safe. Exam is also, I think, safe. Yeah, I also believe that we should from the first beginning only start with 3 drugs, even without the follow. There is a reason why I believe in that. Okay, we will come to these options, but let us understand some points about rheumatoid arthritis. Okay, now rheumatoid arthritis, logically tell me which approach is going to be good to treat. Option number 1, I'll tell you that you start with the best possible drugs you have as soon as you diagnose a rheumatoid arthritis, and once you have a good disease control, start cutting down on your aggression. Like let me say I have started them on a TNF alpha blockers in the first go itself as soon as they presented to me, and once the disease is controlled, I am stepping down on medications. I am switching to some simple medication. That is one approach. The approach number 2 is I see them start them with the basic minimal possible medications like only methotrexate or only steroids. Then as time progresses, if they are not responding well, I keep adding the new drugs which are more potent. Which approach is good for rheumatoid arthritis patients? Which approach is good? You see all these rheumatoid arthritis patients, there are like nice images in your orthopedics books with all those deformities, right? Piano key deformity, swan neck deformity, all those deformities, right? What is the phase of rheumatoid arthritis, or what time in their course of illness where the maximum deformities occur? Is it in the early stages or is it in the late stages? Okay, so please remember one important statement. The maximum deformity occurs in the first 2 to 4 years of the onset of rheumatoid arthritis. After that, we call it as pent up or burnt out rheumatoid arthritis. Means all that immune aggression of the own body starts coming down. The immune aggression starts coming down. So with time, sometimes quite late in the course of illness, like 20-25 years after the onset of rheumatoid arthritis, you may not have the anti-CCP antibodies, you may not have the RA factor positivity, because the body reduces the production of those antibodies. The maximum activity is in the first 4 years, and this is a crucial period. This is the time where you have to keep the disease under control so that you are preventing them from developing deformities. Once they develop deformities, only surgical correction can be done, or you can just give up on correcting the deformities and you can't do much about it, right? So early phase, first 2 to 4 years are the most important time where you need to control the disease activity. That is why many doctors now believe that it is better to start with potent drug combinations in the beginning itself, and once like first 2 to 4 years are done, the disease activity anyway starts coming down and you can come down on the medications. But for the sake of question, we will stick to the ACR guidelines. Okay, so let us see what ACR guidelines talk about. Okay, but before that, when you have a patient of rheumatoid arthritis, whatever medications you're starting based on your own approach or based on the American College of Rheumatology guidelines, what is your objective? What you want to achieve in the patient? We all know that it is not a totally curable disease, right? It's not a totally curable disease. So the aim of treatment is basically to achieve one of the two things. One, priority aim is to achieve disease remission. Remission is different from cure. Cure is like the disease is gone. Remission is with medications, we have kept the disease, the patient's parameters very similar to a non-disease patient or non-disease individual, right? Remission is the ultimate goal. If that is not possible, we cannot achieve remission, or to achieve remission, we need to give drugs in such doses that it is going to cause side effects. So the next alternative, what we can think is what we call as low disease activity. Low disease activity. Now, how do I get to know whether my patient is gone into remission or not? I can't just ask him, right? When he comes for follow-up, how do you feel? The morning stiffness is better, the joint pains are better, good, I'm happy. No, because it is very subjective. Patient interviews are very subjective. So we need an objective definition of remission. And the ACR recommends the definition of remission is this, right? All of the following should be achieved to say that patient is in remission. That is our goal. The treatment goal is this. We need to achieve this. Okay, what is that? The number of tender joints should be 1 or less than 1. So when he comes back for follow-up after the initial treatment, the joints which are tender on palpation should be 1 or less than 1. If there are 2 joints which are tender, you are not achieved remission, right? The number of swollen joints, visibly swollen joints, should be 1 or less than 1. C-reactive protein should be less than 1 milligrams per deciliter. And there are some questionnaire for patient to assess his well-being. Patient global assessment, a score of less than or equal to 1. This is pretty easy to remember, the remission definition. Everything is 1, right? Everything should be less than 1. Tender joint count should be less than 1. Swollen joint count should be less than 1. CRP should be less than 1. Patient global assessment should be less than 1. Right? This is our goal. So we will start a medication. We will ask them to come back for follow-up after 3 months. And if we have achieved this, we are doing a good job, we will continue with the same medication. If we have not achieved this at the end of 3 months, that is the time where we will think of revising our medications, right? Okay, now tell me, what is the drug of choice, the standard medication that every patient of rheumatoid arthritis should get unless otherwise contraindicated? Which drug that we will be giving to all patients of RA unless otherwise contraindicated? Like we can call it as blanket prescription, sabko dena hai, right? Some of the rheumatological diseases have a blanket prescription that we will give to everyone until and unless it is contraindicated, right? So I'm just putting a slide for us to list those blanket prescriptions. I'm calling it as blanket prescription because we give it for everyone unless otherwise it is contraindicated. Right. Good. Okay, for rheumatoid arthritis, yes, it is methotrexate. It is methotrexate. Okay. For SLE, what is it? Yes, for rheumatoid arthritis, it is methotrexate. For all patients, until and unless it is contraindicated, we are giving it. Regardless of whether we add a second drug, third drug, fourth drug, we are giving it for sure. Yeah, for SLE, best COC, right. For SLE, it is hydroxychloroquine. So for all patients of SLE, if HCQS is not contraindicated because of your retinal issues or ophthalmological issues or cardiac issues, we are giving it for all patients. Over and above HCQS, we will add other drugs if required. Similarly, over and above methotrexate, we will add other drugs if required. Right? So this is like a standard prescription for these patients. Okay. Now what ACR guidelines recommend? The treatment is divided into 3 phases. Phase 1 is what we start initially, right? So what is the point here? Phase 1. You make a diagnosis of rheumatoid arthritis. First question to our mind is blanket prescription is methotrexate. Is there any contraindication? If there are no contraindications for methotrexate, we are going to give methotrexate. Along with methotrexate, we will start with the short-term low-dose glucocorticoids. Okay, why are we starting with glucocorticoids? We want to get rid of glucocorticoids. We will not give it for a long run because we know it has side effects and it has problems. But we are giving a short-term glucocorticoids along with methotrexate for one reason. I have made a statement saying that first 2 to 4 years is where there is a maximum disease activity and maximum damage to the joints occurs. So we want to get the disease under control as soon as possible. So to give that extra push for a quick control, we are adding a small dose of steroids for a short period of time. Clear? So whether this patient, they have followed this approach in this question, let us see. You started with methotrexate and low dose corticosteroids, right? So whoever is treating this patient has followed the ACR guidelines. He started with methotrexate and low dose glucocorticoids. When should we do the follow up now? He has followed the guidelines exactly how it is recommended. If methotrexate was contraindicated, he would have started either on leflunomide or sulfasalazine. Those are other DMARDs, right? Non-biological or conventional DMARDs. He would have started one of them. But because that particular patient did not have contraindication, he has started methotrexate, and as recommended, he has added a small dose of glucocorticoids. The recommendation is we should be following up the patient at 3 months. In this question, patient has come for follow-up at 4 months. That's fine. 3 months is what we have recommended. So at the end of 3 months, what is our expectation? At the end of 3 months, remission is not possible, right? Most cases, remission is not possible within 3 months. So at 3 months, the target is to achieve improvement. And at 6 months, okay, at 3 months, improvement at 3 months and remission at 6 months. I have already defined what is remission, right? At 6 months. Okay, so 3 months may we would want this patient to show improvement. Again, not based on just patient's perception or your perception. There are scoring systems. Okay, there is Simplified Disease Activity Index, SDAI. Simplified Disease Activity Index, or there are other scoring systems. You can use any of them objectively. Like before the starting of treatment, these were the scores. Now after 3 months of medications, I can notice the improvement. If improvement is there, you will continue the medications for another 3 months, 6 months, right? Total 6 months. At the end of 6 months, remission should be achieved. If we have achieved the remission, then we will continue with the same medications, and if possible, if the remission is sustained for subsequent follow-ups, maybe you can aim for dose reduction. Why we can aim for dose reduction? As I have told you, over time the disease activity naturally comes down. So then maybe we can maintain with lower dose. But if you have failed to achieve improvement at 3 months or remission at 6 months, like sometimes what happens is you see a improvement at 3 months, you continue for 6 months, but at the end of 6 months, remission target is not met. Patient still has more than one tender joint or CRP is still elevated. In those both scenarios, no improvement at 3 months, 3 months only you're making a decision to move to the next phase, or at 6 months you're not achieved remission, you're making a decision to move to the phase 2 treatment, right? In phase 2 treatment, what choices we have? We had started with methotrexate plus steroids. Now in front of us there is a long list of drugs. We have biological agents, right? Biological DMARDs like anti-TNF alpha drugs and various other biologicals. We have genus kinase inhibitors. Those are options in front of us. But we also have the other conventional DMARDs which we did not use. We had only started with methotrexate and steroids, right? Like for example, leflunomide, sulfasalazine. We have so many other conventional DMARDs. So which one we will add now? Which one we will add? That depends on whether patient has some factors which suggest poor prognosis. If patient has no factors which suggest poor further prognosis, you would better add them on another conventional DMARD like methotrexate plus glucocorticoids, 3 months, no improvement but doesn't have any poor prognostic factors, then I will add leflunomide or I will add sulfasalazine. Okay. On the other hand, if there are poor prognostic factors present, then it is better for me to go to a biological DMARD because I know first 2 to 4 years are very important. I can't wait for another 4 years to achieve remission. मुझे next 3 months में remission चाहिए. Right? What are those poor prognostic factors? Most important poor prognostic factors that I want you to remember, which examiner might put it in the question, is he will mention evidence of early joint damage. Right? How do we get to know the early joint damage? How do we get to know the early joint damage? When you do ultrasound, right, the synovial erosion can be documented on ultrasound. So nowadays rheumatologists do ultrasound of the joint to understand synovial injury. Synovium is the one which is affected here. So that can be one poor prognostic factor. Okay. Plus, if the antibody levels are high, anti-CCP antibody or RA factors high positive, okay, or the disease activity scores that we did, simple disease activity index or SDI, if the scores are very high, all that means that the poor prognosis. In such cases, you will go with the biological DMARD or a Janus kinase inhibitor. Okay. If there are no such poor prognostic factors, you will add a leflunomide or sulfasalazine. Okay, and the story continues. You will follow up again after 3 months with whatever change you have made. Improvement, good, you will continue for another 3 months. 6 months from now, if there is remission, you will maintain. If no remission, you will switch to phase 3. Okay, phase 3 is more about trial and error. In the sense, no objective guidelines exist. You started with something, add something else and see how he responds. Okay, usse bhi nahi ho raha hai, add something else and see how he responds. So phase 3 is more about trial and error to see what works for the patient. Yes, synovial joint erosion is what we will be looking at in the ultrasound. Okay, now let us go back to the question and see with whatever information we have, what makes sense. Stop oral methotrexate and start parenteral methotrexate. Is it recommended anytime in rheumatoid arthritis patient? No, right? We don't consider using parenteral methotrexate in rheumatoid arthritis. So that's not our option. Okay, start only TNF alpha agents. When were we considering TNF alpha agents? When poor prognostic factors were present. From the question, there is no information about poor prognostic factors. They have not given about the antibody titers. So we don't know whether the RA factor activity was very high, whether anti-CCP levels were very high. They have not told that they have done an ultrasound or an MRI of the joint and there is synovial erosion. Do we have that information? No. Right? So there is no evidence of presence of poor prognostic factors. So in that case, I wouldn't be thinking of biological DMARDs, neither Janus kinase inhibitors nor biological DMARDs. Poor prognostic factors. Clear? So option B is out. Now what are we left with? Continue corticosteroids and methotrexate, an unacceptable choice, because if I just continue with corticosteroids and methotrexate, I'm allowing the disease to progress, and morally and legally I will be responsible for this patient developing deformities 1 to 2 years down the line, right? So the only choice here would be to add a conventional DMARD because there are no poor prognostic factor. So option D makes sense, right? Option D makes sense. If given a choice, I would have just added one of them, either sulfasalazine or hydroxychloroquine. But anyway, like among the options, I would rather choose this than anything else. So the D is correct answer. Got? Now similar questions can appear. So I would recommend that all of you please go through these recommendations, American College of Rheumatology recommendations. Yeah, someone was talking about triple therapy is where you start with 3 drugs. Logically, that's a good thing to do for the patients because disease activity should be controlled as soon as possible. In practice, you can implement that. Harrison talks about it. But for the exam, answer it based on this flowchart. Right? Phase 1, phase 2. Don't think about phase 3. Okay. Now, one last question about rheumatoid arthritis. Is there any link between infections and development of rheumatoid arthritis? And if yes, which organism we are talking about and where that organism is causing infection. Link between rheumatoid arthritis risk and infection. Like for example, there are some studies which show that Epstein-Barr virus infection is associated with increased risk of SLE. Similarly, now there is convincing evidence to say that this particular infection is associated with increased risk of developing rheumatoid arthritis. So what infection we are talking about? Okay, so please remember, rheumatoid arthritis risk is increased in gingivitis patients, especially caused by an infection organism known as Porphyromonas gingivalis. Porphyromonas gingivalis. Okay, why this causes the increases the rheumatoid arthritis risk? Because this Porphyromonas gingivalis does one thing. it citrulinates tissue protein. So whenever, like when it causes gum infection, whatever proteins are there in the tissues, na, it adds citrulline to it, right? And what antibody we see in rheumatoid arthritis? Anti-CCP. What does it stand for? Antibodies against cyclic citrulinated peptides. So the citrulline is being introduced by this organism and body will produce antibodies against it. And there are other citrulinated proteins in the joints which also indirectly get targeted by those antibodies. This is one important point that I want you to remember now. Madhavan ki, yes, like whenever you're suppressing the TNF, right, there can be reactivation of tuberculosis. So yes, obviously you need to check for the TB activity before you start on the anti-TNF alpha therapy. Okay, now coming to the next question. A woman came to physician with fever. She also complained about oral ulcers and photosensitivity. On examination, rashes were seen on her face as shown in the below image. She might be suffering from which of the following condition? Dermatomyositis, rosacea, systemic lupus erythematosus, or melasma. Tropical Capricorn and Tarakanthas, right? Anti-CCPA, right? So we were trying to figure out over the years what causes these antibodies to be formed. So we have one lead in the recent times, like last 5-6 years, that this Porphyromonas gingivalis. And we already knew for several years that those who have gingivitis were at increased risk of developing rheumatoid arthritis. An organism was isolated, and we also noted its activity, that it citrulinates the tissue protein. So it tries to work on the tissue proteins, introduces citrulline into their peptide chain, body produces antibodies against it. And there are several synovial proteins which have citrulline, and these antibodies will cross-react with that, and that's how the synovial injury occurs in rheumatoid arthritis. Okay, point number 1. Can this be dermatomyositis? Can this be dermatomyositis? Now, don't only look at the image, right? Every time you have an image-based question, the story in the question is more important than the image. Please remember that image supplements your story. Woman came to physician with fever. Okay. Then she complained about oral ulcers and photosensitivity. Dermatomyositis, do these patients have fever and photosensitivity? And what kind of rash these patients get? Dermatomyositis. Okay, tell me then, name the rashes that patients with dermatomyositis develop. Okay, dermatomyositis is a immune-mediated inflammatory myositis with skin involvement. So, if there is a patient who has dermatomyositis more than skin involvement, what brings him to the hospital is the myositis, right? And whenever we talk about inflammatory myositis, mostly we are talking about proximal muscle weakness. So these patients would have proximal muscle weakness. They'll come to you saying that I'm unable to comb my hair. I feel very weak. Even combing is difficult. They'll find it difficult to raise their head, arm above their head, because proximal muscle means muscles around the shoulder girdle, and for the lower limb, proximal muscle means muscles which are working around the hip. So they have difficulty in climbing the stairs. They have difficulty in combing. That is one of the presenting complaint. They may have tenderness of the muscle. In addition to that, there is involvement of skin. Right? You have another condition called polymyositis, which is also proximal muscle involvement, which is also immune mediated, but skin involvement is not there. Right? You can have Gottron's papules, you can have mechanic's hand, you can have a shawl sign. Those are the signs. Right? So this image doesn't fit into that picture. Point number 1. Second, you don't expect patients with dermatomyositis to present with fever. Okay, so it is a bit unlikely. Okay. Then can this be melasma? Can patients with melasma present with fever, oral ulcers, or photosensitivity may be acceptable, that they have a melasma and when exposed to sun it can worsen. But can they present with fever? Can they present with oral ulcers? Right, good. So melasma is a bit unlikely because we cannot explain fever. We cannot explain oral ulcers. Similarly, in rosacea, I wouldn't be expecting them to present with fever or oral ulcers. Right? Can a patient with SLE present with fever? Can a patient with SLE present with fever? Yeah, we'll come to the image. We'll come to the image. Before that, always try to dissect the story of the question, because that is where mostly the answer is evident. Image only supplements it. And sometimes even when you don't know the image, you will be able to answer if you can dissect the story. Can SLE present with fever? Okay. Can anybody tell me what is the diagnostic criteria, not diagnostic criteria, the classification criteria that is followed for SLE right now? Right, we are following something called as the ACR ULAR classification criteria for SLE. Before that, we used to follow something called as SLICC criteria, right? So for classification criteria for SLE, we are following what is called as ACR ULAR. Okay, and in this there are few points. Point number one, to diagnose someone as having SLE, you need an entry criteria, that this is a minimum point that this patient should have. If he has, then we will start thinking about SLE. Entry criteria. Okay, so what is the entry criteria? What is the minimum thing required for the diagnosis or classification of a case as SLE? The entry criteria is ANA positivity. ANA should be positive. That's the bare minimum thing that is required for classifying a case as SLE. ANA should be positive. And they have defined that the titer of this to call it as positive should be 1:80 or better, right? The minimum titer is 1:80 or 1:160, 1:320. Minimum is 1:80. Okay, right? And it should be based on indirect immunofluorescence. So immunofluorescence is a method of choice for estimating the ANA, right? After that, there are lab criterias and there are clinical criteria. So in 2018 or 19 NEET PG, there was a question asking you which of the following is the newly introduced domain in the current classification criteria. I think 2019 for the SLE. Subhash, yeah, I'll come there. Subhash are right. ANA positivity is the entry criteria. Then you have a lab and clinical criteria. Right, there are different domains in the lab and in the clinical criteria. There are different domains, and a total score of 10 is required to classify a case as SLE, out of which 1 should be from the clinical criteria. Right. Now, in the clinical criteria, a new domain was added in the currently followed classification criteria. Right. The new domain is constitutional symptoms. New domain is constitutional symptoms. Otherwise, the other domains were the respiratory system, neurological system, cardiovascular system, something like that. So constitutional symptoms was a new domain that was added, and there is only one symptom that was mentioned under this, and that is fever, because fever is very, very common in SLE patients. Okay, so it's now a criteria for classifying a case as SLE. Previously it was not, but it is newly introduced. Same question can appear again, so remember. Okay, so fever can be explained by presence of SLE. Oral ulcers are one of the manifestations of SLE. We know that. The rash in SLE is very much photosensitive. We know that. So these three things can be explained by presence of SLE. Now let us look at the image. So what do we see in the image? There is rash in the malar region. It is hyperemic. It doesn't look like melasmic. It's more of hyperemic. And there is characteristic sparing of nasolabial folds that you can see here, right? The sparing of nasolabial folds. So the rash is also very typical of SLE. Patient story is typical of SLE. Rash is typical of SLE. So our diagnosis is SLE, right? Now, every time you get this kind of a question, first try to get some idea from the story, because as examiners, we can introduce some confounding factors which can confuse you and take you in the wrong direction. So always try to make some diagnosis from the story and then come to the image. When you don't have time or we don't really know much about it, you can take a guess based on the image, but always try to make a diagnosis from the story. Okay, let's move to the next question now. On standing, the murmur increases in which of the following conditions? This is like one of the very important question, right? In case of cardiology, I think whether we are presenting the case or in the examination hall writing MCQs, the dynamic auscultation and its interpretation is very, very important, right? What is the question? On standing, the murmur increases in which of the following conditions? VSD, mitral regurgitation, mitral stenosis, and HOCM. Arnan, right, fever is added in the currently followed classification criteria. Those who are following little old notes or old books, you are still following what is called as SLICC classification criteria for SLE. Please dump it and follow the current ACR ULR. Okay. Tushar Bansal says HOCM. In HOCM, on standing, the murmur increases in intensity is what Tushar thinks. Sudha Shukla, right? She is also thinking D. Tarakandas. Okay. So when we auscultate, right, for murmurs, what are the standard things that we describe when we auscultate for murmurs? First thing that we would describe when we auscultate for murmur is its location, right? Where is it best heard? Whether it is systolic or diastolic. And if it is systolic or diastolic, we will also mention which part of the systole or diastole it is occupying. Early systolic, mid systolic, late systolic, early diastolic, mid diastolic, late diastolic, or pan systolic, pan diastolic, whatever. We will describe that. Okay. But that may not be adequate to understand what valvular pathology we are talking about, because there are factors like, for example, a murmur can be conducted elsewhere, so you will hear the same murmur in other areas, and in that case, to know whether it is a particular valvular disease becomes difficult, and the dynamic auscultation helps in making that out, right? So we will subject the patient to some physical maneuvers to understand what that physical maneuver does to the murmur, right? There are a few things that commonly we do in dynamic auscultation. Number one we can do is asking the patient to standing. Okay. The second thing we can do is squatting. Right. The third thing we can do is what happens with respect to inspiration, expiration. How murmur behaves during inspiration and expiration. We can also look at passive leg raising. Passive leg, we can make the patient lie flat, raise his leg passively. What happens to the murmur? Okay. We can also do a Valsalva. Okay. Now let us see what happens with these individual circumstances. Okay. I'm starting with inspiration and expiration because I want you to remember one dictum about inspiration and expiration. When you're taking inspiration, what happens to murmurs? If you ask the patient to start taking inspiration and if I'm auscultating during that period of time, what change I can notice with respect to murmurs? What change I can expect with respect to murmurs? Okay, so this is our heart. This is our heart. This is our right atrium, right ventricle, left atrium, left ventricle. Right? Right atrium receives blood from the superior and inferior vena cava, right ventricle takes the blood to lungs, right? From the lungs we receive the blood coming back to left atrium and it will go to left ventricle, and from the left ventricle the aorta takes the blood to systemic circulation. When we are taking inspiration, what will happen to the blood flow to the right atrium? Will it increase or will it decrease? When we are taking an inspiration, right atrium will get more blood or less blood? Mechanically, at the start of inspiration, what is happening inside the thorax? Do we have a positive intrathoracic pressure or negative intrathoracic pressure? When we start an inspiration, it begins by negative intrathoracic pressure, right? The diaphragm is going down. As the diaphragm descends, the pressure inside the thorax becomes negative, and because of that the lung gets stretched out to the thoracic wall and the air enters into our respiratory system. So we are creating a negative intrathoracic pressure. As lungs start getting filled, the negative intrathoracic pressure starts reducing. But to start with, during the inspiration, as the inspiration begins, we have solid negative intrathoracic pressure. When we have negative intrathoracic pressure, what will happen to the flow of blood to the right atrium? Will it reduce or will it increase? It will increase, right? It's like inferior vena cava is coming to the heart, superior vena cava is coming to the heart. Once the thorax gets negative pressure, the blood will get sucked into it, right? So it will get sucked into the thorax, and where will the blood flow? Right atrium. So inspiration increases venous return to right atrium. right? Now, if more blood comes to right atrium, and what is a valve that is between right atrium and right ventricle? It is tricuspid valve, right? If more blood comes to right atrium, the blood flow across this valve will increase or decrease? It will increase. So if there is a tricuspid stenosis, it is subjected to more turbulence because more flow across the valve. So the murmur of tricuspid stenosis is going to get increased, intensified because of the increased flow. So inspiration will increase the murmur of tricuspid stenosis. Okay, now the blood has reached right ventricle, right? From right ventricle, where it will go? It will go to pulmonary artery. So this pulmonic valve, because RA got more blood, where will that blood go? If there is no problem with the tricuspid valve, the RV will get more blood. If RV got more blood, when RV is in systole, giving the blood to pulmonary artery, if the pulmonic valve is stenosed, then again extra turbulence created, so the pulmonary stenosis murmur will get accentuated. Now think of the other two scenarios. If there is tricuspid regurgitation, RA got more blood, no tricuspid stenosis, so all of that blood easily went to RV. When RV starts contracting, tricuspid stenosis means what? When RV is in contraction, blood is naturally supposed to go to pulmonary artery only, but because this tricuspid valve did not close, blood will go to RA also. Two places the blood is going now, right? And because RV had got more blood than usual, there will be more flow to both directions. So flow across the tricuspid valve also increased during the RV systole. So tricuspid regurgitation murmur gets accentuated, right? Similarly, if there is no tricuspid stenosis, no tricuspid regurgitation, RA got more blood, so RV got more blood, no pulmonic stenosis, so all more blood went into pulmonary artery. But there is pulmonary regurgitation, right? Then what will happen? This more blood will drop back to RV during the right ventricular diastole. The pulmonary valve was supposed to be closed, it did not close, and because we had given extra blood, all that extra is also coming. So the flow across the pulmonic valve during regurgitation also increased. So that means whenever we take inspiration, right, because of this increased venous return to the right side of the heart, all right-sided murmurs and sounds gets accentuated, right? So remember this one statement. During inspiration, all right-sided sounds, whether it is tricuspid stenosis, whether it is tricuspid regurgitation, whether it is pulmonic stenosis or pulmonic regurgitation, sounds get accentuated. There is one exception you need to remember, except pulmonic ejection click or ejection sound. Pulmonary ejection click or ejection sound. Yeah, we will be providing an annotated PDF. Okay, so that is one important statement. So whenever you read these kind of questions, right, sometimes the question may be like, this is a patient whom we heard this kind of a murmur, and on inspiration, the murmur increased in intensity. So then you are not thinking of any left-sided pathology. It cannot be mitral stenosis, it cannot be mitral regurgitation, it cannot be aortic stenosis, it cannot be aortic regurgitation. Right-sided murmurs and sounds increase in intensity on inspiration. Only exception is pulmonary ejection sound. Okay, the vice versa is true. The left-sided sounds increase in intensity during expiration. Why is it? Simple reason is, now during inspiration, right atrium got more blood, right ventricle got more blood, pulmonary artery also got more blood. Now where this more blood is going, it will go to lungs. It should come to pulmonic veins, right? Then that means that left atrium should get more blood, left ventricle should get more blood. But then why the left-sided murmurs are not getting increased during inspiration? Simple reason is, during inspiration, the capacitance of the blood vessels in the lungs increases. So more blood is held in the lungs. During inspiration, it is retained there because it has to get oxygenated. That extra blood that came, you asked the patient to take an inspiration, right? You created extra flow to the right side of the heart. It will go till lungs, but it will get held up there, and all that extra will return to the left side of the heart during expiration. That is why the left-sided sounds are better appreciated in the expiration, right? So we are making one more dictum now, right? Expiration, left-sided murmurs increase. Okay, I hope this point is clear. Expiration, left-sided murmur increases. Now it is very easy, right? When you're auscultating for the aortic stenosis or aortic regurgitation, normal description is breath held in expiration. Why? Because we appreciate it better. When you're auscultating for the right-sided sounds, tricuspid stenosis, regurgitation, pulmonic stenosis, regurgitation, you auscultate during inspiration, right? Left-sided mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation, you ask the patient to hold the breath in inspiration. Position changes depending on which valve, right? If it is mitral valve, left lateral decubitus, so that the valve is much closer to the auscultating stethoscope. If it is aortic valve, patient bending forward, so that the valve is much closer to auscultating stethoscope. Position differs, but breath left-sided held in expiration. Okay, clear? Now coming back to the other maneuvers. Okay. Inspiration, expiration, I hope it is clear. Right-sided pathologies increase in inspiration except pulmonary ejection sound. Left-sided pathologies increase during expiration. Okay. Now coming to standing. Right? You place the stent on the patient's chest and ask him to stand. What is the major change that is happening once he stands? Left side, there are no major exceptions. So when you ask him to stand, what will happen? What happens to the venous return when you ask the person to stand? Now I'm sitting. If I suddenly stand, the blood will get pooled into my lower extremities, right? The venous return to the heart will get reduced, right? That leads to decreased venous return if I stand. Okay. Now, similarly, if we do Valsalva, right? When we do Valsalva, what are we doing in Valsalva? We are trying to exhale against a closed glottis. So during this process, what is happening to the intrathoracic pressure? Close your mouth, close your nose and try to exhale the air. You're building up a lot of pressure inside the thorax, right? So Valsalva is associated with increased intrathoracic pressure, exactly opposite of what was happening during inspiration. So when intrathoracic pressure increases, it will obliterate the flow of blood through the inferior vena cava and superior vena cava into the heart. So indirectly, it is also causing decrease in the venous return. So Valsalva and standing should have similar effect on the murmurs. Right? What effect it is? Whenever you stand or whenever you do Valsalva, right? What will happen whenever you stand or do Valsalva? Standing or Valsalva. Heart, right atrium, right ventricle, left atrium, left ventricle, right? So when you stand, the flow to the right atrium, right ventricle is getting reduced. So that means your right atrium is getting less blood. When right atrium got less blood, right ventricle gets less blood, right? When right ventricle got less blood, the blood going to pulmonary artery also decreases, right? Now we are not talking about the relations of inspiration and expiration, the impact of this standing. So if the pulmonary artery got less blood, lungs get less blood. If lungs got less blood, left atrium got less blood. Yeah, that less blood will reach left atrium during the expiration. That's fine. We are not here trying to see what happens during inspiration, expiration. This act we are seeing. Left atrium got less blood because whatever came to the lung is only that is going to come to the left atrium. If left atrium got less blood, left ventricle got less blood. If left ventricle got less blood, then the aorta is also going to get less blood. So whenever you do these maneuvers, Valsalva and standing, there is decreased venous return, which leads to decreased flow across all valves. All valves. So what do we expect this to do? मोहम्मद कोशिश करता हूँ. Yeah, so when flow across all valves is decreased, what do we expect? Flow less, murmur less. Murmur is because of the turbulence. Jada flow, jada murmur. So am I right if I make a statement that standing in Valsalva decrease all murmurs, regardless of right or left, stenosis or regurgitation, they decrease all murmurs, but there are exceptions. Except two exceptions I want you to remember. Number one is HOCM and the number two is mitral valve prolapse. These are the two exceptions where the murmur actually increases. Okay, why it increases here? We call that these two have what is called as dynamic obstruction. Okay, I'll give you an example, but right now just register. When you ask the patient to stand or when you ask him to do Valsalva maneuver, all murmurs, aortic stenosis, aortic regurgitation, mitral stenosis, mitral regurgitation, tricuspid stenosis, tricuspid regurgitation, pulmonary stenosis, pulmonary regurgitation, all of these murmurs, you expect them to decrease because the flow across all valves is getting reduced. But HOCM and MVP are exceptions. You have to remember these as an exception for all these dictums that we are discussing. Okay, I'll give you an example of HOCM. What happens in HOCM? Okay, HOCM is called as hypertrophic obstructive cardiomyopathy. You also hear a term called as HCM, hypertrophic cardiomyopathy. This HOCM is a subset of hypertrophic cardiomyopathy. It's a variant where there is, like when you look at the left ventricle, no, this is my left ventricle that I'm drawing. This is the left atrium, right? Between the left atrium and left ventricle, we have the mitral valve. And the left ventricle leads to aorta, and here we have the aortic valve, right? Left ventricle has a good muscle mass. This portion where the left ventricle is culminating into aorta is called as left ventricular outflow tract, LVOT, right? This portion where the left ventricle culminates into aorta, we call it as left ventricular outflow tract. Now, what happens in hypertrophic obstructive cardiomyopathy is there is asymmetric septal hypertrophy. In hypertrophic obstructive cardiomyopathy, there is asymmetric septal hypertrophy. So, there is hypertrophy of the left ventricle, but the septum is asymmetrically hypertrophied and it is protruding into the left ventricular outflow tract. Whole muscle mass is increased, but it is little more increased towards this end of the left ventricle where it is beginning to evolve into aorta. Now, because of this protrusion into the flow of blood is what is acting as the obstruction. Okay. Now, when the flow to the left ventricle increases, this obstruction will increase or decrease. If I fill more left ventricle, if I fill more, this obstruction will increase or decrease. See, if the LV is filled more, the LV gets stretched. It gets stretched in this direction and this direction because it is more full. And because of that, this even obstruction gets stretched out. So obstruction is reduced by filling the left ventricle more. So the obstruction is reduced, turbulence reduced, murmur reduces. If the LV is less filled, like it is in a collapsed state, right? It is opposing to each other because it has less amount of blood. That means even the outflow tract gets approached to each other. So obstruction becomes much more increased. So when obstruction is increased, turbulence more, murmur more, right? You're getting the point? That's the main difference. So here, as you fill the LV more, LV gets more dilated and this outflow tract also gets widened. So obstruction is less. If the LV is less filled, outflow tract gets more approximated and it gets more narrowed and obstruction increases. That's why the HOCM is an exception. We can discuss similar about mitral valve prolapse in a later class, but now I hope you got the gist of it. So what happens here is these two have dynamic obstruction. The obstruction can be reduced by filling more and increased by filling less, right? So that is why these two are exceptions. Okay, now coming to what happens with these maneuvers. Squatting, right, and passive leg raising. When you ask someone to sit down and squat, what are we doing to the venous return? Are we increasing it or decreasing? Squatting means we are squeezing the calf veins, right? So whatever blood that was pooled into the lower limb is now squeezed into the central circulation. So squatting will increase the venous return. Okay. Now what do I mean by passive leg raising? Make someone lie down, right? And don't ask him to raise the leg. When he is raising the leg, he is contracting his rectus abdominis also. So he is increasing intra-abdominal pressure and he is obstructing the venous return from the lower limb to the heart. But when we do it passively, patient is relaxed, we lift his leg. So we are causing the gravitational emptying of all the blood that is there in his lower limbs into central circulation. So passive leg raising also increases venous return, right? So any maneuver that reduces the flow of blood to the across all valves will increase the murmur, right? Will decrease the murmur. Any maneuver which increases the venous return will increase the flow of blood to across all the valves, and that will increase the murmur, right? Okay, so the next dictum is about squatting and passive leg raising. Squatting and passive leg raising, both of them will increase the venous return, and thus the dictum is all murmurs increase in intensity. What are the exceptions here we are talking about? The same exceptions, right? Except HOCM and mitral valve prolapse. These are exceptions because these are having dynamic obstruction. As I've already told you, if you fill the LV more, the obstruction get relieved in case of HOCM. So the murmur will come down in intensity, right? Clear? So if this is clear, we are going back to the question now. I think hopefully we will be able to answer. On standing, the murmur increases in which of the following condition, right? On standing, what are we doing? Decreasing the venous return. We are decreasing the venous return. So what is our expectation on standing? Most of the murmurs are going to decrease because we are decreasing the venous return. So just your eye should look for the exception, right? VSD is what? Ventricular septal defect, the communication between right and left ventricle, right? So if the right atrium got less blood, right ventricle got less blood, right ventricle to left ventricle flow will be less. If there is a defect, eventually pulmonary artery got less blood, left atrium got less blood, left ventricle got less blood, left ventricle to right ventricle flow will also be less. So VSD murmur will decrease on standing. Mitral regurgitation, going by the dictum, should decrease on standing. Mitral stenosis should decrease on standing. So what is our exception? HOCM. In place of HOCM, if I place mitral valve prolapse, that will also decrease on like that will also be one of the murmur which will increase on standing, right? These are the two exceptions. Okay, cool. HOCM and MVP. Cool. Okay, I want you to remember one last dictum, right? We have learned these as dictums and you can apply for all these kind of clinical questions. One last dictum is not related to dynamic auscultation, but still a very important point. All named murmurs are diastolic. Okay, so if there is a name attached to a murmur, it is diastolic. Sometimes you get these questions, right? Which of the following is a diastolic murmur, or which of the following is not a systolic murmur? So if there is a name of a scientist attached to a murmur, it is diastolic. Right? Gary Coombs murmur, Austin Flint murmur. There is the thing called as Docke's murmur. All of them are diastolic murmurs. There's only one exception to it, and which is very easy to identify. That is your Gallaverdin phenomenon. Gallaverdin is a name attached, but again we don't use the term murmur there, right? If there is a name, it is followed by murmur, it is diastolic. Gallaverdin phenomenon is murmur, but we call it as phenomenon, which is the systolic one. Everything else, there is a name followed by a murmur, it is all diastolic, right? Okay, now let's move to the next question. Okay, the reduction in FEV1 by FVC of pulmonary function test is characteristic of which disease? Very straightforward. I would rather call this as a physiology question than medicine, and you should be able to answer this easily. Reduction in FEV1 by FVC of pulmonary function test is characteristic of which disease? Right. Okay. Okay, so just a quick approach. See, whenever you have a patient presenting with respiratory complaints, if it is not an acute infection kind of scenario, right, if it is a chronic condition, mostly PFT comes into picture, and it's very much important for us to make a diagnosis of the respiratory disorder. And broadly, we classify the respiratory disorders into obstructive and restrictive lung diseases, right? And FEV1 by FVC is a very important parameter. So FEV1 by FVC, that is the first point we will look at when we see the PFT. Okay, whether it is, what is the normal FEV1 by FVC? What is the normal FEV1 by FVC? Should be more than 70% or 0.7, whether you are expressing in decimals or whether you are expressing it in terms of percentage. Right? FEV1 by FVC should be more than 70% or 0.7. I am following a decimal method, but you can also write 70%. It could be either more than 70% or less than 70%. Okay. If it is more than 70%, possibilities are it could be normal or it could be a Obstructive or restrictive? It could be a restrictive lung disease. It could be a restrictive lung disease, or it could be normal. The patient may not have a respiratory disease at all. Okay. And when it is less than 0.7, we would consider it as obstructive. We will consider it as obstructive, right? Now, whenever you have an obstructive disease, two most important differential diagnoses for an obstructive lung disease for adults. In pediatrics, you have so many other things, but for adults are COPD and bronchial asthma, right? Restrictive lung disease, you can have a intraparenchymal restrictive lung disease, or you can have a extraparenchymal. In the sense, restriction is something is restricting the respiratory movements, right? Intraparenchymal, typical classical example is an interstitial lung disease, ILD. Lung itself is getting affected, right? And the extra lung is your thoracic wall, like you have a GB syndrome and respiratory muscles are paralyzed. That is also a restrictive lung disease, right? That is also affecting the restriction. Those two are possible. In case of the obstructive, main differential diagnosis mainly for an adult is COPD and bronchial asthma. Now, how do we differentiate between these two? COPD and bronchial asthma, how do we differentiate between these two? First is a patient came with a long-standing respiratory complaints. We did the PFT, we looked at FEV1 by FVC. If it was less than 0.7, we considered obstructive, right? And why FEV1 is more affected in case of obstructive lung disease? Why FEV1 is more affected in case of obstructive lung disease? See, in case of obstructive lung disease, you call it COPD, you call it bronchial asthma. Expiration is more affected than inspiration. Can anybody tell me why? Okay, simple reason is, inspiration is an active process. That when you're starting inspiration, your diaphragm is going down, your intercostal muscles are coming into picture. You are actively creating a negative interthoracic pressure and sucking the air inside. Is expiration an active process? No, expiration is a passive process. Whatever descended, whatever expanded, they're all collapsing back. Lung is collapsing back, diaphragm is returning it to its position, intercostal muscles are returning to its position. So it is passive recoil of the lungs, and the other structures is responsible for expiration. So when there is obstruction to airway, like say example of asthma, when the airways are getting narrow, because inspiration is an active process, you will be able to somehow overcome this obstruction and still get enough of air inside your lungs. But because the expiration is not very active, it is just passively happening, this obstruction becomes a limiting factor. What is FEV1? Forced expiratory volume in 1 second, right? Because it's a passive process, you will not be able to overcome this obstruction, and you will rather retain more gas into your lung and expire less. That is why FEV1 is more affected in case of obstruction, and that is why we use this ratio for the diagnosis of obstructive versus restrictive, right? Now these two are our differential diagnosis. How will we differentiate between these two? Both have obstruction, but bronchial asthma has dynamic obstruction or reversible obstruction. COPD is partially irreversible obstruction. So we have to prove that this patient either has or doesn't have reversible obstruction. How do we prove that? We prove that by doing something called as bronchodilator reversibility test. Bronchodilator reversibility test. So when in doubt between COPD and bronchial asthma, we do this bronchodilator reversibility test. What do we do here? We either give them a short-acting beta agonist inhalation or give them steroids for a few days of duration. Most commonly, we give a short-acting beta agonist is given. After that, if it is bronchial asthma, we will expect that his FEV1 improves. If it is COPD, it will not greatly improve. So if FEV1 after the bronchodilator reversibility test increases by more than 12%, it is significant. That means it is bronchial asthma. If FEV1, it can increase in COPD also, right? But it will not be this dramatic. Increase is less than 12%, then you will consider it as COPD. Okay, then we will consider it as COPD. The reason I'm emphasizing on this is because you will get clinical questions where like this is a patient who presented with wheeze, shortness of breath from 6 months, 1 year. They will tell that he's a smoker for some time. Okay, now his PFT is done, FEV1 by FVC is 0.7 or less than like 0.6, 0.5, whatever. and then they will tell that okay, the patient was given a short acting beta agonist. FEV1 before the administration of beta agonist was this much. FEV1 after the administration of beta agonist is this much. So what is the diagnosis? Right, so you should look for this 12% number. 12% के ऊपर है bronchial asthma, less than 12% it is COPD. Okay, now this answer is anyway straightforward. It is a obstructive lung disease. Reduction here basically means less than 0.7. 0.7 के ऊपर we consider it as normal. Okay, cool. Now moving to the next question. In which of the following condition calcitonin levels are increased? Hyperthyroidism, hypoparathyroidism, Cushing syndrome, and hyperparathyroidism. In which of these conditions the calcitonin levels are going to be increased? Yeah, let me increase the thickness of the pen. Okay, in which of the following condition calcitonin levels are increased? Hyperparathyroidism. Okay, what is the physiological role of calcitonin? It is something to do with calcium. इतना तो सबको पता है. We all know that it is something to do with calcium. What's its physiological role? Should it increase the serum calcium levels, or its job is to decrease the serum calcium levels? What is its natural role? What is the role of calcitonin? What is the role of there are two hormones we are talking about with respect to calcium, right? Parathormone and calcitonin. With respect to serum calcium, what parathormone does? Parathormone increases the serum calcium levels or decreases it? Parathormone is expected to increase the serum calcium levels, right? And calcitonin is expected to decrease. So parathormone will increase the serum calcium levels, calcitonin will decrease the serum calcium level. That is its primary roles. How do they do that? By playing with the other organs where calcium is there, right? Okay, now the question is asking in which of the following conditions calcitonin levels are increased. It is probably going to increase when the serum calcium is high and it is coming in picture to reduce it. Like serum calcium is already high, my job as a calcitonin is to come and reduce it, right? Reduction of serum calcium is the calcitonin's ultimate goal. So if the calcium is normal, why do I come into picture? Or if the calcium is low, I shouldn't be coming into picture, right? Okay, hyperthyroidism has no direct relation as of now with calcium, so let us eliminate that as an option. Cushing syndrome also do not have a strong role with respect to calcium, so right now eliminate that also. It has something to do with osteoporosis but not a strong role, so we will eliminate those two and we are left with mainly hypoparathyroidism and hyperparathyroidism. So what happens in hypoparathyroidism? Parathormone levels is low, right? So what will happen to the serum calcium? Serum calcium is already low, right? In hypoparathyroidism, PTH levels are low, so the net result of that is serum calcium is low. When serum calcium is low, what should happen to the calcitonin levels? They should be suppressed, because if the calcitonin level goes high now, the serum calcium will go further low, right? So hypoparathyroidism is expected to be associated with, this will be associated with decreased calcitonin. This will be associated with decreased calcitonin, right? What happens in hyperparathyroidism? In hyperparathyroidism, the PTH is already high, right? The PTH is high. Now this PTH will increase the serum calcium levels, right? It will clear the calcium from the bone. It will take the calcium out of bone and put it into the blood, right? It will stimulate more calcium absorption from the gut, right? So when there is hyperparathyroidism, right, it will reduce the excretion of calcium at the level of kidney. So it is putting more and more calcium into blood. So PTH increase associated with increased serum calcium levels. So when the serum calcium levels are high, beyond the normal range, what do we expect the calcitonin to do? It should increase its level so that it fights out. It tries to reduce that serum calcium levels back to normal range, right? So does it make sense to consider option D as the correct answer? In hyperparathyroidism, parathormone levels are high and also calcitonin levels will be high because the calcitonin is fighting out the parathormone levels. right? So this is basically the job of calcitonin. Calcitonin will inhibit calcium absorption in the kidney, so that more and more calcium is lost in the urine. It will promote more calcium deposition into the bone so that the serum calcium level is reduced. It will inhibit calcium absorption in the intestine so that ultimately it achieves the lowering of the calcium levels in the blood. It's doing exactly the opposite of parathormone. But if parathormone level increases, if PTH level increases, that means the blood level of calcium increases, and calcitonin has to increase and do all this to get the calcium level back to normalcy, right? So the correct answer for this is hyperparathyroidism. Hypoparathyroidism would be associated with low calcium, or in simple words you can remember, calcitonin sometimes follows parathormone. Parathormone is going low, calcium is going low, and calcitonin should get silenced, it will also go low, right? Parathormone is going high, calcium going high, right? Calcitonin should go high to get this calcium back to normalcy. So they are following, they are chasing, the calcitonin is chasing the parathormone. In whatever direction parathormone goes, calcitonin is going in that direction. Okay. Okay, I'm making it more thick. I'm making it more thick. Okay. Now let's go to the next question. A female adult visited physician with complaints of lethargy, increased sleep, and weight gain. Okay, so these are the complaints. What are the complaints? Lethargy, increased sleep, and weight gain. TSH plasma concentration was low, right? TSH is low, and there was a rise in TSH after administration of TRH. So TRH test resulted in increase in TSH levels. Following conditions which are most likely responsible for this patient's situation: hypothyroidism due to disease in hypothalamus, hypothyroidism due to disease in the pituitary, hyperthyroidism due to disease in the pituitary, hyperthyroidism due to disease in the hypothalamus. Okay. Now, patient complaints clearly tell that these symptoms are more likely to lean towards the diagnosis of hypothyroidism, right? If it is hyperthyroidism, patient would have come with irritability, tremors, palpitations, increased heart rate, restlessness, rather than lethargy and increased sleep. Insomnia would have been a problem with a patient with hyperthyroidism. So, and weight loss would have been a feature of hyperthyroidism. So from the options, first things that we can rule out is features of hyperthyroidism. This and this, C and D are out. We are left with mainly between A and B, right? Okay. Now, how the thyroid hormone is regulated? We have something called as hypothalamo pituitary thyroid axis, HPT axis. Just like how you have a HPA axis, hypothalamo pituitary adrenal axis, there is a HPT axis. So you have a hypothalamus, you have a pituitary gland, and you have a thyroid gland, right? So hypothalamus produces a hormone called as TRH, thyrotropin releasing hormone, which will positively influence the pituitary gland to produce TSH, right? TSH will positively influence the thyroid gland to produce T3 and T4, right? And now this T3 and T4 will cause negative feedback inhibition on both pituitary as well as hypothalamus. So it will inhibit TRH production and it will inhibit TSH production. In any endocrine disease, when we say that primary abnormality, we are addressing the gland. It's like if I say primary hypothyroidism, that means I am addressing the thyroid gland. The problem is in the thyroid gland. TSH production is normal, TRH production is normal, but the problem is in the thyroid gland. Primary, the word primary in any endocrine disease addresses the gland from which the hormone is supposed to come. Right? If there is a problem in the thyroid gland, I will call it as primary hypothyroidism. Can anybody give me examples for primary hypothyroidism? What diseases can be counted as primary hypothyroidism? Which diseases we can count as primary hypothyroidism? Hashimoto's, can we call it as primary hypothyroidism? Iodine deficiency, can we call it as primary hypothyroidism? Right, tropical Capricorn, right, yeah. So Hashimoto's, autoimmune injury to what? Thyroid gland, not to the pituitary. Pituitary is not affected in Hashimoto's. Hypothalamus is not affected in Hashimoto's. So Hashimoto's is a primary hypothyroidism. Iodine deficiency is affecting the thyroid hormone synthesis. Iodine is required for T3, T4 synthesis. It is not required for TSH production. It is not required for TRH production. So all of them are primary, right? Those are most common things. Hashimoto's and iodine deficiency and other forms of thyroiditis. They are all primary, right? Now the next step in the ladder, we are starting with the primary gland. Next step in the ladder is pituitary. That is where if there is a pathology in the pituitary, we will call it as secondary, right? If there is a pathology in the pituitary, we will call it as secondary. What pathology in the pituitary can be there? There can be a tumor or a pituitary apoplexy or some other tumor like prolactin producing tumor compressing the thyroid producing cells, or a growth hormone producing tumor compressing the thyroid producing cells. Any pituitary pathology, right? That can cause secondary hypothyroidism. That will reduce the TSH production. If the TSH goes low, the gland is not getting the stimulus to produce more hormone, so it will produce less and less TSH. That is secondary hypothyroidism, right? Most common cause for secondary hypothyroidism is a pituitary adenoma. Pituitary adenoma. Yeah, Sheehan also. Anything to do with pituitary. It could be a vascular insult or a tumor which is compressing the TSH producing cells. The tumor may be producing any hormone, or it may be a non-functional tumor. It is just suppressing or compressing the TSH producing cells, so TSH levels are going low. Okay. Now the problem can also be at the level of hypothalamus. If the problem is at the level of hypothalamus, we will call it as tertiary hypothyroidism. Tertiary hypothyroidism. What can go wrong at the hypothalamus? There can be a large suprasellar tumor which is compressing the hypothalamus. Most commonly, it is a hamartoma, hypothalamic hamartoma, or it can also be subjected to strokes and vascular insults. Okay, whatever is the cause, if the problem is at hypothalamus, it is called as tertiary. Okay, how we evaluate the patient? TRH is not routinely done, right? TRH is not routinely done. What do? We do TSH and most likely free T4 level. That's more than enough for us. TSH and free T4 levels. Free T4 low and TSH low. What are the possible outcomes when we have done the TSH and free T4? Right? Scenario 1, TSH free T4. Scenario 2, TSH free T4. Scenario 3. Okay, if the TSH is increased, free T4 is low. TSH is increased, free T4 is increased. TSH is low, free T4 is low. These are the possibilities, right? When TSH is increased and free T4 is low, what do you think it is? What do you think it is? Like, look at this ladder. This has gone low. When T3, T4 goes low, what is our expectation from the pituitary gland? We want the TSH to go high, right? So that it stimulates the thyroid gland to produce more and more hormone. It means that if the TSH is high, pituitary has no problem. We don't even need to think about hypothalamus. Pituitary has no problem. If TSH is gone high, it is an appropriate response. So it is basically the thyroid gland which is not able to produce adequate hormone. T3, T4 is low. TSH is appropriately high. So it is primary hypothyroidism, right? So when you have a TSH which is high and a free T4 which is low, it is primary hypothyroidism. Primary hypothyroidism. Clear? Now the other scenario is TSH is high, free T4 is also high. What do you think it is likely to be the reason? TSH also high, free T4 also high. Okay. So that means that when T3, T4 goes high, what is our natural expectation? It should cause a feedback inhibition of TSH and TSH should go low. Right? That is also a possibility. That's also a possibility where your TSH is low and free T4 is high. It basically means that increased T4 inhibited the TSH. So the problem is in the thyroid gland which is producing more. So this is primary hyperthyroidism. Primary hyperthyroidism. The problem is in the thyroid gland itself. It is producing more, and as a result the TSH is suppressed. More T3, T4, feedback suppression of TSH. Okay, but what is this? TSH high, free T4 high. TSH high, right sip of medicine. So it basically points towards the pituitary gland. Pituitary gland itself is producing very high amount of TSH, and this high amount of TSH is stimulating the thyroid gland to produce high amount of T3, T4. Clear? So when you have this scenario where both have gone high, this is basically secondary. Free T4 is high, so hypothyroidism or hyperthyroidism. This is secondary hyperthyroidism. Secondary hyperthyroidism. So we have the scenario of primary hyperthyroidism, secondary hyperthyroidism. We have a scenario of primary hypothyroidism. Okay, now coming to this scenario number 3. TSH is low, free T4 is low. Okay, so that means from the pituitary adequate amount of TSH is not coming. That's why TSH is low, and because TSH is low, the thyroid gland is not producing adequate T3, T4, so that is also going low. But there is a possibility that this low TSH may be because of the low TRH production. कि pituitary को ही sufficient stimulus नहीं है hypothalamus से. TRH has gone down, that is why the TSH has gone down, that is why T3, T4 has gone down. A possibility. Another possibility is TRH production may be normal, but pituitary is not listening to the hypothalamus. It is unable to respond to the TRH stimulation. T3, T4 has gone low. It is trying to, this low T3, T4 is stimulating TRH production and TSH production. So TRH has gone high, but this high TRH is failing to stimulate the pituitary gland because it has a problem. That's also a possibility, right? So this scenario, there are two possibilities. Either you have a secondary hypothyroidism or a tertiary hypothyroidism. Now, how do we differentiate between these two? In this scenario, we will do what is called as TRH administration test. So we will give TRH. We did the TSH, which is low. Free T4 is also low. Hypothyroidism is guaranteed because it is free T4. TSH is low. Now I want to know whether this TSH is low because of the primary problem in the pituitary gland or it is in the hypothalamus. So I administer TRH. After TRH is given, if the TSH level increase, will you call it as pituitary cause or hypothalamic cause? After I gave the TRH to the patient, right? Patient's pituitary started producing more TSH. What does it mean? Pituitary is capable of producing TSH. It is not damaged. Because it was not getting adequate TRH, it was not producing adequate TSH. Right? That is the interpretation. If after giving TRH, TSH goes up, that means pituitary is capable. But it was not producing TSH because it was not being stimulated. But if after giving TRH, I gave TRH, after giving TRH, the TSH doesn't go up, it still remains low. That means that pituitary is the site where there is a problem. No matter how much TRH I will give externally or internally, naturally, pituitary will not respond. Right? That means you have a problem at the level of pituitary. Right? I hope the things are clear. Now going back to this question. In this patient, TSH was low and the TSH increased after administration of TRH. So what is the interpretation? We have two options: hypothyroidism due to the disease in the hypothalamus or hypothyroidism due to disease in the pituitary. What is the interpretation? We gave TRH and the TSH increased. That means the pituitary is not the problem. It is capable of producing the TSH, but it was not getting adequate TRH to get stimulated. So the problem was in the hypothalamus. When we give externally TRH, pituitary responded well, right? So the correct answer is option A. Hypothyroidism due to disease in the hypothalamus. That's the right answer for this question. Okay. So this is basically a case of tertiary hypothyroidism. Tertiary hypothyroidism. Okay. Now before we move to the next question, few important practical points for which can be asked as MCQs and also practically relevant. If you have diagnosed a case as hypothyroidism, what is the most common cause for hypothyroidism? Is it primary, secondary or tertiary? Hypothyroidism most commonly is primary, secondary or tertiary? Most commonly it is Primary thyroid gland is the one which is mostly getting affected. Pituitary causes or hypothalamic causes are extremely rare. Okay. And when I say most common, it is primary. The cause for the primary hypothyroidism, what is the most common cause? We have to understand two set of populations. There are two sets of population. One is in iodine sufficient areas and in iodine deficient areas. Iodine sufficient areas and iodine deficient areas. So what is the most common cause in iodine sufficient areas and what is the most common cause in iodine deficient areas? See, the hilly regions and all where iodine deficiency is there, obviously iodine deficiency is going to be the most common cause. Okay, but in places where the soil is repleted with iodine, what is the most common cause? What is the most common cause in iodine sufficient areas? Okay, the most common cause in iodine sufficient areas is Hashimoto's thyroiditis. Hashimoto's is the most common cause in iodine sufficient areas. Now comes the controversial point. What is the most common cause overall? What's the most common cause for hypothyroidism overall? Okay, my suggestion is to go with Hashimoto's or autoimmune thyroiditis as the answer even overall. The reason for that is even in iodine deficient areas, even in the backward countries, salt is iodized. It has become part and parcel of the national program. Salt is iodized and the iodine deficiency as a contributor is declining. So you see most of the hypothyroid patients that in your clinical practice are going to be Hashimoto's. Right? If the question is specific iodine deficient areas or iodine sufficient areas, you know what to answer. If they ask overall, I would suggest to go with Hashimoto's. Okay, that is one point. Then the second point is the treatment. What can they ask? We are replacing thyroid hormone. Right, whatever is the cause, ultimately we are replacing thyroid hormone. Even if it is secondary, like there is a pituitary tumor, we will operate, but till that we are going to give thyroid hormone. Hypothalamic problem, we will still give the thyroid hormone. So replacement, right? We use levothyroxine. Question that can be asked is the dose, or sometimes you get clinical questions. Okay, this is a patient started on this medication, comes back for follow-up, and still we have not achieved the improvement or result we wanted. How do you manage further? Those kind of questions, right? So levothyroxine. Now, can anybody tell me what dose you would start with? What dose you will start with? Is it based on patient's severity of symptoms or based on something else? What is the parameter? Like, see, you might have seen patients using L-troxin or Thyronorm 75, 82.5, 100, 125, 112.5, 150, up to 200 micrograms per day, right? So what is the deciding factor? At least the starting point, what is the dose that you decide? Is it based on like severity? Patient ka TSH is, let me say, 20, 50, 100. Based on that you will decide, or based on something else? Right, it is based on patient's weight. It is based on patient's weight. Approximately we start at 1.6 micrograms per kg body weight. We start with 1.6 micrograms per kg body weight. In the clinical practice, I roughly remember 1.5 because it is easy. Like a 50 kg person, 1.5 into 50 is 75. 75 dose tablet is available. I'll prescribe that. Right? So roughly remember 1.5 or 1.6 is what precisely you need to answer. Once I start, right, what is my goal? What is my goal? Target is to keep the TSH in middle third of the normal range. Middle third of normal range. So most labs will have a TSH normal range between 1 to 5. 1 to 5 as, or something like 1 to 5.5 or 1.5 to 5.56. That is their normal TSH range. So what is the middle third of that range is what we were trying to keep the TSH. When do we ask them to come back for follow-up? 4 to 6 weeks. They come back for a follow-up. At the end of 4 to 6 weeks, we want to see the TSH in the middle 1/3 of the normal range. Okay, if we are not reached the middle 1/3 of the normal range, then we have to, if TSH more than target, that means we still need to increase the medication, right? So remember, increments in 12.5 to 25 micrograms per day, right? Like I had started with 75, he has come back at the end of 4 to 6 weeks, he has got a TSH done, and it is still not in the target range. It is like 8 9. My target range is to keep between 3 to 5. I'm just giving you hypothetical number. Then I will increase by 12.5 to 25, not more than that. I started with 75, I can go to 82.5 or 87.5, or I can go to 100, not 125, right? This cycle will continue till you achieve the control. That's how we manage. So there is nothing random in treating a hypothyroidism, it is all methodical. Now one point is, I have a patient who is 75 years old, he is 50 kg. How much thyroid hormone I should start? Age of the patient is 75 years, weight is 50 kgs. How much I should start? Yeah, 6 weeks. 4 to 6 weeks. 6 weeks is the sweet number, that's the right number. Because to get a clear picture of impact of whatever dose you started, it takes 6 weeks. How much you would start? 50 kg, 75-year-old. Will you start 75 micrograms, 100 micrograms, or something different? Right. So in elderly individuals, they do not tolerate the thyroid hormone replacement well. They become at risk of the arrhythmias, especially atrial fibrillation induced by this thyroid hormone, and their vasculature also doesn't favor it. So please remember, in elderly, this is one question that appeared in NEET SS recently. In elderly, start with 25 micrograms. Because they do not tolerate well, we are not giving them 75, they don't tolerate it well. They may require 75, but we go slow. We start 25, 4 to 6 weeks they come back for follow-up, not achieve the target, I'll increase by 12.5, I'll go to 37.5. I'll take some time to get them adjusted, because they are at increased risk of thyroid hormone induced arrhythmias and ischemic events. So better to start at lower dose for elderly. So this is a point that appeared in recent NEET SS question, and it can appear for NEET PG also. So please remember this. Okay, clear? Okay, now let's move to the next question. Okay, yes. In pregnancy, that's a good point. So in pregnancy, the thyroid hormone requirement increases, and in pregnancy we have a stringent TSH target. Here I gave you a rough number, right? Middle 1/3 of the normal range is our aim. That's like, even if you're in the normal range, it is acceptable. But why we are keeping in the middle 1/3 is, suppose like for 2-3 days patient skips the dose, or he goes through an intercurrent illness where the thyroid hormone requirement may be more, because it is in the middle 1/3, still it will remain in the normal range, it will not get offshot. That's why we are trying to keep it in the normal range. But what is the TSH target recommended for the pregnant women? Yeah, that's a very important point, and that's a solid MCQ point. TSH target for, yeah, for MBBS synapse for young individuals like 18-year and all, you can manage according to this weight thing only. TSH target for pregnancy. What is the TSH that you need to keep for pregnancy target? For a better pregnancy outcome, the TSH target for pregnancy is less than 2.5 international units. Right? The TSH target is less than 2.5 during pregnancy, and the thyroid hormone requirements increase during pregnancy. So whatever the dose that was required for control of their hypothyroidism prior to pregnancy, what we generally do is we increase it by 50%. Got the point? Now Prince Care or Rishi, in pregnancy 10 and all is absolutely unacceptable. We want it below 2.5. Again, in OBG you may get little bit of trimester specific recommendations, but for your exam just remember 2.5. If it is more than 2.5, it is associated with adverse pregnancy and fetal outcome, right? So for pregnancy, TSH target is less than 2.5, and On confirmation of pregnancy, increase the dose by 50%. Right? If the patient was already taking 50 micrograms, I will be increasing it by 25 micrograms on confirmation of pregnancy. And then I will follow up with the TSH during the pregnancy, and we will make sure that the TSH is less than 2.5. If it is more than 2.5, I'll increase the dose. Right? That's how we manage the hypothyroidism in pregnancy. This is very, very important because it decides the pregnancy outcome. Okay. Right. Yeah, that's right. Good point. Okay. Let's move to the next question now. Okay, a patient with mild ascites came to hospital. On examination and further investigation, he has no encephalopathy. Okay, no encephalopathy is there. And found serum bilirubin to be 2.5 milligrams per deciliter. Serum albumin is 3 grams per deciliter, and prothrombin time is 5 seconds. It's not exactly how the question would have appeared in the NEET PG. Whoever is recalled, it is probably 5 seconds over and above the baseline value. And anyway, they have given INR, which is elevated. INR is 2. So as per the Child-Pugh score class, which class this patient belongs to? Okay, I think we have discussed some questions based on this in the yesterday session also, and this should be pretty easy, right? So Child-Pugh score has 5 important parameters. What are those? Encephalopathy. Encephalopathy, we need to know the grade. I have told you yesterday also what is the grading system that is followed for encephalopathy, and you should be able to at least remember the name, right? So I am again reiterating, or can anybody tell me what is the name of the grading criteria used for grading the encephalopathy in hepatic disease patients? Dopamine, somewhere in the middle of the March, we are expecting to launch. Recordings are going on. Yeah, encephalopathy, what is the name of the grading system? Because here we are telling, no, grade 1 or grade 2, 2 points. Grade 3 or grade 4, we are giving 3 points. So what is the name of that grading system? Right, awesome. West Haven criteria. West Haven criteria for grading the encephalopathy. That is first parameter, right? Second parameter is ascites, whether it is diuretic responsive or diuretic refractory. Okay. Then the third parameter is serum bilirubin levels, less than 2, 2 to 3, more than 3. Next is albumin, 3.5 plus, that is normal. 2.8 to 3.5, less than 2.8. And the last one is prothrombin time. Either we are looking at elevations above the baseline, how many seconds above the normal or the baseline, or we are looking at INR. I always find comfort in looking at INR because I don't know the baseline. I don't know the laboratory cutoffs at many labs. So INR is like standardized. So look at INR is what I do. Okay. Now let us look at this patient. He has mild ascites. They have mentioned it as mild. Whether diuretic responsive or refractory, we don't need to bother because they themselves have called it as mild. Sometimes in a CTP related question, they will tell that there is ascites. Patient is on optimal dose of diuretics, but still ascites persist. They are basically trying to point towards severe ascites, diuretic refractory ascites. So we need to keep attention to that. So in that case, we will be assigning 3 points to the patient, right? So let us make a list. Ascites is present and it is mild. So how much points we will be giving? 2 points. We have 2 points already. They have mentioned that there is no encephalopathy, right? No encephalopathy. So for the encephalopathy, I am giving the 0 points. Now coming to bilirubin. How much is it? 2.5. So I'll be giving 2 points because 2.5 falls in this category, 2 to 3, right? 2 points. For bilirubin. Albumin is how much? Albumin is 3. If I am not mistaken. Yeah, 3. So again, it is also in the mid range, 2.8 to 3.5. Another 2 points for albumin. Everything is falling into 2. 2, 2, 2. So far we have 6 points. And the prothrombin INR was 2, right? If you remember, or 5 seconds above the baseline prothrombin time. INR 2 means it also falls here. So another 2 points. So what is the total points we have? 8. 8 points. How do we classify it? 5 to 6 is A, class A. 7 to 9 is class B, and 10 to 15 is class C. So how many points we have here? We have 8. So it belongs to class B. It belongs to class B. So that would be our correct answer. Option C is the right answer. This belongs to class B. Okay. Should we remember this table? The answer is, when you ask me as a doctor, I would say no, because we're not following it that diligently. MELD score is what we routinely put into practice. But somehow these NEET PG people are very much fond of the CTP score. So I would recommend, for the sake of exam, remember this. And when I've seen the questions, right, last 7-8 years, whatever CTP related questions where you had to score, remember most of the values now, they fall in this 2-point score only. Like this question, everything is put for the 2-point score. So sometimes we can quickly get 2 and get the score. Okay, but please try to remember this. This is worthwhile spending 10 minutes of time trying to memorize this. Okay, now moving to next question. A woman in her old age was brought to the OPD with complaints of forgetfulness and behavioral change. History of multiple falls and urinary incontinence was also present in the patient. Most likely diagnosis is. Okay, what information we have? In her old age. So basically means that we are talking about a geriatric age group. So mostly patient is 65 years plus. Whenever these questions talk about old age, at least we can assume that the age is more than 65 years. Now, what are her complaints when she was brought to the hospital? Forgetfulness. And there is change in the behavior. There is history of multiple falls and urinary incontinence. What is the most likely diagnosis? Options are Creutzfeldt-Jakob disease, frontotemporal dementia, Parkinson's disease, and normal pressure hydrocephalus. Interesting question. Oh yeah, okay. Yeah, you can add one point to encephalopathy. I ignored that. Yeah, even then we are in class B, right? We still have a 9 points, right? We still have a 9 points, and in that case, yeah, in that case, still it is class B. Joseph, right? So where do we see that the triad of dementia, gait unsteadiness, and urinary incontinence? Let us dissect one by one. When you have a patient with Creutzfeldt-Jakob disease, what is the most important clue that examiner wants to give you? Okay, first point. Can we have forgetfulness in Creutzfeldt-Jakob disease? Can we have forgetfulness in Creutzfeldt-Jakob disease? Can we have forgetfulness in Creutzfeldt-Jakob disease? The answer is yes, because it is also a neurodegenerative disease where it can affect the cognition. So patient can have forgetfulness. Can we have behavioral change? Very much. We can have behavioral change in Creutzfeldt-Jakob disease. Okay, so those two things are possible. Okay, do these patients have multiple falls? Probably not. Do these patients have urinary incontinence? Probably not. Plus, one important clue in the question is missing. If examiner wants you to think of Creutzfeldt-Jakob disease, he mentions this clue almost always. So what is the clue I'm talking about? Yeah, what is the clue I'm talking about? Like typically, if the examiner wants you to think that this is a case of CJD, then he will tell that this patient has behavioral change, dementic features, plus this is there. What is that? Okay, so remember, more than 90% patients of CJD have myoclonus. More than 90% of patients with CJD have myoclonus. So if I want to make you think that this is a case of CJD, I would make sure that I write this point in the question. Okay, so I wouldn't now be considering CJD as an option because multiple falls are unlikely. The gait unsteadiness is not feature of CJD. Urinary incontinence cannot also be explained from CJD, and I have not told that this patient has myoclonus. Some finding which is seen in 90% plus patients, I should definitely mention it, right? It is also not there. So I will be not considering this. Okay. Now coming to frontotemporal dementia. Okay. So what is frontotemporal dementia? Name says frontotemporal dementia. So the frontal lobe and temporal lobes are getting affected by degeneration. Okay. And how do these patients present to us? These patients present to us in three forms. The presentation differs. Three forms. What are those three forms? One is a behavioral variant of frontotemporal dementia, which is the most common variant, where patients present with apathy. Apathy means what? Not showing interest in the surroundings. They're very apathetic. See, empathy, sympathy, those are things where like you are getting involved into events and surroundings. Apathy, आप कुछ भी करो मुझे घंटा फर्क नहीं पड़ता है. That's apathetic. Then they can have disinhibition. Like for everything we have inhibition, right? Like we have a social inhibition. I cannot get up on this chair and start dancing even if inside I'm feeling like dancing, because now I know you people are watching. So I have some inhibition, social inhibition that is lost. Disinhibition, right? Loss of empathy can occur in these patients, and overeating. So basically a drastic change in their behavior, what we call as behavioral variant of frontotemporal dementia. That is the most common. This is also an MCQ point. Most common type of frontotemporal dementia is behavioral variant. Okay. Next thing is there is something called as semantic variant. They find it very difficult to decode the words and emotions. Like normally when you talk, like your two friends, the other friend is talking in a tone and the cluster of words which make you think that okay, this guy is going through something, right? We recognize it. He's not directly telling me that I'm feeling sad or I'm feeling low, but I can still interpret, right? We read between those lines. That is lost. Very difficult to diagnose this because not recognized easily. Semantic variant. Then there is also another thing called as agrammatic variant. Name says agrammatic, grammar gaya. Right? These patients have inability to produce words. But apart from these, patients with frontotemporal dementia, they are associated with one particular neurological disease. Other than that, major neurological manifestations in terms of motor features or autonomic features are not seen. Right? They are not seen. So what is the neurological manifestation that can be associated with, or what neurological disease can be associated with frontotemporal dementia? Very important MCQ point. Can be associated with which neurological disease? I'll give you a clue. There is a mutation in the gene called as ORF mutation. ORF mutation. Okay, some patients with frontotemporal dementia can develop, or it can be associated with amyotrophic lateral sclerosis. Especially the behavioral variant can be associated with amyotrophic lateral sclerosis, and these patients can have ORF gene mutation. But other than that, incontinence, autonomic symptoms, those are not expected in this patient. Okay, so can we consider that as a cause for this patient? No. No. Right? Okay. Now coming to Parkinson disease. Parkinson disease, how do you identify? What is the characteristic features of Parkinson's disease that help us to diagnose Parkinson's disease as a entity? What cluster of symptoms that you see? Okay, remember Parkinson's disease is categorized under a broad heading called as akinetic rigid syndromes. It is the most common akinetic rigid syndrome. Right? Parkinson's disease is a most common akinetic rigid syndrome. Akinetic rigid syndrome is a term used for a cluster of motor movement disorders. Parkinson's disease is one of them. The other diseases that I can list under this is multisystem atrophy, progressive supranuclear palsy, all of them. Right. So as the name says, there is reduced movement. There is bradykinesia. Right. There is rigidity. Okay. But these two things are standard across all akinetic rigid syndromes. Multisystem atrophy, progressive supranuclear palsy, all of them. Right? All of them have bradykinesia, all of them have rigidity. So how is Parkinson's disease different from all of the other things? So Parkinson's disease has bradykinesia plus rigidity The additional thing which is not seen in all of the other akinetic rigid syndromes is tremor. Tremors are an extra feature here. Clear? Okay. We are familiar with all the manifestations of bradykinesia, right? Slowness in the initiation of movements, right? Reduced facial expression. When they write small letters, right? Reduced facial expression, what do we call it as? What do we call the reduced facial expression? Their facial expressions are reduced. Like Parkinson's disease patient, we call them as mask-like faces, right? Okay. The other word is hypomimia. Okay. Then their spontaneous movements are reduced. When a patient of Parkinson's disease is walking, you will notice that their arm swing is slowed down. It is reduced. The eye blink is reduced. Those are all manifestations of bradykinesia. Okay. Rigidity in Parkinson's disease. See, rigidity is an important clue to differentiate between Parkinson's and other akinetic rigid syndrome. Let me give you an example of what is called as progressive supranuclear palsy. All of you recognize this condition, progressive supranuclear palsy, from one MRI image, that is hummingbird sign, right? You're all familiar with that. Hummingbird sign seen in progressive supranuclear palsy. But clinically, how do we distinguish between? Because progressive supranuclear palsy patients also have bradykinesia. They also have rigidity. Tremor nahi hai, but otherwise, what else it is different from Parkinson's disease? In all these movement disorders, you need to concentrate on rigidity. When you're talking about rigidity, you should know whether the rigidity is affecting distal muscles or proximal muscles more. You should know whether it is affecting the truncal muscles more or axial muscles more, or the limb muscles more. Okay. Whether it is affecting, if it is affecting the axial or truncal muscles, whether it is affecting the anterior group of muscles more or the posterior group of muscles more. Yeah, Muhammad Ali had because of the repeated trauma. Trauma can also be a cause for Parkinson. But in case of Muhammad Ali, you cannot call it as Parkinson's disease. He had Parkinsonism. Parkinson's disease is idiopathic. Right? If there is a cause secondary, then we can simply call it as Parkinsonism. He did not have idiopathic Parkinson's disease. Right. Micrographia, monotonous speech. Prince Care, yeah, you brought out a very important point. So I'll just first tell you about rigidity. So rigidity here in the Parkinson's affects both axial and extraaxial. Axial as well as extraaxial. So that means the rigidity is affecting the limb muscles also and the truncal muscles also. Okay. In case of the axial involvement or the truncal muscles, it is affecting anterior group of muscles more than the posterior. So the back muscles are less affected. Anterior muscles are more affected. So if the anterior muscles like the chest and abdominal muscles, if their rigidity means what? Hypertonia. If the tone is increased, they are more in state of contraction. What will happen to the patient of Parkinson's disease? He will bend forward or he will bend backward. He will bend forward or he will bend backward. He will bend forward, right? Because the front muscles are more contracted. They have increased tone. Back muscles don't have increased tone. So he will bend forward. That is where the problem of Parkinson's disease starts. He starts bending forward. He gets that stooped posture, that what you describe in Parkinsonism, because of the axial rigidity which is affecting the anterior group of muscles more than the posterior group. And once he starts stooping forward, his center of gravity shifts forward. So when he is walking, his center of gravity is shifted forward. When he is walking as if he is trying to catch his center of gravity. So you bend forward and start walking for some distance fast. What you will notice is that you are about to fall forward. So to escape that, you walk much more faster. That is what we typically describe as Festinian gait in Parkinson's disease. The gait is stemming not only because of the postural instability, but also because of this rigidity which is affecting the anterior group of muscles more, causing a stooped posture. Got it? Okay. Now this extraaxial affects upper limb more than lower limb, because in Parkinson's the problem starts in the upper limb first and then goes to the lower limb. So it affects upper limb more than lower limb. Okay, as someone mentioned that in lower limb you get lead pipe rigidity and in upper limb you get the cogwheel rigidity. Why? Because upper limb has predominant tremors. The lower limb can get tremors but quite late in the illness. It starts with upper limb. So you have rigidity, but the rigidity is superspersed by tremors. So when you are examining for the rigidity, these tremors are interfering in your assessment of the rigidity. So it is like, the cog wheel, right, where there are cogs and the wheel is shifting between those cogs. So that kind of a experience the examiner will get. It is not like a uniform rigidity. It is jerky rigidity that you are experiencing, because there is rigidity, but there are also tremors which are adding on to that. So that is why upper limb has typical cogwheel rigidity. Lower limb doesn't have tremors, so you have that smooth rigidity. That's why it's called lead pipe rigidity. Okay. Tremors तो आपको पता है. You know that tremors is a resting tremor. Intention it will reduce, but it is basically a resting tremor. And you should remember one more characteristic feature, something called as re-emergent tremor. Re-emergent tremor. Now what do I mean by re-emergent tremor? Re-emergent tremor. See, you all know that it is resting tremor. So I have this typical pill rolling tremors. At rest I am doing this, okay, and if I start moving, right, I need to catch something, the tremors will disappear for some time. At least in the initial stages of Parkinson's disease, it will disappear. I do the action will reduce or make the make the tremor disappear. But once the action is completed, my limbs are back to rest, right? Limbs are back to rest. They will not immediately start the tremor. As soon as I come back to the rest, they will not immediately start the tremors. There will be a pause of 4 to 5 seconds, and then the tremors will reappear. This is what we call as re-emergent tremor. So rest tremor is there, movement abolishes the tremors or reduces it, and it takes few seconds of time for the tremors to re-emerge after assuming the resting posture. This is very characteristic of Parkinson's disease, re-emergent tremor. Okay, now the question here is, Parkinson's disease, the tremor and the rigidity, all of that is going to be symmetrical or asymmetrical? Is it going to be symmetrical or asymmetrical? Yes, Parkinson's disease patients will have depression, dysthymia as well as anosmia. In fact, the earliest manifestation of Parkinson's disease is anosmia and autonomic dysfunction. Because this dopaminergic neuron that are getting degenerated, they first start in the locus coeruleus, okay, and the anterior olfactory bulb. So earliest degeneration of dopaminergic neurons is in Parkinson's disease. There is degeneration of dopamine producing or dopaminergic neurons. So it starts with anterior olfactory bulb and locus coeruleus, which is concerned with autonomic nervous system regulation. So even before patients start developing rigidity, tremors and motor features of Parkinson's disease, they might have had the history of anosmia. So anosmia predates the onset of motor features. Okay, and this degeneration of dopaminergic neuron also spreads to the areas of the brain which are concerned with mood. So patients can get depression, right? Because it includes the autonomic nervous system. Patients can have autonomic nervous system manifestations in the form of postural hypotension, resting tachycardia, okay, and they can have constipation. They generally do not have urinary incontinence. They can have constipation. Constipation can happen. Parkinsonism can be associated with memory loss. I'm coming to that point. Okay, so now going back to the question, they have not mentioned about tremors, which is a very important point for me to consider the Parkinson's disease. That is first thing. Okay, then the second thing is the behavioral change and forgetfulness or dementia. Can it occur in Parkinson's disease? Yes, it can occur in Parkinson's disease. So 20% of the patients with Parkinson's disease develop dementia, will develop dementia. And there is another condition which you know, right? Dementia with Lewy bodies or diffuse Lewy body dementia, right? Lewy body dementia. Now we need to differentiate between a Parkinson's disease and Lewy body dementia. Parkinson's disease also has Lewy bodies, and there also dementia can occur. And the dementia with Lewy bodies, there also dementia can occur and Parkinson's features can occur. What is the difference? In Parkinson's disease, dementia is a very late feature. Late feature. It won't occur until decades after the onset of Parkinson's disease. Most patients of Parkinson's disease are diagnosed in their 60s. In their 80s is where you start noticing the dementia in them. But in case of dementia with Lewy bodies, right, you have to remember that in these patients, dementia occurs either before the diagnosis of the motor features or within 1 year of the diagnosis of motor features. In Parkinson's disease, it's going to take decades. Today, you diagnose Parkinson's disease, 10, 20 years later, you will see dementia. In dementia with Lewy bodies, sometimes dementia is first diagnosed and then the motor features. Or at the same time of presentation, both dementia and motor features are there. Or today, I have diagnosed it with motor features. Within 1 year, dementia becomes evident. Okay, clear? But in neither cases, you will see urinary incontinence. So if it is a Parkinson's disease patient, if at all it is a Parkinson's disease patient, right, tremor and motor features would be there at least for 10 years before the patient develops forgetfulness and behavioral change. So it definitely goes against the diagnosis of Parkinson's disease. And in any patient of Parkinson's disease, falls are possible. Why do they fall? They fall because of this particular gait, right? They are stooping forward, they're trying to catch their center of gravity, and they have a tendency to fall forward. But for that to occur, first it starts with tremors, slowly this rigidity increases, slowly they become stooped. It's going to take several years. In any patient with Parkinson's diagnosis, if there is evidence of early falls, right, it is a red flag sign. Your diagnosis of Parkinson's disease may be wrong. Several years after the diagnosis of Parkinson's disease, if they are experiencing frequent falls, it makes sense. Early in the course of the Parkinson's disease, if they are falling frequently, it is considered as a red flag sign. So this multiple falls, I will take it as a red flag sign. So now tell me what conditions where dementia occurs and frequent falls occur early in the course of the illness. There are only two conditions you have to remember where dementia plus frequent falls are mentioned. Dementia plus frequent falls. Which condition? Okay, one you are all aware, right? Normal pressure hydrocephalus, dementia, frequent falls, and urinary incontinence is described as a triad of normal pressure hydrocephalus, right? Prince, right? Yeah, see, Parkinson's disease is one of the alpha synucleinopathies. Yeah, these alpha synucleinopathies, because you brought it up, I want you to remember one point. These alpha synucleinopathies can be associated with what is called as REM behavioral disorder. So these patients with Parkinson's disease can have REM behavioral disorder. Now, what is REM behavioral disorder? REM behavioral disorder is, now when we go into the rapid eye movement or REM phase of sleep, what are we experiencing? We are experiencing beautiful or annoying dreams, right? In the REM sleep, rapid eye movement sleep, we are going through dreams. Like in the dream, you may be playing cricket alongside Virat Kohli, or in the dreams, you may be dancing alongside Deepika Padukone. But whatever is happening is only in the brain. Physically, you're not doing it, right? You're not dancing on the Besharam Rang. Your body movements are not happening. Only in brain, you're dancing with Deepika Padukone. Why the dreams or brain's thoughts are not put into action during this REM sleep? Because during sleep, our muscle tone goes low, hypotonia, right? Muscle tone goes low. We are in hypotonia. So that hypotonia prevents us in doing all these actions. But what happens in Parkinson's disease? The tone is high already, right? The tone is elevated, rigidity, and that too in Parkinson's disease, truncal as well as axial, both tone is increased, right? That is what we were discussing. Aapka limb tone is also increased, and the central body tone is also increased. So whatever your brain is dreaming, you can put that into action. So if you're dancing with Deepika Padukone on Besharam Rang, right, you're doing all those steps in sleep. If you're fighting against John Cena in WWE, right, you're literally pulling your partner out of your bed. All that can happen, right? And we call this as REM behavioral disorder. They can ask you REM behavioral disorder is characteristic of which of the following disease. Either they will mention alpha synucleinopathies, right? Parkinson's disease is a classical example, or they can directly mention Parkinson's disease. REM behavioral disease. Yeah, this is also one of the non-motor manifestations of Parkinson's disease. non-motor manifestations of Parkinson's disease. Okay, good you brought it up. So this, there are so many red flag signs, so I will not be considering this as a Parkinson's disease. Yeah, I was telling you about dementia with frequent falls. You have to think of two things. One is normal pressure hydrocephalus. Okay, and the second one is progressive supranuclear palsy. Progressive supranuclear palsy. This is also a condition where patients have frequent falls and they have dementia, but they do not have this urinary incontinence. Okay, why the patients with progressive supranuclear palsy have frequent falls? Progressive supranuclear palsy, why do they have frequent falls? This is also an akinetic rigid syndrome, right? So they have bradykinesia, reduced movement, they have rigidity. Now the rigidity here, this is also an akinetic rigid syndrome. So it is somewhere similar to Parkinson's, but it is also somewhat different from it. Okay, so rigidity here is affecting the axial skeleton more than extraaxial. So the limb muscles are less affected by rigidity. It is the truncal muscles which are affected more. Axial is the one which is affected. Okay, and which part of the axial? Is it anterior or posterior? In case of this progressive supranuclear palsy, the posterior back muscles are more affected. So what happens? The result is these patients have what is called as retrocollis. The back muscles are more contracted, so their neck is pulled upwards. Retrocollis, right? So this leads to what is called as retrocollis. Retrocollis. Okay, then what is the second important feature? The name says progressive supranuclear palsy. Now these patients have vertical gaze palsy, more predominantly affecting the upward gaze. Predominantly affecting the downward gaze. So they have vertical gaze palsy, both the direction, the gaze or movement of eyeballs is affected, but the downward gaze is more affected. They have more difficulty in looking down. So just imagine a patient who has developed retrocollis, right? The head is like this. Now I cannot look down also. So what is my awareness about the floor and the lower surroundings, right? My whole field of view is shifted upwards towards the moon and sun. I am not able to look at the eye level. Uske below to impossible for me to see, right? Because retrocollis and downward gaze palsy. Because of that, these patients have very early in the stage of illness, they have frequent falls. They have frequent falls, and because it is a neurodegenerative disease, these people can have dementia. But urinary incontinence is not known to occur in these patients. Okay, clear? Okay, and I think you are familiar with the MRI finding, right? On MRI, what do we get? We get a hummingbird sign. Because the tegmentum is atrophied with a normal cerebellum and pons, we get that hummingbird appearance on the MRI. So that is a frequently asked question. Remember and also go through the images on the internet. Okay, the other sign I want you to remember, or image you should identify, is what is called as Procerus sign. Google it, you will get the image, Procerus sign, which can also be seen in PSP patients. Okay, so can we think this as a case of progressive supranuclear palsy? No, right? So we are only left with an option which is normal pressure hydrocephalus. That's our correct answer. And normal pressure hydrocephalus is described by a triad. The triad of NPH is dementia, urinary incontinence, and gait imbalance, resulting in frequent falls. That's the triad of normal pressure hydrocephalus. So this answer is normal pressure hydrocephalus. Okay, just a quick table that will give you signs of normal pressure hydrocephalus. I don't think I need to talk more about it except the triad. Triad is dementia or cognitive dysfunction, gait disturbance, and urinary incontinence. Okay, how do we diagnose these patients? For the diagnosis of normal pressure hydrocephalus, what do we use? How do we diagnose? How do we diagnose a case of normal pressure hydrocephalus? I will suspect when an elderly, it is more common in the elderly age group. Normal pressure hydrocephalus, not like 25-year-old I presented with me and I will consider normal pressure hydrocephalus. If he present with this triad, I will be still thinking of some other causes. Right? I will think of this in an elderly individual, and in this question they have mentioned in her old age. Right? It is seen in elderly. So an elderly presenting with this triad, I will be thinking of, but how will I diagnose? How will I confirm? What are the investigations necessary? What are the investigations that are necessary? Two investigations are necessary. One is an imaging to say that there is hydrocephalus, but the name of the disease is normal pressure hydrocephalus. Hydrocephalus is there, but pressure is normal. So I need a CSF tap to show that the CSF pressure is normal, right? So we need imaging to show that there is hydrocephalus, plus I need the CSF tap to prove that there is normal pressure, normal opening pressure. Right? We can connect a manometer to the lumbar puncture needle and measure the pressure. It should be normal, but imaging should show that there is hydrocephalus. And there is one important differential diagnosis, because we are talking about elderly patients. They will have age-related cerebral atrophy. The brain is getting atrophied with aging. So because of that, all your ventricles may look dilated. So how do I know whether it is really a hydrocephalus or the ventricles are dilated because of the age-related atrophy? So for that, we need to look at something called as callosal angle. Callosal angle. Let's look at this angle. And here, which one is a normal pressure hydrocephalus and which one is showing the age-related changes? So in NPH, right, it is more obtuse angle. It's a wide angle here. This patient probably has a significant atrophy and all, cerebral atrophy. So that is why the ventricles are stretched, because the brain parenchyma is atrophied. Here, brain parenchyma is not atrophied. It is the ventricles which are indeed dilated without the brain parenchyma being atrophied. So we see a obtuse angle. We call it as callosal angle. If it is obtuse, it is favoring the diagnosis of normal pressure hydrocephalus. I will still do a lumbar puncture, measure the CSF opening pressure. It should be normal to call it as normal pressure hydrocephalus. Now, once you are diagnosed, right, how do you treat? Treatment of normal pressure hydrocephalus. Treatment is essential. If tremor and bradykinesia are included, can we consider Parkinson's? No. It's still difficult to explain the urinary incontinence. Even if the tremor and bradykinesia are included, it is difficult to explain the urinary incontinence. Right? In a real clinical scenario, I have to find a different explanation for incontinence. Rest of the things can be explained from the Parkinson's disease. Right? So it happens that when you are seeing patients, they may have two diagnoses. Right? It may be a case of Parkinson's disease. Incontinence may be because of something else, overflow incontinence or something else. If you have to explain from one condition, it is impossible. If they have tremors and the rigidity, Parkinson plus some other diagnosis should be there. Right. Okay, so what all we can do for these patients is, can we use acetazolamide? Can be used, but not largely helpful. So the best things to do is therapeutic lumbar puncture. What you can do is repeatedly tap the CSF. That is one thing, but that comes with risk, like repeatedly tapping. Patient needs to come to the hospital, spend some time, risk of introducing infections and meningitis, meningoencephalitis, all that is there. Or alternatively, what you can do is ventriculoperitoneal shunt, as someone had mentioned, right? If someone asks you what is the preferred treatment, it is VP shunt. Once you shunt it, right, their symptoms improve up to 80%. 80% of the patients will have improvement in gait. They will have improvement in even the memory functions, and they will have improvement in incontinence. Right? It is like, I can say, largely a treatable condition. And for this question, our diagnosis is that normal pressure hydrocephalus. Okay, we will, LP will improve symptoms. See, in practice, that is also what we do. Sometimes we are not really convinced based on the image and the lumbar puncture and all. We are not convinced. Not everything goes according to books, right? Real challenges are real. So what we do is, we do a therapeutic tap and see how patient responds. Like I did one tap, I removed some 20-30 ml of CSF. Now the next time After a few days, if patient's symptoms are improved, then I am more sure about my diagnosis of normal pressure hydrocephalus. So sometimes in practice we do that. Okay, now let's move to the next question. Patient with COPD presents with acute exacerbation and is admitted to ICU. What is the initial management? Invasive PPV, that is positive pressure ventilation, should be given. Non-invasive positive pressure ventilation should be given. IV corticosteroid should be administered, or permissive hypercapnia is allowed. Which one of this is a ideal management here? COPD diagnosis is known. Acute exacerbation is admitted to ICU. What is the initial management of this patient? Invasive positive pressure ventilation. Invasive means intubate karna hai, right? Put a tube and then connect to mechanical ventilation. That's what it means. Non-invasive positive pressure ventilation like CPAP or BiPAP, you are giving positive pressure but not through an invasive tube, not through endotracheal tube. You are using a interface in the form of face mask or something like that, right? BiPAP or CPAP. So this option basically means intubate and consider mechanical ventilation. This option means either CPAP, continuous positive airway pressure, or bilevel positive airway pressure, right? Now administer IV corticosteroids, or the last statement is permissive hypercapnia is allowed. So Madhavan Kutty thinks we should give non-invasive positive pressure ventilation. Prince Care, Joseph, Neelam Bhatia, all of you think non-invasive positive pressure ventilation. RPR considered corticosteroids. Okay. Prince Care, yeah, bilevel positive airway pressure. Okay. Now, few important points. We'll start with the question. The diagnosis is COPD. Now tell me, what is the most common cause for acute exacerbation of COPD? Why a COPD flares up? What is the most common cause for acute exacerbation of COPD? See, bronchial asthma, acute exacerbation is most often because of exposure to trigger factors. They are allergic to something, or something is a well-known trigger. Exposure to that triggers the asthma attack. So most commonly, acute exacerbations in asthma are because of exposure to trigger, continued exposure to trigger. If that is not the cause, then poor compliance to medications. So in COPD, what is the most common cause for exacerbation? The COPD, the most common cause for exacerbation is infections, right? So in COPD, most common cause for exacerbation is infections. So can it be prevented? Can the infections be prevented so that the exacerbation is prevented? Yes, right. At least some infections are preventable. So is it recommended that we should consider vaccination for COPD patients? Yes, right. So what are the vaccines that are recommended for COPD patients? Vaccines. This is a very potential MCQ point. Vaccines recommended for COPD patients. Prince Kier, right. The patients who are experiencing very frequent exacerbation, azithromycin can be used as one of the strategies to reduce the exacerbations. But there are also some infections which are vaccine preventable. Should we consider that in COPD patients? So what are the vaccines that you would give for all COPD patients? Yes, pneumococcal vaccine, first one, good. What else? Pneumococcal, right. Anything else? Okay. Would you give them vaccination against the influenza virus? Against influenza virus? The flu vaccine, would you give them? Right. The influenza vaccine is recommended for almost all, right? So influenza vaccine also included. Okay. Recently, now for COPD, we follow this something called as GOLD guidelines, right? Global Initiative for Obstructive Lung Disease, GOLD guidelines for management of COPD. And recently, like the last guidelines, they've introduced one more vaccine that should be considered for COPD patients. What is that vaccine? Yes, HIB is recommended, HIB is recommended, and there is also a new influenza virus vaccine that is like your H1N1 and all, seasonal every year. There is also a vaccine recommended recently. Which one is that? Which vaccine is recently recommended? COVID, yeah, COVID is a standard recommendation for everyone, right? Not only COPD. Okay, let me list it because it is recommended for everyone. COVID is also there. Apart from that, RPR channel, yes, pneumococcal and Hib are definitely required for the splenectomy patients. Influenza is just a choice, right? Nothing to do with, it's not a capsulated organism. We're talking about virus. COVID-19, we're talking about virus. So whether splenectomy done or not, it doesn't make a difference, but they are recommended for people. Okay. So what has been noted is that the cases of diphtheria and pertussis coming back in patients with COPD is increasing of late. Probably because the vaccine coverage in the kids is declining for whatever reason in various parts of the world, either because of the economical constraints or because of the religious reasons the vaccinations are not being taken. So there is decreasing level of the diphtheria, pertussis and tetanus vaccination, and because of that these patients in the elderly, because once the kids are not well vaccinated, they get infected, and by the time you become 50, 60, when COPD is diagnosed, right, even your childhood vaccination, the antibodies would have gone down low, but still many years the people were not getting infected with pertussis or diphtheria because the prevalence was low in the in the children population. But now that children started becoming a reservoir, these elderly who's, see, I am vaccinated right now, I'll not get affected, but 30, 40 years from now, if the herd immunity is low, my immunity also would have gone low and I can get affected. So that is why they are recommending the DTaP or diphtheria, tetanus and acellular pertussis vaccine now for COPD, and this is going to be a potential MCQ. They can ask you which of the following vaccination is newly recommended for COPD patients, right? So please remember this. This is newly recommended. Okay. So that's about the exacerbations. Most commonly infections, mostly viral. If we are talking about bacterial, it is like Moraxella catarrhalis, Streptococcus pneumoniae, and those organisms. Once they come to hospital, you have to evaluate for the cause for exacerbation, which is most likely going to be an infection. So you would probably treat with antibiotics. But the management of this exacerbated part of COPD, right? We will see which options make sense. What is permissive hypercapnia? What do you mean by permissive hypercapnia? Hypercapnia means COP, the carbon dioxide levels in the blood are high, and we are allowing it to stay that way, right? Is it a real term or it is just made up in the question? It is a real term. There is something called as permissive hypercapnia. But please remember, permissive hypercapnia is not for chronic hypercarbia, right? Patients who have a long standing increase in the CO2 level, it is not an applicable concept. Patients who have like a short duration of a respiratory disease, we can allow them to have this hypercarbia for some time. A typical example I can give you is patients with ARDS. They have developed ARDS, right? They are retaining carbon dioxide now because of this ARDS. Their oxygen levels are low, they are retaining carbon dioxide. Now, in an attempt to wash out this carbon dioxide, I have to use very high level ventilatory settings, and you know that ventilatory settings can cause barotrauma and volute trauma. So I don't want to take that chance of injuring the lung further. So I will allow this hypercarbia to stay there. As long as I'm maintaining 88 to 92% of saturation, I'm happy even if the carbon dioxide levels are high. These high carbon dioxide levels may be affecting the patient's brain. He may stay drowsy for now, but as long as ventilator is taking care of his respiration and oxygen levels are fair, I'm okay with it. That is permissive hypercapnia. So it is especially applicable to acute hypercarbic conditions, a short-lived hypercarbic condition. It does not apply to chronic hypercarbic conditions. A COPD patient, if you allow him to have a CO2 of 70, 80, 90, he'll become drowsy, his respiratory effort will go, and you need to put him on mechanical ventilator. So it does not apply to COPD. So this option is out. Option D is out. Now IV corticosteroids. They're not indicated in management of any acute obstructive lung disease, like any obstructive lung disease presenting with acute exacerbation. And asthma presenting with acute exacerbation, many people give steroids in the emergency room, but that is not what is indicated by the guidelines. Right? What we should do in acute exacerbation of asthma, we should give repeated cycles of short-acting beta agonists. Give in nebulizations continuously, repeatedly till the spasm is relieved. You can use magnesium sulfate. Steroids have limited role. COPD, to steroids have no role at all. Right? No role in the management of COPD. If a patient of COPD is getting oral steroids or injectable steroids, whether an acute exacerbation or a chronic management, it is mismanagement. Right? You are actually increasing the risk of developing infections and further exacerbation and repeatedly coming to hospital. Hospital का business बढ़ेगा, patient के लिए कोई फायदा नहीं है. So no role. Flat, no role. Okay, so that is out. Now we are left with invasive positive pressure ventilation and non-invasive positive pressure ventilation. We have to choose between the two. Should we intubate any patient of acute exacerbation of COPD just like that? The answer is no, right? There are specific indications for endotracheal intubation. One, there is severe hypoxia or severe hypercarbia, or there is respiratory failure in the form of reduced respiratory effort from the patient side, or the patient GCS is very low, which can happen in COPD patients if they retain more and more carbon dioxide. Once their PCO2 level is 70 plus, their mental function starts coming down. We call it a CO2 narcosis or CO2 encephalopathy. Then their respiratory efforts also start coming down, their GCS starts coming down. You don't have any choice, but you need to put them on mechanical ventilation. Once their GCS is going low, we can't put them on BiPAP or CPAP. Why can't we put them on BiPAP and CPAP when their GCS is going low? The simple reason is when their GCS is going low, they cannot protect their airway. If you put a BiPAP, it will give a positive pressure. It is inflating your oral cavity and pharynx with the pressure that is coming. Right? This inflation means that some amount of air will go into the esophagus, into the stomach. Some amount of air will go into the trachea. But the stomach will get distended over time. The content of the stomach can regurgitate, come to the throat, and during one cycle of positive pressure respiration, this content can go into the trachea. So there is increased risk of aspiration. Whatever secretions that are collecting in the nose and the throat, they are pooling into the pharynx. They can also go into the trachea. So if the GCS is good, I will swallow. I'm conscious, secretions collecting, I'll swallow. But when I'm having low GCS, I'll not do that. So I'll not be able to protect my airway. I become at increased risk of aspiration. That is why when GCS is low, we need to intubate. In this question, no such signs. They have not given the ABG to show that there is severe hypoxia or severe hypercarbia. They have not mentioned the GCS to say that patient is having low GCS or GCS less than 8 is the number that we need to remember. That is not there. So there is no indication for mechanical ventilation. So we are only left with option B, right? Non-invasive positive pressure ventilation, right? So that's our correct answer because there are no indications for intubation in this patient. Okay, good. Now let's move to, yes, there is chances of aspiration. Okay, we will move to the next question now. In comparison to diffuse cutaneous systemic sclerosis, limited cutaneous systemic sclerosis presents more commonly with which of the following symptoms? Myopathy, esophageal dysmotility, interstitial lung disease, or scleroderma renal crisis. Vikash Sharma, okay, we'll take this question and then we will take a quick break. In comparison to diffuse cutaneous systemic sclerosis, limited cutaneous systemic sclerosis presents more commonly with which of the following features? myopathy, esophageal dysmotility, interstitial lung disease, or scleroderma renal crisis? Let me wait for your answers and then we will take a quick discussion on systemic sclerosis. Which one of this? You are familiar with the disease systemic sclerosis, right? And there are two subcategories, diffuse cutaneous and limited cutaneous. So you should objectively know what do you mean by diffuse cutaneous and you should know what do you mean by limited cutaneous. Okay, I'm waiting for you guys to respond. I'm just curious to know how much you know about the systemic sclerosis. Okay, good. I think we will go for a quick break and maybe 15 minutes and then we will connect after this. Meanwhile, I will give you a little small task what you can do in this 15 minutes on your mobile phone. Okay, so learn about the spectrum of systemic sclerosis. Just the definitions. What do you mean by limited cutaneous and what do you mean by diffuse cutaneous? When we come back, we will learn how do they differ at the pathophysiology level and how it is easy for us to remember the differences between these two. And you can tackle any questions related to that. Limited is crest. Yes, that's a valid point. Suman Kavas, we will be connecting soon. Okay, so guys, we will resume after the break. I'm leaving you with this question and we will discuss, we'll take around 10-15 minutes to discuss important points about systemic sclerosis and then we will continue with the next questions. Okay, see you soon guys, just 15 minutes and we'll be connecting back. Hi guys, I hope I am live and audible and you guys are able to hear me out. Just give me a thumbs up if you guys are able to hear me loud and clear. Okay, so I can see myself live. So we will begin with the session. We were talking about this question number 27. In comparison to diffuse cutaneous systemic sclerosis, limited cutaneous systemic sclerosis presents more commonly with which of the following conditions? One of you had commented that there is something called as CREST syndrome. Yeah, the CREST is the terminology which we no longer use. But yeah, once upon a time, we used to call something as CREST syndrome. So what CREST syndrome stands for? So C in the crest stands for calcinosis cutis. Calcinosis cutis. So calcification of skin and soft tissues. Calcinosis cutis. Right. R in the crest syndrome used to stands for Raynaud's phenomenon. Raynaud's phenomenon. Okay. E here used to stand for esophageal involvement. Esophageal involvement in the form of esophageal dysmotility, right? Okay, yes, here used to stand for sclerodactyly. Now what do I mean by sclerodactyly? Sclero means basically fibrosis. Dactyly means we're talking about fingers. So there is fibrosis of the skin over the fingers leading to resorption of the skin, resorption of the fingers, like lengthy fingers become shortened. Sclerodactyly, right? And the T here used to stand for telangiectasia. So there used to be vascular telangiectasias on face and some other areas. So all this put together we used to call it as CREST syndrome. Yes, some of you had commented saying that CREST syndrome is equal to the limited cutaneous, which is very true. But the manifestation of limited cutaneous systemic sclerosis are more than that. Okay, so if you know CREST, then you can answer this question for sure. But let us also know a little more about the systemic sclerosis. Okay, now inside the rheumatology, we study about some important diseases. SLE is the topmost important disease. Then we have rheumatoid arthritis. Then we have this immune-mediated inflammatory myositis, dermatomyositis, polymyositis, right? Anti-synthetase syndrome, those, right? And then next in the queue is systemic sclerosis. The systemic sclerosis is different from your rheumatoid arthritis and rheumatoid arthritis and the SLE in one way, and that is when it comes to SLE, when it comes to rheumatoid arthritis, genetics plays a very important role, right? You know that particular HLAs are associated with increased risk of RA, particular HLAs are associated with increased risk of SLE. So we know that genetics plays a very important role. But when it comes to systemic sclerosis, see, in rheumatoid arthritis or SLE, environmental factors also play an important role. Right, like I was giving you an example, rheumatoid arthritis, yes, genetics plays an important role, plus environmental exposure. I was giving you an example of a gingivitis caused by Porphyromonas gingivalis that acts as a environmental contributor. You have genetics required for it, you get this infection, your chance of developing rheumatoid arthritis increases. But the systemic sclerosis is one condition where the environmental factors play the predominant role. The genetics plays very minimal, negligible, or no role. Why we have come to this conclusion? Because there is no disease which iatrogenically we have introduced which resembles rheumatoid arthritis. Like you give this drug and patient develops rheumatoid arthritis, or you give this drug, patient develops something similar to SLE. No, we don't have anything like that. Yeah, there is drug-induced SLE, I agree, but apart from that. But a condition very similar to systemic sclerosis can be seen, which without any role of genetics, just by exposure to a particular drug, patient might develop. Now, what is systemic sclerosis? Systemic sclerosis means there is a fibrosis of systemic organs plus the skin. Right? Skin fibrosis of the fingers and hands plus the internal organs. That's what the basic meaning of systemic sclerosis. Have you heard of nephrogenic systemic fibrosis? Anybody has heard of nephrogenic systemic fibrosis and where it occurs? Nephrogenic systemic fibrosis. Or have you heard of nephrogenic fibrosing dermopathy? Nephrogenic fibrosing dermopathy. Okay, so nephrogenic fibrosing dermopathy or nephrogenic systemic fibrosis is a condition which is very, very similar to systemic sclerosis. No difference. There also skin becomes thick and fibrosed. Internal organs like lungs can develop interstitial lung disease. They can develop esophageal dysmotility. So a lot of similarities. Why that is happening? Right, Madhavan Kuti. So exposure to gadolinium in patients with compromised renal functions was known to be a trigger. So now we know that you don't need any genetics. Just by giving gadolinium, we can create a disease which is very, very similar to systemic sclerosis. Right. Similarly, exposure to certain contaminated oils in their dietary intake had led to similar diseases. So we clearly understand that genetics plays very minimal role in this rheumatological disease, and environmental factors play important role. When it comes to SLE, rheumatoid arthritis, IIMs, genetics plays a very, very important role. Right? Okay, that's a point. Now, there are some terminologies I want you to know before we discuss a little more about systemic sclerosis. The first terminology is morphia. Can anybody tell me what is morphia? Morphia. And if you are into dermatology or if you are very much fond of dermatology, you might have heard of a device called Morpheus 8, which is used, Morpheus 8, which is used for skin tightening, like people with saggy skin because of aging, or people who have saggy skin after weight loss. For skin tightening, there is a dermatological device called as Morpheus 8. I think it is a MNRF device, micro needling plus radio frequency. Basically, it tightens the skin. So the word morph somewhere here means the tightening of the skin. Morphia means there is skin tightening or fibrosis. Right? When this fibrotic process is only restricted to skin, we will call it as morphia. Right? Only skin. We will call it as morphia. The same pathology when it extends to the internal organs. Right? System is getting affected, not only the skin. Then we will call it as systemic sclerosis. Systemic sclerosis. So systemic sclerosis basically means the same pathological process that is causing morphia, but it is now involving systemic organs. Then we will call it as systemic sclerosis. And we categorize that into limited cutaneous and diffuse cutaneous. So for categorization into limited or diffuse cutaneous, we will see the extent of skin involvement, not the extent of organ involvement. Any organ involvement evidence, we will call it a systemic sclerosis, but we will look at the extent of skin involvement. Okay. When there is patchy skin involvement with no systemic features, that is morphia, right? Skin plus systemic involvement in the form of sclerosis, which is nothing but fibrosis, right? Then we will call it as systemic sclerosis. Now, if the skin involvement only includes face though both the types it will be included. Okay. In terms of the limb involvement, as long as the skin fibrosis is restricted to the portions distal to the elbow, like you can see in this image. In the upper limb, it is restricted to distal to elbow. In lower limb, it is restricted to distal to the knee joint. We will call it as limited cutaneous, right? The fibrotic process is not extended proximal to the elbow joint. It is not extended proximal to the knee joint. That is limited cutaneous. When it involves anything more than the elbow joint, more proximal to elbow joint or more proximal to knee joint, that is where we call it as diffuse cutaneous. Okay, so the distinction between diffuse and limited cutaneous is based on the extent of skin involvement. But we know that both these diseases, limited cutaneous versus diffuse, behave differently. Right? In what way they behave differently? To understand that, we need to understand the pathophysiology quickly. Okay. The systemic sclerosis, there are two things. One, there is vascular injury. Second, there is triggering of fibrotic process. The two things happening in systemic sclerosis patients. Blood vessels are getting injured and something is triggering the fibrotic process. Okay. So whatever is genetics or environmental factor, something is triggering the endothelial injury. If the endothelium is injured, body will make an attempt to repair it, right? So that process of repair leads to proliferative obliterative vasculopathy. What does that mean? Inside the blood vessel, the endothelium is more proliferating and it is narrowing down the orifice or the channel, right? The result is ischemia and repair. This ischemia and repair is happening one side. On the other side, there is production of certain cytokines which are fibrogenic. All of these are fibrogenic. A very important question that can be asked is, which cytokine plays the predominant role in fibrosis in systemic sclerosis patients, right? That is TGF beta. This is the most important cytokine concerned with the pathogenesis of systemic sclerosis. See, there is a reason why I am talking about this. Okay, when endothelial injury occurs, endothelium of the pulmonary vasculature can also be affected, so it can lead to pulmonary hypertension, right? And this ischemia and repair of the blood vessels in the fingers, right, that can lead to what? Development of Raynaud's phenomenon, and repeated ischemia, injury, healing, that can lead to sclerodactyly. Okay, now I want you to remember one important point. I am partitioning this screen. The endothelial injury is the predominant pathological process that you see in limited cutaneous patients. Clear? Predominant pathogenic process in limited cutaneous. Okay, so this arm is more predominant in limited cutaneous, and this arm is more predominantly happening in diffuse cutaneous. Now you guys should be able to tell me clearly, okay, which patient is more likely to develop pulmonary hypertension, limited cutaneous or diffuse cutaneous? In diffuse cutaneous, it is the fibrogenic potential which is more, endothelial injury is less, right? So this leads to fibrosis of internal organs, right? So which patient is more likely to develop pulmonary hypertension? It is limited cutaneous. Which patient is more likely to develop the interstitial lung disease, where the fibrosis is happening more? In the diffuse cutaneous, right? So that is how, if you just remember that limited cutaneous means it is mostly affecting the endothelial function. So vascular abnormalities are more likely to occur in the limited cutaneous, and the fibrotic process is the predominant pathophysiology in case of the diffuse cutaneous, so that the fibrotic outcome is more common in the diffuse cutaneous. That will give us, like, if you remember this, you will be able to get all these questions related to limited versus diffuse easily. Okay, point number one, important difference. Skin involvement happens in both because that's part and parcel of the systemic sclerosis. Okay, but an important point is, in limited cutaneous, skin involvement is indolence and it is limited to the portions distal to the elbow and knee joint. In diffuse cutaneous, it is more commonly involved, and generally in diffuse cutaneous it is more rapid. Okay, and again, please pay attention. Raynaud's phenomenon in case of limited cutaneous antedates, because vascular injury is starting there, right? That's the predominant finding here. So first there is repeated ischemia and repair, so they develop Raynaud's phenomenon. Long in the course of the illness, the fibrosis of the skin starts happening. So first they have Raynaud's phenomenon, later they have fibrosis. On the other hand, diffuse cutaneous, in the beginning only they start seeing the fibrotic changes and Raynaud's phenomenon. So in limited cutaneous, the Raynaud's phenomenon antedates, occurs before and then fibrosis. On the other hand, in case of diffuse cutaneous, the skin fibrosis and Raynaud's phenomenon occur together. So there was one NEET PG question asking, between limited and diffuse cutaneous, which patient is more likely to present with critical digital ischemia? Is it limited cutaneous or is it diffuse cutaneous? Who is more likely to present with critical digital ischemia? At presentation, there is severe ischemia, gangrene of the tips of the fingers. Which patient is more likely to present like that? Is it going to be limited or is it going to be diffuse? Which patient? Yeah, Ankit, we will rush through. Yeah. The answer is limited cutaneous. Why limited cutaneous? Because they first develop Raynaud's phenomenon. Raynaud's phenomenon occurs in 5% of the general population. You put your hands into the cold water, your hands go pale and numb. It happens in 5% of the general population. When you are experiencing, right, you will just say that, okay, I'm not able to tolerate cold nowadays, I can't put my hand in cold, but you will ignore the symptoms till the ischemia becomes so critical that you start developing gangrenous ulcers. On the other hand, diffuse cutaneous, as soon as the disease starts, with initial few episodes of the Raynaud's phenomenon, you already have skin fibrosis. When your fingers are becoming like this, you don't sit quite at home. You present early, right? You present early before severe ischemia has occurred. But limited cutaneous, only Raynaud's phenomenon, skin fibrosis is not there. So you sit on it. Patients sit on it. And once the critical ischemia comes, when they start seeing the ulcers, they present, right? So it is limited cutaneous who are likely to present with critical digital ischemia. So this is an important MCQ point. Likely to present with critical digit ischemia. Okay, that is one point to note. Okay, then musculoskeletal involvement, right now we will forget. Interstitial lung disease. In limited cutaneous, fibrotic arm of the pathophysiology is not very active. So it is ILD, if it is occurring, it is very mild. On the other hand, diffuse cutaneous, it is very aggressive, severe and rapid. On the other hand, endothelial injury is a predominant feature in limited cutaneous. So very frequently they have pulmonary arterial hypertension. A diffuse cutaneous, if you develop pulmonary arterial hypertension, it is because of ILD, not because of the endothelial injury. That's not a predominant pathology there. So interstitial lung disease is happening and they will develop pulmonary hypertension because of the lung disease. Okay. Then coming to scleroderma renal crisis. Scleroderma renal crisis is a hypertensive emergency that we see in patients with the scleroderma. Okay, and generally we treat them with AC inhibitors or ARBs, and they now respond well. Once upon a time, when we didn't know the pathophysiological process, it was one of the reasons for mortality. Now it is not anymore. But again, as I've told you, right, internal organs are more likely to be affected with diffuse cutaneous. So you can go with the answer saying it is more common with diffuse cutaneous. Okay, then calcinosis cutis. Some of you are already telling this. Crest is typically limited cutaneous. So calcinosis cutis is a typical feature of limited cutaneous. Okay, now I'm taking you back to the question. You should be able to answer even if you don't know much about systemic sclerosis. In comparison to diffuse cutaneous systemic sclerosis, limited cutaneous systemic sclerosis patients are more commonly to present with. Myopathy, right, it is like more likely to be seen with diffuse cutaneous. The severe joint involvement and severe muscle involvement, again diffuse cutaneous. Esophageal dysmotility, right, part of the crest syndrome, typically seen with limited cutaneous. Okay, interstitial lung disease, which part had a predominant fibrotic potential? Diffuse cutaneous. So it is going to be more common in diffuse cutaneous. Scleroderma renal crisis, which part had predominant internal organ involvement? That is diffuse cutaneous. So scleroderma renal crisis will have diffuse cutaneous. Okay, now the other important points that you need to know is antibodies, right? We do see antibodies in these patients. Which antibody is particularly associated with the limited cutaneous and which antibody is associated with diffuse cutaneous? Antibodies, that can be a MCQ point. Antibodies in systemic sclerosis. Which antibody in limited cutaneous? Which antibody in diffuse cutaneous? Okay, I'll tell you two antibodies. You tell me which fits into which. Okay, the first antibody I'm writing here is anti-centromere antibodies. Anti-centromere antibodies. And the second antibody I'm writing here is anti-DNA topoisomerase 1 antibody, which is also called as anti-SCL antibody, anti-SCL70 antibodies. Which one is for limited cutaneous and which one is for diffuse cutaneous? Okay, I'll make it a little easier for you to remember. Inside a cell, what is the location for centromere? Where are the centromeres present? They are part of the chromosome, right? So where is chromosome present? Inside the nucleus. Okay, now DNA, where is present? It is present inside the nucleus. Can it be present in the cytoplasm? Yes. Can there be circulating DNA present? Yes, right? So DNA has more diffuse presence. So you can simply remember that DNA has more diffuse presence. So anti-DNA topoisomerase 1 antibody is for diffuse cutaneous because it is more diffusely present its presence is not restricted to the nucleus. Can DNA be present inside the mitochondria? Yes, right? Mitochondria has DNA, not in the form of chromosomes, but it has circular DNA. So DNA, its presence is not restricted to the nucleus, but where will we find centromeres? Only in the chromosome. That is only inside the nucleus. So its presence in the cell is limited to the nucleus. So that way you can remember that anti-centromere antibodies are for limited cutaneous. Right? For diffuse cutaneous, it is the anti-DNA topoisomerase 1 antibodies. Cool, good. Okay, is there any blanket prescription for systemic sclerosis? Like we had hydroxychloroquine for SLE, we had methotrexate for rheumatoid arthritis. Is there any blanket prescription for the systemic sclerosis? Something that we give for all patients of systemic sclerosis. Is there any drug? Okay, so remember that there is no disease modifying agent for systemic sclerosis. We generally treat their complications. Right? What are the complications we are talking about? One is esophageal dysmotility, which can occur in limited cutaneous. So we can give prokinetics, right? We can give metoclopramide or other prokinetics. The second thing is they develop Raynaud's phenomenon. How can we treat that? We can give calcium channel blockers as vasodilators for Raynaud's phenomenon. If the patient has developed pulmonary hypertension, you can treat it according to that. You can use sildenafil or other drugs to treat pulmonary hypertension. If patient is developing ILD, how do we treat ILD? Are there any drugs to treat ILD? Yes, we have drugs. What is that? There's a drug called as perfenidone, right? There's a drug called as perfenidone, which is an antifibrotic agent, or there is another drug called as nintedanib. So just a quick list of important management aspects of systemic sclerosis. Basically, we are addressing their symptoms. So if there is Raynaud's phenomenon, we are giving them calcium channel blockers, which act as vasodilators and reduce the Raynaud's phenomenon. Second thing is, if there is pulmonary hypertension, we are using whatever drugs that are available for management of pulmonary hypertension. It will be considered as primary pulmonary hypertension. So you can use drugs like calcium channel blockers can be used. Then you can use phosphodiesterase 5 inhibitors, right? Endothelin 1 receptor blockers like bosentan. Example for this is bosentan. Those things you can do for management of pulmonary hypertension. If there is interstitial lung disease, I want you to remember two antifibrotic agents. That is nintedanib and the other drug is perfenidone. These are antifibrotic agents, and you can also consider using immunosuppressants for arresting the fibrosis. If there is esophageal dysmotility, you can use prokinetics. So there is no blanket prescription. Most commonly prescribed drug is calcium channel blockers because Raynaud's phenomenon is the most common manifestation. So almost all patients receive calcium channel blockers. Rest of the things depends on patient's picture. Yeah, so the hypertension, renal contribution or hypertensive crisis, yes, AC inhibitors are the drug of choice. They generally respond well. Once upon a time, it used to be a cause for mortality, at least not in the current context. Okay, let's move to the next question now. Which of the following conditions presents with water hammer pulse? Water hammer pulse. Options are aortic stenosis, aortic regurgitation, aortic stenosis with aortic regurgitation, or mitral regurgitation. Okay, what is the answer here? Okay, before you guys answer, let me pose another question. Water hammer pulse is only seen in case of aortic regurgitation or aortic stenosis, any of these valvular conditions, or do we see it in other conditions also? Do we see it in other conditions also? And why is it called water hammer pulse? Do you know this physics phenomenon called water hammer? There's a phenomenon called water hammer. What does it mean? It's like the civil engineers study about it. Okay, so if imagine this is a pipe and there is a valve here. Okay, and it is closed. The valve is closed. Okay, and this pipe is connected with a water reservoir. So there is water in this. But water is still, it is not moving because the valve is closed. Now if you open the valve, if you make the passage possible for this, if the valve is opened, right, then water will start moving, right? The valve is open and the water will start moving in one direction. Suddenly if you close the valve again, then water that was moving in one direction, there is a inertia for movement of that direction, but some waves are hitting and reverting back to this closed valve. So there is a forward movement and a reverse movement that generates enormous pressure and turbulence in this pipe. So that is one of the reasons why pipes get broken in long supply chains. Something similar to that happens, or like when we are palpating, we feel something similar to that. That is why this was called as water hammer pulse. Okay, where do we see that? Vasi, right? Yeah, right. Hydraulic shock. Yeah. So where do we see this water hammer pulse? Is it only in a particular valvular disease? MBBS synapse, yes, perfectly right. Any condition where the pulse pressure is increased, you can see water hammer pulse. Now, what do I mean by pulse pressure? Pulse pressure is nothing but your systolic blood pressure minus diastolic blood pressure, right? Any condition where the pulse pressure increases, we can have water hammer pulse. So let us see what are those conditions. What can increase the pulse pressure? One possibility is pulse pressure can be increased if systolic blood pressure is increased and diastolic blood pressure remains normal. If systolic has gone up, diastolic remains normal, the gap between the two increases. One possibility, right? The second possibility, pulse pressure can increase when systolic blood pressure remains normal, okay, and the diastolic blood pressure drops down. Systolic is normal, like 120 hai, but diastolic 60 ke bajaye has become 40. Pulse pressure increased, right? Or the other condition, diastolic is 60, systolic has gone to 180. Pulse pressure increased. It can also increase when the systolic blood pressure increases and the diastolic blood pressure decreases. Systolic has become 120 normal, say has become 180, and diastolic 80 normal, say it has dropped down to 40. Very wide pulse pressure, right? All these are possible scenarios where you can have a water hammer pulse. Okay. Now in aortic stenosis, what do we see? Pulse pressure is widened or narrowed. What happens in aortic stenosis? Pulse pressure increases or decreases? In aortic stenosis. Okay. Have you heard of this term called as systolic decapitation? Systolic decapitation. Some of your old-time examiners might ask you, where do you see systolic decapitation? Where do you see systolic decapitation? Okay, just give me 1 second. Where do you see systolic decapitation? Systole means systole BP. Decapitation means chopping off its head. Decapitation means chopping off its head. That means whatever is the systolic BP, let me say 140, its topmost portion is cut. Sorry, its topmost portion is cut. Right? Where does it happen? Which valvular disease? Right? Your answer should be aortic stenosis. So in aortic stenosis, there is systolic decapitation. Systolic decapitation. Why that occurs? What is the problem in aortic stenosis? Right? This is aorta, left ventricle and left atrium. Aortic valve. There is stenosis of the aortic valve. Now, normally when aortic valve opens during the systole, it opens completely like this. There is no gradient between aorta and the left ventricle. So all the blood in the left ventricle can easily move into the aorta. So the peak pressure during the systole in left ventricle is equal to the peak pressure in the aorta. Right? If the left ventricular pressure is 180, pressure in the aorta will also be 180 because the valve is almost non-existent. It is completely open. But in aortic stenosis, it doesn't open well. Left ventricle, no matter with what force it contracts, only small amount of blood will be able to go into the aorta. So the pressure in the aorta will be lesser than the pressure in the left ventricle. Right? So basically means that the pressure, systolic pressure in the aorta is going down, and the peripheral pressure, whatever you check at the radial or brachial artery, will also be obviously low. Right? So in aortic stenosis, systolic blood pressure is lowered. It is lowered. diastolic blood pressure remains normal. It can increase later if the left ventricular hypertrophy developed. Aortic valve is narrow, left ventricle is doing a lot of work, so it can develop hypertrophy. Once it develops hypertrophy, during diastole, it will not be able to relax well. I think I told you yesterday also, hypertrophied muscle mass struggles with relaxation. So if it is not relaxing well, during the diastole, pressure inside the left ventricle can be higher. So the overall diastolic pressure can sometimes be higher. But at least you can say, to start with, it is normal. It is not going down. So your diastolic blood pressure is going to be normal. So what will happen to the pulse pressure in case of aortic stenosis? Pulse pressure is systolic BP minus diastolic BP. Systolic BP is decreased. Diastolic BP is remaining slow, same. So the pulse pressure is reduced. So you have reduced pulse pressure in case of aortic stenosis, right? So this is not the cause for water hammer pulse. Okay. Can mitral regurgitation cause water hammer pulse? Can mitral regurgitation cause water hammer pulse? What will happen in mitral regurgitation? See, this is your left ventricle, atrium, left atrium, aorta. Right? This is where you have a mitral valve, aortic valve. Now, when the left ventricle is in systole and it is contracting, to eject the blood, the only direction the blood should go is to the aorta, right, during systole, because the mitral valve is expected to be completely closed. But in mitral regurgitation, it fails to maintain the closed structure. So what happens? The blood will go into the left atrium also. So it has two directions now. The blood is going into left atrium, it is going into aorta during the systole. So what is the net result? Aorta is getting less amount of blood during the systole, so it is getting lesser pressure, right? Because some amount of blood, see, let me say cardiac output, thoda sa hissa is going into the left atrium. So what will happen to the systolic blood pressure in the mitral regurgitation? Because aorta is getting less amount of blood, because that whatever output that came, the ejection fraction, some of that is going into the left atrium. So the systolic blood pressure in mitral regurgitation can be decreased. Diastolic blood pressure is not largely affected. So what will happen to the pulse pressure in mitral regurgitation? Again, it is often decreased. Right? We are not expecting it to be increased. Now, the option C, right, aortic stenosis and aortic regurgitation. The result depends on which one is a predominant anomaly, right? Patient cannot have aortic regurgitation and aortic stenosis at the same level, right? One of them is a dominant lesion. Either it is predominantly a stenosis with some amount of regurgitation, or it is predominantly a regurgitant lesion with some amount of stenosis. So the outcome depends on what is it, right? So we will come to this later. Like it's going to be dependent on if it is a predominant stenosis, pulse pressure is going to be narrow. If it is predominant regurgitation, pulse pressure may be wide. So right now we can't comment about it. Now let us see what happens in aortic regurgitation. Okay, what is going to happen in aortic regurgitation? In AR, okay, this is our left ventricle, left atrium, mitral valve. Okay, so during systole, the aortic valve completely opened, right? All the blood from left ventricle went to aorta. Left ventricular contraction is over now, and the left ventricle is entering into diastole. So during this phase, what are the changes we are expecting? The LV going into diastole. Our expectation is that during this phase, the aortic valve closes, right? And the mitral valve opens. The blood from left atrium starts coming to the left ventricle, right? This is during LV diastole. This is what we are expecting. The aortic valve is expected to be completely closed, but because it is regurgitant valve, right, whatever blood that had gone to the aorta, right, will start dropping back into the left ventricle, right? It will regurgitate back into the left ventricle, right? When is it dropping back into the left ventricle? Systole mein there was no problem. The valve was completely open. All the blood from LV went into the aorta. So the systolic blood pressure at least is not dropping down, right? It is at least normal. Okay, but as the diastole started, this valve was supposed to close so that the blood only keeps moving forward, but this valve did not close. So blood is dropping back into the LV. So during diastole the flow through the aorta is reduced. So in aortic regurgitation, systolic blood pressure can remain normal, but diastolic blood pressure is significantly decreased. Significantly decreased. Okay. And the other thing that can happen here is, because left ventricle now has blood, like think about the next cycle. In the next cycle, left ventricle has blood which it has received from the left atrium, but it has also got little more extra blood during the that is regurgitated. So it has more blood than a previous cycle. Now this extra blood is all pumped out during the next systolic. So the systolic blood pressure can increase because it got blood. See, in first cycle, let me say it pumped out 60 ml without any problem. It pumped out 60 ml. During the diastole, whatever 60 ml it should get from the left atrium, it got, but 20 ml dropped down back from the aorta because of the regurgitation. Now I have 80 ml of blood. So this contraction, I am pushing all that 80 ml into the aorta. So my systolic blood pressure is now going to go high. Right? Now that 80 ml I pumped into the aorta, during the diastole, again the valve will not close and more blood will drop down. So my diastole will further go down. So the systolic BP is often increased and diastolic BP is often decreased. So what will happen to the pulse pressure? The pulse pressure is going to be increased. So any condition you have increased pulse pressure, you experience water hammer pulse. Why are we experiencing water hammer pulse? Large amount of output was gone into the aorta through the it is going through the peripheral pulses. Then all of a sudden it is also regurgitating back, right? Something similar to what happened with the water hammer that we discussed earlier. That is something similar to that is exactly happening. That is why we call it as water hammer pulse, right? But it is not specific. It is seen in aortic stenosis or classically described in aortic regurgitation, but it is not specific. Any condition where there is wide pulse pressure. The examples I can quote for wide pulse pressure conditions is hyperthyroidism. First example, beriberi, right? Where you call it as high output cardiac failure. Beriberi. Sepsis. It's again a high output cardiac state. In all these conditions, you can have water hammer pulse, right? Can anybody explain why in hyperthyroidism we are getting water hammer pulse and wide pulse pressure? Why in hyperthyroidism? Why in hyperthyroidism? Okay. Can hypothyroidism and hyperthyroidism cause hypertension? Can hyperthyroidism and hypothyroidism cause hypertension? Okay, both of them cause hypertension. Hypothyroidism as well as hyperthyroidism, both of them can cause hypertension. But in hyperthyroidism, the systolic blood pressure is the one which is grossly increased. Systolic blood pressure is grossly elevated in hyperthyroidism, and in hypothyroidism, diastolic blood pressure is the one which is increased. So hypothyroid patients have diastolic hypertension, hyperthyroidism have systolic hypertension. So what will happen to the pulse pressure? In hyperthyroidism, right, SBP is increased, diastolic BP is normal, so their pulse pressure is increased. Tushar Bansal, right. So in hyperthyroidism, the pulse pressure is increased. That is why these hyperthyroid patients can have water hammer pulse. They can have water hammer pulse. On the other hand, hypothyroidism they won't have because they have a narrow pulse pressure. Their systolic BP is normal, diastolic BP is increased. So systole is remaining same, diastolic is much coming closer to the systolic. So they have a narrow pulse pressure. They have narrow pulse pressure. So you won't see them presenting with water hammer pulse. Okay, cool. Now let's move to the next question. Very simple question. Based on the ABG report with findings of pH 7.3, bicarb 10 and PaCO2 or PCO2 30 millimeters of mercury, partially compensated metabolic acidosis was detected in a patient. The mechanism of secondary disorder is, so you have a ABG, we should dissect the ABG, and then they have told the diagnosis, it is partially compensated metabolic acidosis. So we have one primary abnormality, and what is the secondary compensatory mechanism that is happening here? So can anybody answer this? There's a significant lag between me streaming here and coming on the YouTube, right? Like I need to wait quite some time to get your feedback. Okay, let me ask some basic questions. Before we discuss these all compensatory mechanisms and all basic things, okay, let us first analyze this ABG. What is this, right? So in ABG, you have acidosis or alkalosis, and whatever it is, whatever acidosis or alkalosis, you have either metabolic or respiratory, right? So first question whenever we have to address an ABG is to see whether it is acidosis or alkalosis. So that is obviously based on pH, right? So approach to ABG. First point is acidosis versus alkalosis. And for that we are looking at pH, right? So what is the normal pH? The normal pH is 7.35 to 7.45. That's a normal pH. Okay. So if it is less than 7.35, right, we will call it as acidosis. And if it is more than 7.45, we will call it as alkalosis, right? It is as simple as that. Now going back to this patient's ABG, his pH is 7.3. What does that mean? It means there is acidosis. There is acidosis. Okay. The second thing we do after this, confirming whether it is acidosis or alkalosis, the next thing we do is look at whether it is metabolic or respiratory. If it is acidosis, metabolic acidosis or respiratory acidosis. If it is alkalosis, metabolic alkalosis or respiratory alkalosis. So for that, what we need to do, we look at the PCO2 or carbon dioxide. Right? That's a normal approach. We look at the PCO2. Okay. And you might be familiar with the mnemonic that everyone uses. Right? PCO2. All we have to see is the direction of the pH and the direction of PCO2. Right? When you're looking at PCO2, I'm just making a table here. pH and PCO2. Okay. A condition where pH is going above normal, going high, and PCO2 also going high in one direction, right? The second possibility is pH is going down, PCO2 is also gone down. The other possibility is pH has gone up, PCO2 has gone down, or pH has gone down and PCO2 has gone up. These are the four possibilities, right? Okay, among these four possibilities, we have all the diagnosis of ABG incorporated. Okay, can you guys answer me what are these findings? Like, let me go through one by one. Okay, what is the first finding? First scenario. You might remember this mnemonic, right? Respiratory, opposite, metabolic, equal, or metabolic, same. During my UG days when we were preparing for entrance, there used to be books called ROMS, Review of All Medical Subjects, and we used to use that as a mnemonic. ROMS, respiratory, opposite, metabolic, same side. Okay, so now that means if pH and PCO2 are going in different directions, opposite directions, it is a respiratory anomaly. If the pH and PCO2 are going in the same direction, it is a metabolic anomaly. So what is happening in the first scenario? pH and PCO2 are going in the same direction. So is it respiratory or metabolic? They are in the same direction. So it is metabolic. So first point is it is metabolic. And what is the anomaly? pH is more than normal, right? More than normal. More than normal means it is alkalosis. It is alkalosis. So we will call it as metabolic alkalosis. The second scenario, again pH and PCO2 are in the same direction. Both are going down or lower than normal. So pH going low means acidosis, right? And because both are in the same direction, this is also metabolic and it is acidosis, metabolic acidosis. Now coming to the remaining two spectrum, both of them are going in the opposite directions, right? Both the scenario 3 and scenario 4, they are going in the opposite direction. So both of them are going to be respiratory. Both of them are going to be respiratory. In the scenario 3, pH is more than normal, So it is alkalosis. So scenario 3 is respiratory alkalosis. Scenario 4, pH is less than normal. So that means it is acidosis. Acidosis. Okay. This much is very much clear to us, right? ओके मैं कोशिश करता हूँ जब भी हिंदी आ सकती है मेरे से. सो लेट अस डाइसेक्ट दिस एबीजी फर्स्ट. सो वी आर लुकिंग एट पीएच. पीएच इज लेस देन नॉर्मल, डिक्रीज्ड, राइट? सो दैट मीन्स वी आर डीलिंग विथ acidosis. We are dealing with acidosis. Second thing is we are looking at PCO2. What is the normal PaCO2? The normal PaCO2 is 35 to 45 millimeters of mercury. This is also very easy to remember क्योंकि the pH range is also same, 7.35 to 7.45, 35 to 45 is the normal CO2 range, PaCO2 range. So what is happening with the PCO2 here? PCO2 is decreased, right? PCO2 is decreased. That means both of them are in the same direction. So when they are in the same direction, what do we call it as? Metabolic. ROMs. Respiratory opposite, metabolic same. So they are in the same direction. So whatever it is metabolic. Right? So what are we dealing with here? We are dealing with metabolic acidosis. We are dealing with metabolic acidosis. So they have already given the diagnosis, but we learn to dissect it. Metabolic acidosis. Now, what is the compensation that metabolic acidosis expects? When you have a metabolic acidosis, respiratory system compensates. When you have a respiratory anomaly, the metabolic system or kidneys compensate. That is a basic thing, right? We know that. Okay, so if you have metabolic acidosis, the respiratory system should compensate. How can it compensate? How can it compensate? Okay, whatever the compensatory mechanism is, has to be opposite of it, right? It cannot compensate by creating respiratory acidosis. If you have a metabolic acidosis, it can only compensate by respiratory alkalosis. If you have a metabolic alkalosis, the respiratory system can compensate by inducing respiratory acidosis. That's how the pH is compensated. Ultimately, goal is to compensate the pH, right? Okay, so we have agreed that this is metabolic acidosis. Okay, and that means only the respiratory system can compensate, not the system or the metabolic system. So kidneys are not going to play a role here in case of metabolic acidosis. So kidney thing is something that we can rule out because one system compensates for other. If you have a respiratory pathology, right, you have respiratory acidosis, then kidneys can compensate. So increased tubular absorption of bicarbonate or increased excretion of H plus are ruled out. We are only dealing with a respiratory system compensating for a metabolic system. In what way it can compensate? It has to cause alkalosis. Alkalosis can happen when you drain out more carbon dioxide. So you have to cause hyperventilation, right? So that becomes a correct answer. Hyperventilation is the expectation from the respiratory system, and it is very easy to pick up, right? You go to what? You remember diabetic ketoacidosis? Diabetic ketoacidosis is a typical example of metabolic acidosis. And see the patients. The patients are they are hyperventilating already when you go and see them. Patients with sepsis, they will be in metabolic acidosis. They will be tachypneic. All the tachypnea is because they are hyperventilating to compensate for the metabolic acidosis. So that is our correct answer. Hypoventilation can't be the answer because if you are hypoventilating, you are not able to wash out carbon dioxide well. So you are actually creating a respiratory acidosis. You have already metabolic acidosis, add respiratory acidosis, it is hell. That is not how body compensates, right? Okay, so this is a correct answer. Now let me give you a slight challenge. Okay, the challenge is I'll give you a scenario. Okay, the same patient, same ABG, similar ABG. Okay, pH of the patient's ABG is 7.38. Okay, and his bicarbonate is same as this 10. His PCO2 is also same as that 30. Okay, now tell me what is this ABG abnormality? Is this a normal ABG? Because the pH is 7.38. Normal range of pH is 7.35 to 7.45. So will you call this as normal ABG? Or it is abnormal? What is it? Is this a normal ABG or it is abnormal? Is it normal or abnormal? Okay, I'm waiting for your response because pH तो लगता है normal है, right? 7.35 to 7.45 is a normal pH, but pH तो normal range में है. Yes, that's the point, right? So when metabolic system is deranged, the respiratory system puts an effort to get the pH back to normal, or when the respiratory system is deranged, the kidneys and the metabolic system tries to put an effort to get the pH back to normal, right? Did you hear this term here? Partially compensated. So compensatory mechanism is almost always triggered. Respiratory system is not going to keep quiet when you have metabolic acidosis. It will try to create a respiratory alkalosis so that the pH is set back to normalcy. When the pH is put back to normalcy, it is called as fully compensated ABG. Okay. When the pH is not back to normal range, despite the opposite system's efforts, we call it as partially compensated. So in this case, the pH remains 7.3 despite CO2 washout. Patient is hyperventilating, he is washing out carbon dioxide, but pH is not back to normal. That is why we called it as partially compensated. If the effort puts the pH back to normalcy, it is called as fully compensated. Okay, now then is the question. Then how do I get to know whether the patient is having acidosis or alkalosis? pH तो normal range में है. Right? How do I get to know that whether patient has acidosis or alkalosis? How? Okay, so please remember, every time you have a ABG in front of you, not only look at the pH. pH may be normal because of the compensation. If it is fully compensated ABG, pH will be normal, in the normal range. Okay, but also see the bicarb and PCO2 level. pH 7.38 looks normal, but bicarb, is it normal? No, it is low. PCO2, is it normal? No, it is low. So it is still an abnormal ABG even when the pH is normal. So normal pH, do not discard the ABG as normal. Always read bicarb and PCO2. If there is abnormality underneath this, it is still an abnormal ABG and you need to make an attempt to diagnose what is it. Okay, and to diagnose what is it, I am making one important statement for you to remember. The statement is, the compensatory mechanisms never overcorrect. Compensatory mechanisms never overcorrect. What do I mean by that? In this ABG, we had metabolic acidosis. So patient will develop respiratory alkalosis as a compensatory mechanism. But this respiratory alkalosis will only work to an extent that the pH is somehow pushed back to the normal range. It will never take it to the other side. Right? The pH of 7.3 by the compensatory mechanism will not become 7.45, 7.5 and all. It will never overcompensate. Just jitna chahiye utna. As soon as it pushes it back to the normal range, the compensatory mechanism restricts itself there. Right? It will never overcorrect. That's the first point we have to remember. And the second point, we have to take a reference point in such ABGs to dissect whether it is acidosis or alkalosis. And the reference point is, reference point for pH is 7.4. Okay, if it is a compensated ABG where the pH is within the normal range of 7.35 to 4.5, then you will see whether it is less than 7.4 or more than 7.4. If it is less than 7.4, such a ABG, you will call it as acidosis, and then depending on the direction of PCO2, you will decide whether you will call it as metabolic or respiratory. If it is more than 7.4, you will take it as going towards alkalosis, and then depending on the direction of PCO2, you will decide whether it is metabolic or respiratory. Right? Now in this ABG, because this is less than 7.4, this will be counted as acidosis. That's the point number 1. Now whether this is metabolic or respiratory, I will look at the PCO2. PCO2 is in the direction going down, so both in the same direction. Then I will call it as metabolic acidosis, which is fully compensated. This is a ABG which is fully compensated. Right? I hope you got the gist of it. Fully compensated metabolic acidosis. As the same thing, if I just put the pH of this patient as, let me say, 7.42. Now what is this ABG? 7.42. It is alkalosis. Then it will be called as alkalosis because it is more than 7.4. ABG to abnormal hai because these values are not normal. I will call this as alkalosis. 7.4 is my reference point here. Okay. Then I will look at PCO2. pH is going up, PCO2 is going down. So they are in the opposite direction. So then what it will become? Respiratory. So this ABG now becomes respiratory alkalosis, which is fully compensated. Because pH is in the normal range, right? Okay, that's how we generally dissect the ABGs. Okay, so the answer for this is hyperventilation causing increased CO2 washout. Okay, now moving to the next question. Pituitary apoplexy presents with hypertension, fatigue, unconsciousness, or shock. Pituitary apoplexy presents with. Pituitary apoplexy, what does it mean? It means a acute or hyperacute vascular insult to the pituitary. There can be sudden hemorrhage into the pituitary or sudden ischemia of the pituitary causing pituitary dysfunction, right? Most commonly it is the hemorrhage into the pituitary that happens. That's what we call as pituitary apoplexy. So in what way these patients are going to present? Uprising, at least we'll try to finish till 50th question today, and then we will do one more session to do another 30-40 questions. Okay, what are the important hormones produced by pituitary? Pituitary hormones. When suddenly there is bleeding into the pituitary, its ability to produce these hormones is going to go down. So we have to know what are the hormones it is going to produce. So number one it produces is growth hormone. Second, it produces prolactin, right? Third, it produces, Sheehan syndrome is one example for pituitary apoplexy. There can be other causes also. Postpartum hemorrhage. Apart from that, there can be other causes. Anything, sudden vascular event affecting the pituitary function, mostly hemorrhage. Okay, growth hormone, prolactin, TSH, then FSH and LH, or in other words, gonadotropins, right? And ACTH. Have I missed anything? Okay, so these are the hormones that is produced by the anterior pituitary, right? And what are the hormones produced by the posterior pituitary? We have oxytocin and vasopressin. These are produced by the posterior pituitary. Okay. Now, if I suddenly stop growth hormone secretion, will it have any impact on the hemodynamics of the patient? No, right? What growth hormone does? Yesterday also we discussed. Growth hormone helps you in linear growth before the fusion of epiphyses. After that, helps you in maintenance of muscle mass and keeping the fat mass less. That's the growth hormone's job. If suddenly I'm taking off growth hormone, it's not going to have any impact on the hemodynamics. Okay. Growth hormone deficiency can cause fatigue. Fatigue is the commonest presenting symptom of adult growth hormone deficiency. Before the fusion of epiphyses, if the growth hormone deficiency is there is stunting of growth, right? That is easy. In adults, it's very difficult because they just present with fatigue. Their muscle mass is less, fat mass is more, they experience fatigue. But will it be a immediate feature? No, like whatever growth hormone there is already in circulation and all, it will be used for some time. So it's not like an acute presentation. So fatigue, I won't be thinking of as a presenting feature of pituitary apoplexy. Growth hormone can be affected in the pituitary apoplexy, but weeks later its manifestations will be evident. Prolactin deficiency. What is the symptom of prolactin deficiency? There is no known manifestation of prolactin deficiency. Prolactin excess we know, right? It causes galactorrhea. Galactorrhea, amenorrhea, the typical presentation of prolactinoma. Galactorrhea, amenorrhea, and bitemporal hemianopia. But there is no known manifestation of prolactin deficiency. There are some proofs to say that prolactin plays a role in immune system, but if there is no prolactin, nothing will happen. Only, there is one known manifestation of prolactin deficiency, that is lactation failure in women. So they will not be able to lactate. They can conceive, all that things can happen if you manage it well, but they will not be able to lactate. Other than that, there is no other known manifestation. So I will not be thinking of that as a presenting feature, right? Okay. TSH deficiency. That will cause thyroid hormone dysfunction. But again, for the thyroid hormone to respond by reduced production, and for us to start seeing the symptoms of thyroid hormone deficiency, that is hypothyroidism, it's going to take several weeks. That's not going to be the presenting feature of pituitary apoplexy, which is an emergent acute presentation, right? FSH LH levels can also go down, so that can cause in a male hypoandrogenism. In females also it can disturb, but those are mostly to do with the menses, and those are mostly to do with the sexual function in a male, not an acute thing that these patients will present with, right? Okay. Apoplexy means a vascular insult. Vascular insult. Apoplexy is the literal word for a vascular insult. Okay. ACTH deficiency. When ACTH goes low, right? What are the hormones that ACTH stimulates? ACTH stimulates what hormone production? Number one, it stimulates cortisol. It stimulates cortisol production, right? Number two, does it stimulate any other hormone production? Any other hormone production? Will it stimulate mineralocorticoid production? Actually, ACTH can stimulate all three layers of the adrenal cortex, not the medulla, but the cortex. It can stimulate. That's why the name is adrenocorticotropic hormone. We don't call it as adrenocortisol or the cortisol-tropic hormone or something like that, right? We call it as adrenocorticotropic hormone. It can stimulate all three layers of the adrenal cortex. So it can stimulate production of mineralocorticoids. And adrenal glands also produces androgens, right? Testosterone and dihydrotestosterone is not the only androgen in human body. There is also a androgen called as DHEA, which is produced by adrenal glands. So they are called as adrenal androgens. So it stimulates production of all of these, right? And if there is decrease in ACTH, all of these levels can go low. All of these levels can go low. Okay. Similarly, if the posterior pituitary is affected, oxytocin, love hormone, right? Like, okay, forget about lactation or its role in females. In males, it is only restricted to feelings towards the opposite gender. It's believed to be playing a role in feelings towards opposite gender, nothing more than that. But vasopressin, it regulates serum osmolarity, it regulates blood pressure. It has some role in regulation of blood pressure. Not the predominant role, but it has some role. So now imagine a circumstance where vasopressin has gone down. Cortisol plays a very important role in regulation of blood pressure. Mineralocorticoids play a very, very important role in regulation of blood pressure, right? So all of these have gone down. What will happen to such patient? Suddenly ACTH has gone down, so suddenly cortisol is dropping, mineralocorticoids are dropping, vasopressin is dropping. So what will happen to the patient? What will happen to the patient? So will he present with hypertension? Absolutely no. Hypertension ka chance ही नहीं है. You have to struggle a lot to increase this patient BP. Mostly these patients present with shock because the hormones required for a sustenance of BP are gone down. So they present with shock, right? We need to do a cortisol we need to give cortisol or the hydrocortisone along with fluids and inotropic support to maintain this patient BP. Okay, so shock is the presenting feature of pituitary apoplexy, or you call it Sheehan syndrome, one of the examples for pituitary apoplexy. Those patients also present with shock. Once you handle the initial shock and they are on the cortisol and mineralocorticoid replacement, during later follow-up, depending on what are the areas of the pituitary where the hemorrhage had occurred, they may present with other hormone deficiency. The other hormones will start becoming evident later. Growth hormone deficiency, TSH deficiency, they will start becoming evident later. But in the acute stage, it is the shock that brings them to the hospital. Okay. If the apoplexy is restricted to pituitary, they are not going to go unconscious because the consciousness is not the function of the pituitary gland, right? It is your reticular activating system, frontal lobe. Those are the determinants of consciousness. So if there is a massive injury to the pituitary plus the cerebral cortex, you can lose consciousness. Just the pituitary being affected, you will not lose consciousness. The shock might lead to hypoperfusion of the brain and then you might lose consciousness, but that is a consequence. So shock is the first thing that happens. If there is loss of consciousness in a patient with pituitary apoplexy, there are only two possibilities. Either the shock has led to hypoperfusion of the brain and that has led to unconsciousness, or along with the injury to the pituitary, there was also injury to the cortex. Isolated injury to the pituitary without the hypoperfusion of the brain will not cause unconsciousness. So that is why option D becomes our right choice. Okay. Now moving to the next question. Following a trauma, an adult man was brought to the emergency department with respiratory distress and hypotension. Straightforward question. I'm not going to waste much time here. So he is presented with respiratory distress and hypotension, right? Whenever you read this sentence, you already know the diagnosis. Okay. On examination, there is subcutaneous emphysema. Now they are making the diagnosis much more clear. And absence of air entry into the right side of the lung. Patient should be managed by start IV fluids with large bore cannula, start positive pressure ventilation, take the patient to the ICU and intubate him, needle decompression into the fifth intercostal space anterior to mid-axillary line. Limo, I think so far we have not encountered any seizure related question. As we encounter, we'll discuss about it. Okay, so what is the story talking about? There is trauma. After that, patient has developed respiratory distress. Okay, after a trauma, if the patient is developing respiratory distress, only 2-3 possibilities, right? One, there is a direct trauma to the chest, rib fractures, he has developed a pneumothorax, or the contusion of the lung, or hemothorax. Those are the possibilities. The other possibility is that there is a fracture of the bone and it has caused fat embolism. That is a possibility, right? A third possibility is there is trauma, immobilization of a limb, he has developed a DVT and it has caused pulmonary embolism. Right. Fourth possibility is that after the trauma, maybe there was head injury, he has gone unresponsive, he has aspirated and developed aspiration pneumonia. These are the 4 or 5 scenarios which happen why a patient post trauma develops respiratory distress. And in an exam scenario, first thing we will think of is direct injury to the lung. Otherwise, they have to build up more scenario to make us think of other possibilities. Right. Now here they are telling that patient has developed hypotension. They're also telling that there is subcutaneous emphysema. It points towards that there was direct injury to the chest, there was rib fracture, the ribs have gone and hit the lungs, from there air is leaking, that is how it is making its way into the subcutaneous plane. So that it is telling that there is rib fracture. And when there is rib fracture and there is subcutaneous emphysema, there will be probably pneumothorax. And he is also telling that there is absence of air entry. So that means, like, see what happens in pneumothorax. As the pneumothorax, as the air is accumulating between the pleura and the lung, or in other words, the parietal pleura and the visceral pleura, right? The air is accumulating more and more and the lung is getting collapsed. So the air entry on that affected side is getting reduced. So all of that fits into pneumothorax. And because this patient has hypotension, I all the more believe that it is tension pneumothorax. If I had given the normal blood pressure, then as of now, I wouldn't be thinking of tension pneumothorax. And because they're telling that this patient is having hypotension, this prompts me to think that this is tension pneumothorax. So the diagnosis is clear. This is a case of tension pneumothorax. So how do we treat a tension pneumothorax? Okay. The point number 1 or the question is, should we? Okay, tension pneumothorax, the clinical clue is deteriorating hemodynamics. Because as the lung is, as the hemithorax is expanding by air accumulation, mediastinum is getting shifted outwards, this lung is getting collapsed, and blood flow to the heart, venous return to the heart is getting reduced because the intrathoracic pressure is building. As the heart is getting less and less blood, the cardiac output keeps dropping down, he is getting hemodynamically compromised, right? Every time a question talks about the patient having significantly compromised hemodynamics with respiratory distress and the scenario is about the pneumothorax, right? We have to consider this as a possible tension pneumothorax. On the imaging, yeah, you will see that it is a massive pneumothorax and the mediastinum is shifted. If you don't want to act and you want a very objective evidence that this is tension pneumothorax, then you can do interval imaging where you will notice that the pneumothorax is expanding. Because there is no escape from the air out, there is only inlet of air into the pleural space and it is not escaping out. Pneumothorax, do a x-ray now, 5 minutes later do one more x-ray, it has increased significantly in size because those 5 minutes, whatever extra breaths, it has worsened, right? We don't wait for all of that. If there is hemodynamically unstable and there is a gross pneumothorax, we will practically take it as tension pneumothorax, needle, push it. Okay, so the answer here is very simple and straightforward. We are going for a needle decompression into the fifth intercostal space in the anterior mid-axillary line. Okay. Now let's go to the next question. All of the following conditions are false about polyarteritis nodosa except PAN. Polyarteritis nodosa except. Okay, please pay attention to the question. It is asking all of the following conditions are false except. That means you have to pick up one which is a true statement. which is a true statement. Suresh Mehta, yeah, it can be a possibility. Hemothorax can be a possibility with such a presentation. Okay, so the definite management also takes into account imaging. We just don't do like that, and examination will give us a lot of clue, right? If it is hemothorax when you're examining, right? Even if I cannot get access to an X-ray, or patient is so unstable that I cannot wait for an X-ray in the emergency room when someone is presented with trauma followed by that hemodynamic compromise and respiratory distress, I can percuss for sure. If it is hemothorax, what note I will be getting there? I'll be getting a very dull note, right? And if it is pneumothorax, what note I'll be getting there? I'll be getting a hyper resonant note. It is not going to be very difficult for me to make a distinction between hemothorax versus pneumothorax bedside. I don't need to visit a X-ray. But in this question, they've not given that information, right? Sometimes when the questions are constructed, all the information like a proper case history is not given to us, so we have to make some assumptions. And subcutaneous emphysema is another pointer, right? For subcutaneous emphysema to occur from the lungs, air has to reach the subcutaneous plane. That is only possible when the pleura is ruptured, lung is injured, and there is also communication between the pleural space to the subcutaneous space. That can only happen when there is a rib fracture, right? So all that makes me think that it is more of pneumothorax, and I'm considering it as tension pneumothorax in that question because of the hemodynamic instability that patient has. Okay, polyarteritis nodosa. Let us understand some things about polyarteritis nodosa. Okay, what is polyarteritis nodosa? It is a vasculitis, right? It is a vasculitis. Okay, generally vasculitis is classified into small, medium and large vessel vasculitis, and there is a name for this classification system, right? What is the name? What is the name of the vasculitis classification system? Name of the vasculitis classification system. The name of the vasculitis classification system is Chapel Hill classification. Chapel Hill classification. So Chapel Hill is a place where all these vasculitis experts convened and came out with a classification system. Chapel Hill classification. Based on this Chapel Hill classification, we classify the vasculitis into small vessel, medium vessel and large vessel. There are further detailed classification. Broadly speaking, small vessel, medium vessel and large vessel. Large vessel vasculitis. Okay, so now the polyarteritis nodosa is one of the vasculitis. It belongs to small vessel vasculitis or medium vessel vasculitis or large vessel vasculitis. Chapel Hill, right? Mnemonic only, right? So polyarteritis nodosa is a small vessel vasculitis or medium vessel vasculitis or large vessel vasculitis. Right, it is considered under medium vessel vasculitis. It's a medium vessel vasculitis. Okay. Mostly the vasculitic phenomena are autoimmune, so there is some role involved of immune system. Okay, but as a rough rule, remember that ANCA associated vasculitis are mostly small vessel vasculitis. Right? Typically PAN, you don't see them to have ANCA association. Okay, typically PAN, you don't see them to have ANCA association. Okay, that's one point. Now let us go back to option A. Is it a true option? Is it a true statement or is it false statement? Necrotizing inflammation of the large vessel. PAN is a medium vessel vasculitis. So this is a false statement. Okay. In PAN, you have necrotizing inflammation. You have necrotizing inflammation without granuloma formation. Because there are some vasculitis where you can have granuloma formation, like EGPA, eosinophilic granulomatosis with polyangiitis. So there can be some vasculitis where granuloma formation would be there. Necrotization and inflammation are standard features of all these immune vasculitis, right? Here there is no granuloma formation. The reason I'm emphasizing this is a similar question might come where they might ask you, or there may be a statement where it shows that necrotizing inflammation with granuloma of medium vessel, right? You're tricked there. because you know medium vessel, you know that necrosis occurs, necrotizing inflammation occurs, but you're not sure whether granuloma occurs or not, and we might go wrong there, right? So there is no granuloma formation. Okay, then pan has two types. Pan can be classified into two types as primary and secondary. Primary and secondary. Okay. Primary is because of the mutation in a gene called as ADA2, or the gene is also called as SERC1. Mutation in this gene can lead to primary polyarthritis nodosa. Secondary polyarthritis nodosa is most commonly associated with HBS or hepatitis B infection. Hepatitis B virus infection. Hepatitis B virus infection. Okay. Why hepatitis B virus infection causes polyarthritis nodosa? If you go back to the hepatitis B management, right? Now we make few statements like we start antivirals when these particular parameters are met, like hepatitis B viral DNA should be this much, the ALT level should be more than 2 times the upper limit of normal, or there should be biopsy evidence of fibrosis and necroinflammation on the liver. Then we start antivirals in HBV. We don't start antivirals in all HBsAg positive patients. There are selected parameters. Okay. One of the parameters is if there is extra hepatic manifestation of hepatitis B virus infection, we start antivirals. Even if the LFT is normal, we start antivirals. And one of that extra hepatic manifestation is polyarthritis nodosa. Why this is a manifestation of HBV? See, what happens in hepatitis B is you have HBsAg. That is an antigen from the hepatitis B virus. Antibodies are formed against it. They form the complexes. Right? This antigen antibody complex, they're produced in large numbers, so our complement system is not able to clear it. So what is the fate of these antibodies? The antibody antigen complexes, or what you call as immune complexes, they get deposited in different tissues. One of that can be blood vessel. So deposition of this HBsAg antigen plus the body produced antibodies, anti-HBs antibodies, this combination, immune complexes, they get deposited in the vessels, leading to polyarthritis nodosa. So it is an immune complex deposition. Immune complex deposition is what is happening there. So why we give antivirals? We give antivirals because if you give antivirals and reduce the hepatitis B virus population, that means the HBsAg antigen is reduced. Antigen reduced means antibody reduced. So immune complex is reduced, vessel injury reduced. That is why we use antivirals, even if the LFT is fine, as long as they have extra hepatic manifestations. Majority of the extra hepatic manifestations of hepatitis B are because of this HBsAg anti-HBs immune complex deposition. Okay. Can polyarthritis nodosa occur with hepatitis C infection? The answer is yes. You can have with hepatitis C infection also. Okay. But hepatitis C infection most likely causes cryoglobulinemia rather than polyarthritis nodosa, or cryoglobulinic vasculitis rather than the polyarthritis nodosa. Similarly, hepatitis B can also cause cryoglobulinic vasculitis, but most commonly it causes polyarthritis nodosa, right? So secondary, most commonly it is caused by HBV infection. Okay, I hope that point is clear. Now, the additional points that you need to know is, we know it is medium vessel vasculitis, necrotizing inflammation without formation of granuloma. So medium-sized vessels are being targeted. It can be either because of hepatitis B or primarily because of the SERC1 mutation. What vessels are most commonly affected, right? So two important MCQs. The most commonly affected artery is renal artery. Renal artery. Okay. And there was one question in one of the NEET PG exams, which artery is spared in case of polyarthritis nodosa. So that is a pulmonary artery. Pulmonary artery is spared in case of the polyarthritis nodosa. It doesn't get affected. Renal artery and other small sized arteries get affected, right? And the involvement of renal artery, how does it manifest? You will see development of aneurysms. You will see development of aneurysms, especially at the bifurcations of arteries. Like there is a renal artery, it starts giving out branches, right? All those bifurcation areas, you will start seeing aneurysms. Aneurysms at bifurcation of vessels. So sometimes you may get an image based question. So please Google out after the session about polyarteritis nodosa angiogram. Just put these keywords polyarteritis nodosa and angiogram. You will get some 2-3 images. Mostly all of them are renal angiogram, kidney, blood vessel showing all these bead like appearance on the blood vessels, which are nothing but aneurysms. Okay. So now let's go back to the question. Necrotizing inflammation of the large vessels is a false statement. Right? I'll come back to option B later. 90% associated with ANCA positivity is a false statement. Right? Typically, PAN is not associated with ANCA positivity. Mostly it is the small muscle vasculitis which is associated with ANCA positivity. Some patients with PAN might have ANCA positivity, and what has been observed is that if it is a PAN and they have ANCA positivity, later they get additional ANCA vasculitis diagnosed. Like right now they may not meet the criteria, only PAN criteria they meet, but later they might meet the criteria for EGPA or other small vessel vasculitis. But typically just ANCA and staying with PAN as a diagnosis is unlikely to occur. So this is also a false statement. Okay, now I have confusion between B and D, and I'm leaving you also a bit confused between the B and D. There are some reasons. Okay, now hepatitis B untreated, 30% of the patients with hepatitis B active infection where there is viral replication untreated, they have polyarteritis nodosa. This statement doesn't make exactly same statement, right? What I said, 30% of untreated hepatitis B patients with active infection have polyarteritis nodosa. I did not say that the 30% of patients of the polyarteritis nodosa are because of hepatitis B, right? Okay, and the other point we need to remember is the primary polyarteritis nodosa with ADA mutation or SERC mutation, right? These patients have hypogammaglobulinemia. They have hypogammaglobulinemia. In addition to polyarteritis nodosa, they also have hypogammaglobulinemia. On the other hand, the secondary patients do not have. Hypogammaglobulinemia. They can develop hypogammaglobulinemia if there is increased immune complex deposition. All these immune complexes are globulins, right? Gamma globulins. They are being cleared for the deposition, so the gamma globulin level can go low. So to me, right now, these two statements are making sense. This is a statement which is making sense. In the larger context, it is true, and this statement needs to be taken with a pinch of salt whether it exactly makes the sense. So these two are possibilities. I'll give you a little more clarity after I study about the recent literature about the prevalence of hepatitis B and the polyarteritis nodosa. But this is definitely a true statement. In the primary, there is hypogammaglobulinemia. In the secondary, as more and more immune complexes get deposited, gamma globulin level can go low. So that is certainly a true statement. Okay, whether the statement B is perfectly true in terms of epidemiology, we need to confirm. There is association between hepatitis B and polyarteritis nodosa beyond any doubt, that's for sure. Okay, so I'll give you more clarity when I get little published literature of recent thing. These are important MCQ point. Renal artery is the most commonly involved artery, and the artery that is spared is pulmonary artery. Multiple times INICET and NEET PG, this question is asked: which of the following artery is not involved in polyarteritis nodosa? Very important MCQ point. Right, so please remember that pulmonary artery is spared in patients with polyarteritis nodosa. Okay, now moving to the next question. Lesions of the posterior part of superior temporal gyrus present with fluent aphasia, non-fluent aphasia, fluent aphasia, anomic aphasia, or conduction aphasia. We're talking about superior temporal gyrus. They are going to present with which of the following? Okay, we know about two important speech areas, right? The Broca's area and Wernicke's area. So where is Broca's area located? Broca's area, where is it located? Where is Broca's area located? Which lobe? Just tell me which lobe. Frontal lobe, temporal lobe, parietal lobe, occipital lobe. And where is Wernicke's located? Yeah, so broadly speaking, it is in the frontal lobe, right? Frontal lobe. And Wernicke's is in the temporal lobe. That's the basic thing we know, right? So you're clear. This is where is your Broca's speech area present, right? Frontal lobe, inferior frontal gyrus, right? And the temporal lobe, the posterior aspect, is where you're seeing the Wernicke's area, right? This is where the Wernicke's area present. Superior temporal gyrus, posterior part of it. This is where is your Wernicke's area present. So in this question, what are they talking about? Superior temporal gyrus. This is our superior temporal gyrus, right? This is our superior temporal gyrus. And they're talking about its posterior part. So they are obviously talking about this area, which is Wernicke's, right? So we are talking about Wernicke's area here. So Wernicke's area, if there is a lesion, it will cause fluent aphasia or non-fluent aphasia, or anomic aphasia or conduction aphasia. Okay. Now I'll give you a scenario. So here is a patient who has difficulty in producing words. He's like, sir, I have problem in talking about myself. Okay, he's talking like this. You ask him, what did you have for lunch? I had rice. He's able to tell this. Okay. And you ask him more questions. He's coming out with single word answer. Like, how is your day going? Good. Does he have Broca's aphasia or Wernicke's aphasia? Whatever scenario I told. See, what does this word fluent mean? Fluency. What is fluency? Right? You in layman term we say, right? Like he speaks fluent English. या he speaks fluent Hindi. उसकी हिंदी इतनी fluent है, उसकी English इतनी fluent है. So what is fluency? What is fluency? Fluency is your ability to make a quick transition from one word to other word without breaking. Right? So if I am talking about a subject without struggling to move from one word to other word, that means I'm fluent in it. You're talking to me in English without struggling to find the next word, like as if it is like a chain of events. Smoothly you're making a transition from word to word. That is fluency. When you have a speech which is broken by unnecessary pauses, like I say something, then I'm struggling to produce the next letter or next word, that is non-fluent. Right? The commonly non-fluent English, you know, like how do they speak? That is non-fluent. Okay. So whenever we assess speech, we are assessing speech in 4 important domains. Speech assessment will happen in 4 domains. What are the important domains of speech that we are assessing? Number 1, we are looking at fluency. Right? Fluency. Second, fluency, or you can also say word output. Second thing, we are looking at comprehension. Comprehension. Third thing we are looking at is naming. And fourth thing we are looking at is repetition. These are the 4 domains that we will look whenever we assess speech. Even if they give you a complex speech related question, it is very easy to answer it if you know these 4 domains. Okay, 4 domains. Fluency. Fluency is basically assessed in the question by 2 things. Either they will tell that patient is talking excessively and he is fluent, they will directly tell, or they will tell that he is not fluent, or they will tell that his speech is characterized by unnecessary pauses, or they will also use a term reduced word output. See, if I am fluent, I'll talk more, right? If I know this language very well, you question me something on that language, I'll talk more. I will not restrict myself. When I know that I have struggle, right, that is where I will restrict my words. So increased word output in the question means that there is increased fluency. If the question says reduced word output, that means like patient is giving one word answers to lengthy questions. How did you travel to Bangalore? Train. Or otherwise, hyperfluent speech will be like, no, I took a cab to my station. From there, I took a flight till here. and then I again took a cab, and then I took a metro train, and I have landed here. This is hyperfluent speech. How did you travel to Bangalore from Delhi? Train. This is reduced word output, right? Decreased fluency. Second thing they will say is broken or struggling production of words. That is again suggesting of decreased fluency. Okay, that is one thing that question talks about. Second thing, it talks about comprehension. How do we get to know? Patient is responding appropriately to verbal commands. That means comprehension is preserved. Patient's response to the commands is inappropriate. That means comprehension is affected. You ask him, where did you go this morning? I went to auditorium, or like auditorium. Comprehension is present. Where did you go this morning? I had been there, and then he saw me. I went to him. That means this patient comprehension is affected. He didn't understood what you told, right? That is the second domain that we will be assessing. After this, after the fluency and comprehension is assessed, we will ask him to name known objects. If he is able to name known objects, that means comprehension is preserved. That means the naming is preserved, sorry. But again, please don't challenge him by giving him a vernier caliper or some speculum and ask him. For a layman, you can't pick up your medical instruments, give him Welch-Allyn otoscope and tell him to name it. No, wo nahi chalega. Give him known object, give him a pen, give him a spoon, right? Give him a soap and ask him to name. He should be able to name it. If he's not able to name it, that is a defect. Okay. After that, ask him to repeat after you. Say pen. He should also be able to say pen. Right? If you ask me to repeat anything, I will repeat as long as it is in my known language. अगर आप जापानीज में कुछ बोलोगे, I will not be able to repeat. But हिंदी में बोलो, मराठी में बोलो, कन्नड़ा, English, Urdu, Tamil, Malayalam, I'll be able to repeat it because it makes sense to me. Right? These 4 domains we will assess. Now the outcome of it at the end of it, all 4 domains may be affected or only some may be affected. Right? So let me say scenario 1. 4 out of the 4 domains are affected. What do we call that scenario? Patient's fluency is gone. He is struggling to produce word. Neither he is able to understand what you are telling. Comprehension is also gone. He can't name the objects. He can't repeat the words. All 4 are gone. What do we call that as? We call that as global aphasia. That is global aphasia. Okay. Next possibility is 3 out of these 4 domains are affected. 3 out of these 4 domains are affected. Okay, so that means one domain is preserved. Okay, so let me say scenario 1. Fluency is affected, right? Fluency is gone down. Comprehension is normal. Naming and repetition. Remember, they are almost always affected in most of the speech abnormalities. Naming and repetition is affected. Arshad, okay, yeah, I'll rush through. So naming and repetition are affected. Only fluency is the one, comprehension is the one which is preserved. Now what kind of aphasia it is? That is one scenario. Second scenario is fluency is normal, naming and repetition are affected, and comprehension is affected. The first scenario is fluency has gone down, right? That means it is motor, right? That means it is motor or it is Broca's aphasia. Comprehension is normal. Patient can understand but cannot produce words. Naming and repetition are gone. It is Broca's. And what happens in Varney case? In Varney case, his comprehension is gone. He is not able to understand what you say. But his fluency is good. Sometimes it is hyperfluent. Whether it makes sense to you or me doesn't matter. He'll keep talking. But you ask something, he's not able to understand. That is Varney case. Okay. Then you have another scenario where 2 out of these 4 domains are affected. That is, naming and repetition are affected. Fluency is normal, comprehension is normal. So this patient talks fluently, he understands whatever you tell him, but he can't name objects, he can't repeat words. What we call this as? We call that as conduction aphasia. We call this as conduction aphasia. Clear? Okay. So in Varney case, fluency is normal or increased. Fluency is normal or increased. Comprehension is the one that has gone down. So Wernicke's aphasia can be said that it is fluent aphasia or hyperfluent aphasia. So now going back to the question, what is going to be our answer? Conduction aphasia, fluency is unaffected. right? And the comprehension is also unaffected. It's only the naming and repetition which are affected. Anomic aphasia, only naming is affected. That's why it's called as anomic. 1 out of the 4 domains affected, right? So non-fluent aphasia is typically Broca's. It is typically Broca's, and fluent aphasia is typically Wernicke's. Wernicke's. So I know Wernicke's is the one which is present in the superior temporal gyrus. So option B is our correct answer, right? Okay. Now we will move to the next question. A 69-year-old. Okay, one more important point. You might have heard about also something called as transcortical motor aphasia or transcortical Wernicke's aphasia, transcortical sensory aphasia, transcortical motor aphasia, or transcortical Broca's aphasia and transcortical Wernicke's aphasia. What do they mean? So we've learned 4 out of 4 affected, that is global aphasia. 3 out of 4 affected, it could be Broca's or Wernicke's. 2 out of 4 affected, that is conduction. 1 out of 4 affected, that can be anomic aphasia, right? That was one of the option. Only naming is affected, usually after head injury. That's the most common speech abnormality after head injury. Important MCQ point. Most common speech abnormality after head injury, that is anomic aphasia. फिल्मों में देखा है ना, हेड इंजरी के बाद फैमिली मेंबर्स को रिकॉग्नाइज नहीं करता है, नाम याद नहीं है, एनोमिक एफेजिया. दैट्स द मोस्ट कॉमन स्पीच abnormality after head injury. Important MCQ point. Okay, you hear this transcortical motor and transcortical sensory aphasia. What is it? Conduction, yes, the region is in the arcuate fasciculus, yes. Okay, so I will leave that small work to you. What is the difference between Broca's and transcortical Broca's? Difference between Wernicke's and transcortical Wernicke's. Okay, anyway, we will address this, in detail about all these aphasias, but it's a small work which you can do after the class. We will move to the next question now. In this question, we have a 69-year-old man who presented with history of progressively worsening dyspnea on exertion. Case of progressive worsening dyspnea on exertion, known diabetic and hypertensive. So he has all the risk factors required for a cardiovascular disease, that I can tell you. He is on regular medications for these problems. Now he has presented with the dyspnea on exertion, right? On examination, his JVP is raised. JVP is raised. He has a positive hepatojugular reflex. He has a positive hepatojugular reflex. Okay. At the base of the lungs, he has crepitations or crackles. So that means there is some amount of fluid in the lungs. He has hepatomegaly. He has ascites. He has pedal edema. Now the question is, what is the provisional diagnosis? Portal hypertension, hypertrophic cardiomyopathy, mitral regurgitation, or heart failure. Okay, now you tell me. Limor, right. So the only difference between the Broca's and Wernicke's, what did I tell you? Broca's and Wernicke's, 3 domains are affected. 1 is paired. In Broca's, conduction, comprehension is paired. In Wernicke's, the fluency is paired, right? The other 3 are affected. Now make repetition preserved. Those becomes the transcortical Broca's and transcortical Wernicke's, or transcortical motor and transcortical sensory. So repetition was affected there. Keep it preserved. It becomes transcortical motor, transcortical sensory. Good, good, good. Good. So it is not just the heart failure. This is right heart failure, right? So what are the manifestations of left heart failure? What are the manifestations of left heart failure? What are the manifestations of left heart failure? See, when the right heart fails, right ventricle's ability to have a good systolic contraction is going down. What will happen? Right atrium finds it very difficult to empty the blood into right ventricle. So right atrial pressure starts going up, right? So then what will happen to the blood that is flowing to the right atrium from the periphery, the one that is coming from superior vena cava to right atrium and the one that is coming from the inferior vena cava to right atrium, they get disturbed, right? The flow gets reduced. So the result of this is superior vena cava, the flow is slowed up, so the JVP starts going up. That leads to increase in the JVP, right? Now the inferior vena cava is closely related to liver. right? And the blood that is flowing from the lower extremities towards the right side of the heart is getting affected. So this can lead to edema, right? Then it can lead to congestive hepatomegaly. The blood is getting congested in the liver because it's not moving towards the right atrium. Congestive hepatomegaly, right? Then eventually it can lead to development of ascites. So all these are features of right heart failure: ascites, hepatojugular reflex, congestive hepatomegaly, peripheral edema or lower limb edema, raised JVP. These are all signs of right heart failure. What are the signs of left heart failure? Yes. So what happens when the left heart fails? Left ventricle is failing, either systolically, it's not able to contract well, or during the diastole, it is not able to relax well. So heart failure on the left side can be classified as systolic and diastolic, or heart failure with reduced ejection fraction and preserved ejection fraction. One of the things is happening. In both cases, the brunt is borne by the left atrium. See, let me say, left ventricle is not able to contract well during systole. It will not empty well, right? It has got, let me say, 100 ml of blood during the diastole. Because its force of contraction is reduced, it will only push out 50 ml. So it is left with 50 ml more before the next cycle. Now what will happen to the left atrium? Because already there is some amount of blood in LV, it finds it more difficult to eject itself into the left ventricle, because left ventricle already has some amount of blood. That's a problem, right? Or it is, let me say, it is diastolic failure. Left ventricle did not relax well during the diastole. Because it is not relaxing well, again left atrium is finding it difficult to put the blood into the left ventricle. So the end result is left atrium is suffering here badly. So pressure in the left atrium is going up. If the pressure in the left atrium is going up, then the pulmonary veins are the ones where the pressure goes up. If the pulmonary veins are getting higher pressure, then the blood flow from pulmonary artery through lungs back to the left atrium is getting affected, right? Because there is slowing of blood flow in the pulmonary veins because left atrial pressure is high. So the lungs are getting congested. So pulmonary congestion is the typical presenting feature of left heart failure. Eventually it will develop pulmonary edema. As the capillaries start getting injured and start leaking out, they will develop pulmonary edema. Even before that, he has exertional dyspnea because of the congestion, increased blood inside the lung at any given point of time, right? Yes, so this can lead to, this pulmonary congestion can lead to exertional dyspnea, paroxysmal orthopnea, as well as PND. And between orthopnea and PND, it is the PND which is more specific for the left heart failure than the orthopnea. Orthopnea can also occur if you have ascites, right? If I have massive ascites, if I lie down, ascites will push my diaphragm upwards, making it less easy for the diaphragm to do a descent during inspiration. So I'll become breathless. So massive ascites, abdominal pathologies can also cause orthopnea. But PND is very specific for the left heart failure. So all the signs that are described here are for the right heart failure. Okay. Why can't this be portal hypertension? Why can't this be portal hypertension? If there is portal hypertension, this patient will develop varicosities. He will have esophageal varicosities. He will have hemorrhoids. He will have ascites. Right? Portal hypertension will cause ascites, but he will have varicosities. It is difficult to explain the other manifestations. Okay, so it is less likely to be portal hypertension. Hypertrophic cardiomyopathy. See, most of the patients with hypertrophic cardiomyopathy are kind of asymptomatic. Like most of them come to light because they develop a arrhythmia. They are at increased risk of developing atrial fibrillation and ventricular tachycardias, and they are at increased risk of sudden cardiac death because of that. Most of the hypertrophic cardiomyopathies are undiagnosed before the death. They get diagnosed on autopsy tables. Them developing heart failure is only possible when this hypertrophic cardiomyopathy is long standing, patient is put to increasing demand of cardiac output, then this hypertrophied left ventricle develops ischemic insults, develop a ischemic heart disease, dilates, and then fails, right? So we cannot hypertrophic cardiomyopathy patient might develop failure, but that cannot be the primary diagnosis here, right? And there is nothing else to prove that he has got hypertrophic cardiomyopathy. In the question is, they have not told that there is a systolic murmur. The murmur increases with all those maneuvers that we discussed previously in the question. No such information. Mitral regurgitation will cause left-sided heart failure, right? If you have mitral regurgitation during left ventricular systole, blood that is supposed to go into aorta, part of it is coming to LA. So LA pressure is going up and you will have pulmonary congestion, and you can have the features of left heart failure, not the right heart failure. So mitral regurgitation cannot be an option. So the only option we are left with is heart failure. If they had specifically told right versus left, our answer would have been right heart failure. Right? So option D is our correct answer. Okay. Now let's move to the next question. In multiple sclerosis, the mechanism of slowing of conduction occurs due to. In multiple sclerosis, mechanism of slowing of conduction occurs due to. Okay, we'll add only 3-4 points for this. Is it because of gliosis, loss of myelin sheath, defect at node of Ranvier, or leaky sodium and sodium channels? Okay, see, there are two important major demyelinating disorders that we should know, right? Two major demyelinating disorders. One is for the peripheral nervous system and the other one is for the central nervous system. For the CNS, the major demyelinating disorder is multiple sclerosis. And for the peripheral nervous system, the major demyelinating disorder is, we have discussed umpteen number of times in previous session also, that is your GB syndrome. The AIDP variant, the most common variant, is a demyelinating disorder, right? Okay, so we know that multiple sclerosis is a demyelinating disorder. So obviously the slowness in the conduction is because of the demyelination. So the answer should be loss of myelin sheath. Okay. 2-3 important points about multiple sclerosis. Okay, they might ask you, what is the diagnostic criteria? Name of the diagnostic criteria. What is the name of the diagnostic criteria that is followed? Okay, that is one. Okay, then they might ask you about a named radiological finding that you will get on the MRIs. You should be aware about that. What is the name of the diagnostic criteria? Yes, it is McDonald's criteria. Okay, I'm not getting into the details of McDonald's criteria because it will consume a lot of time, but at least remember the name, McDonald's criteria. The essence of McDonald's criteria is that you need to prove that patient has two lesions which are disseminated in space and time. Right? You need objective clinical evidence or the imaging evidence to say that there are at least two events of demyelination that this patient has gone through. Okay. So that is the name of the diagnostic criteria. Then on the radiology, you are basically looking at the evidence of demyelination, and most common site where you will see the demyelination is in the periventricular region. Okay, and that gives rise to a named radiological finding. What is it? Right. So that is called as, okay, most common site for demyelination is periventricular region. And what do we call that as? We call that as Dawson's fingers. Okay, they can also ask you what is the most common long tract sign, or what is the most common neurological manifestation. See, demyelination is occurring in different parts of the brain, right? These patients can develop optic neuritis. These patients can develop involvement of cerebellum. There can be transverse myelitis or myelitis, right? Among all these findings, what is the most common finding? Most common CNS manifestation of multiple sclerosis, or most common long tract sign. Most common manifestation as well as most common long tract sign is same. What do I mean by long tract? Motor tract, right? Pyramidal pathway, or the sensory tracts. These are the long tracts. Most common long tract sign. Both are same, that is sensory symptoms. Yeah, 25% of the patients at presentation may have optic neuritis. Neuritis. Yes. Okay. Other than that, the important potential exam clues is they often have myelitis or transverse myelitis. Myelitis or transverse myelitis. Okay. I think fair enough of discussion on the multiple sclerosis. This answer is very straightforward. There is loss of myelin sheath. Okay. We will move to the next question now. Which of the following is the single next best test to be done in a 15-year-old girl who presented with fatigue, chronic diarrhea, and weight loss, bone pain, abdominal distension, and in whom iron deficiency, anemia, and osteoporosis was revealed on investigation? 15-year-old female presented with fatigue, chronic diarrhea, weight loss, she has bone pains, she has abdominal distension or discomfort, she has iron deficiency anemia, and she also has osteoporosis. What is the investigation you want to do? TSH levels, C peptide levels, IgA tissue TTG antibody, or urine sugar and ketones. Urine sugar and ketones. Tropical Capricorn thinks we should be doing a anti-TTG antibody test. Why? Do you think this patient has celiac disease so that we do this anti-TTG antibody test? Okay, some things make sense to consider it as celiac disease. She has diarrhea. Okay, I agree. Maybe. But does celiac disease explain all the manifestations that we are seeing here? C peptide levels. Okay, let us address one by one. Okay. If she has fatigue, TSH levels, we do it for either looking at hyperthyroidism or hypothyroidism, right? Can fatigue occur in patients with hyperthyroidism? No, hyperthyroid patients are hyperactive, right? They are quite restless. They have difficulty in sitting at one place. They are more like maniac patients. Hyperthyroid is like pacing around. They're not sitting at one place because their basal metabolic rate is high and they are like active. They want to keep moving around. Fatigue is not what they would be complaining of. Okay. Hypothyroid patient, yes, they can present with fatigue. Okay. But if I'm thinking of hypothyroidism, can hypothyroid patient have weight loss? Yes. Hypothyroid patient, no. Hyperthyroid, yes. Hypothyroid patient will have constipation or diarrhea. Hypothyroid will have constipation. Hyperthyroid can have diarrhea, but hyperthyroid, I don't expect him to have fatigue. Okay. If hypothyroid, then there should be weight gain. So there are conflicting findings here itself. Okay. Then hyperthyroidism is not associated with iron deficiency anemia. Hypothyroidism can be associated with normocytic normochromic anemia because of the reduced bone marrow activity, but not this typical iron deficiency anemia. So it's not fitting there, right? So I am not considering this as an option as of now. C peptide levels, why do we get it done? C peptide levels, why do we get it done? Most likely we will get it done when we are thinking of an insulin producing tumors. When insulin is synthesized by the pancreas in equimolar concentration, it also releases C peptide. Why are we not looking at insulin levels and why are we looking at C peptide levels? Both are produced in equimolar concentration, right? It is a pre-pro insulin which is formed. From that it is cleaved to produce insulin and C peptide. Why we don't bank on insulin levels and rather bank on the C peptide levels? It is something to do with the half-life. Insulin has short half-life and it is very much influenced by recent changes in the blood glucose levels. Like 10 minutes back I took some syrup or took some juice, my insulin is going to shoot up, right? So it is very much fluctuant. Though C peptide is produced in equimolar concentration, because it has long half-life, it has much more stable levels. That is why we use C peptide levels if you are suspecting a insulin producing tumor. If this patient is experiencing insulin producing tumors, that can explain some of the things, right? Insulin is increased in production, so blood glucose levels are repeatedly going low. She can have fatigue, right? And insulin producing tumor or insulinomas are pancreatic neuroendocrine tumors. So they can produce, in addition to insulin, they may be producing other vasoactive peptides like VIP and all. That might explain diarrhea. Okay, but insulinomas, will they cause weight loss? The answer is no. If you have constantly increased production of insulin, you are hungrier because your blood glucose level is repeatedly dipping down. You feel hungry, you eat more, and all of that. What will insulin do? Convert all that glucose into fat. So you will not have weight loss. So that goes against the insulinoma or hyperinsulinemic state. So I am not going to think of even C-peptide levels as an option. Okay, urine sugar and ketone. Okay, if I'm doing that, right, then that means I'm suspecting type 1 diabetes mellitus. In a 15-year-old girl, I'm suspecting type 1 diabetes mellitus. That's why I'm interested in looking at urine sugar and ketones. Some things can be explained by diabetes. Fatigue can occur, yes. Diarrhea in a long-standing diabetic, they can develop autonomic nervous system dysfunction. They can have diarrhea. We call it as diabetic diarrhea. Weight loss can also be explained. Diabetic ketoacidosis patients often experience abdominal pain and distension. That can be explained. Okay, but it is difficult to explain osteoporosis and iron deficiency anemia from diabetes alone. So I'm going to not consider this as a very valid point right now. So I'm only left with option C. So by exclusion, my choice is option C, but we will come back to this, why this can be a case of celiac disease. What we know about celiac disease, it is a disease because of immune mediated injury to the gut mucosa, and this immune mediated injury is triggered by exposure to gluten, right? Gluten is converted to deamidated gliadin peptides against which trigger the immune response and damage the gut mucosa. That's the basic thing we know, right? Okay. Now, has anybody heard of something called as Oslo definitions? Oslo definition. Celiac disease is broadly categorized into 4 categories. 4 categories. Has anybody heard of Oslo definitions? Celiac disease, also called gluten sensitive enteropathy. Right? Okay. So I want you to remember what is this called as Oslo definition, which will help you to answer most of the questions that will come in the subsequent exams on celiac disease. Okay. What is Oslo definition? In Oslo definition, celiac disease is classified into 4 categories. One is called as classic celiac disease, non-classical celiac disease, subclinical celiac disease, and probable celiac disease. For these classification, we are looking into 3 parameters. Okay, what are those? Number 1, clinical features, present or absent, and if present, what kind of clinical features. Second thing we are looking at is serology, whether those are antibodies. We know the antibodies, right? Anti-TTG, anti-endomysial, anti-DGP, anti-gliadin, those antibodies, whether they are present or not. And third thing we are seeing is biopsy evidence of celiac disease. Okay. So clinical features wise, we can have intestinal manifestations and extraintestinal. The typical intestinal manifestations is diarrhea, malabsorption, right? Abdominal discomfort. These are all intestinal manifestations. What are the extraintestinal manifestations we can expect? We can expect them to have cerebellar dysfunction. Remember, this is very important. A lot of patients, adult patients of celiac disease are diagnosed because they presented with cerebellar signs. Okay, if I have an adult presenting to me with cerebellar signs, I will think of 3 things today. Number 1 is vascular insult. It could be part of a stroke. Number 2, just few minutes back we were discussing multiple sclerosis. Cerebellum is one of the commonly affected side after periventricular things and the optic nerve and the spinal cord. 4th most important affected structure is cerebellum. So I will think of multiple sclerosis, stroke, multiple sclerosis, and 3rd thing I will be thinking of is celiac disease. Okay, it can cause osteoporosis. It can cause arthritis. Okay. It can cause a skin manifestation called as dermatitis herpetiformis. Those are all extra intestinal manifestations. Okay. Serology we know, right? Serology, what are the antibodies we know? We know anti-TTG antibody. We know anti-endomysial antibody. Then we know anti-gliadin antibody. Then we know anti-DGP antibody, anti-deamidated gliadin peptide antibody. Okay. Yes, there is increased risk of T-cell lymphoma. Yes, right. There is increased risk of T-cell lymphoma, and it is quite predictable also. Looking at the number of intraepithelial lymphocytes on the biopsy, we can predict the risk of development of T-cell lymphoma. Okay. Important MCQ point, between these antibodies, which one is most specific? Which one is more specific for the diagnosis of celiac disease? Is it anti-THC, anti-EMA, anti-gliadin? Least specific is anti-gliadin. Fake the bar. Between the anti-TTG and EMA, which one is more specific? Which one is more specific? Anti-TTG and anti-EMA. No. It is anti-EMA which is more specific. Anti-endomycin antibody is more specific, but the starting point of investigation is anti-TTG. The reason for that is anti-endomycin antibodies, the test that is done is very cumbersome and it is time consuming. So the specificity is not so great over anti-TTG that we have to do anti-EMA for all patients. So anti-TTG, the test procedure is not very cumbersome. Results can be available quick and the equipments and investments for doing anti-TTG is less expensive. That is why the initial investigation of choice is anti-TTG. Initial investigation of choice is anti-TTG, but the most specific is anti-EMA. Most specific is anti-EMA. Initial investigation of choice is anti-TTG. Okay. Now biopsy, what are the findings we are expecting on the celiac disease? When you are doing the biopsy, the point number one is what is the site you are taking the biopsy from? Like esophagus, stomach, duodenum, jejunum, ileum. From which site we are taking the biopsy? Remember, biopsy is taken from the duodenum. Usually second or third part of the duodenum. Roughly remember duodenum. Why duodenum? Okay, see we have esophagus, stomach, duodenum, jejunum, ileum and all. Okay, when you consume this gluten rich food, right, it goes to stomach, then starts getting lysed, right, then the TTG starts acting and you have this deamidated gliadin peptides and that will start causing immune attack. But as the food goes further down, right, lesser and lesser amount of exposure occurs because most of the antigens are exposed. The duodenum gets the highest exposure to antigen. So duodenum is the one which is more likely to show histopathological changes. As you go further down from the duodenum to jejunum and ileum, the amount of antigen exposures is less and less and less. So the histopathological changes are going to be less likely. So duodenum is the most severely affected part in celiac disease. It's a very important point for us to learn, right? Okay, why? Now tell me, where is the site of absorption of iron? Where the iron gets absorbed? Which part? Duodenum, jejunum, ileum, colon. Where is the iron absorbed? Yeah, but okay, we don't take the biopsy from the first part of the duodenum because the acid output of the stomach can also influence the histopathology of that region, right? That's why we either consider D2 or D3 segments. Duodenum इतना remember करोगे तो काफ़ी है. Iron absorption occurs at the level of duodenum. So when the duodenal mucosa is so much affected by celiac disease, the iron absorption gets affected. That is why these patients are very much prone for iron deficiency anemia. They are not prone for B12 deficiency anemia because B12 absorption occurs in the terminal ileum. Right? If you have an intrinsic factor and good dietary intake of B12, terminal ileum is where your B12 absorption is occurring. So it is not affected. But iron absorption is affected. Good amount of carbohydrate, protein, fat absorption does occur in duodenum. So those malabsorption manifestations can be there. But B12, no. Right? Okay. So now we know why iron deficiency anemia occurs. And in the biopsy, what are the findings we are getting? Biopsy findings are not specific except Whipple's disease. No? All other malabsorption syndrome, biopsy findings are not going to be specific. All we see is, normally when you look under the microscope, you have villi, right, in the intestinal epithelium, and then you have crypts. You have villi and crypts. So what you will be seeing on the biopsy is these villi are shortened, right? So you will have villus atrophy. So the villi are shortened and you will see crypt hyperplasia. Crypt hyperplasia. So these crypt are much more deeper now. The crypts have become much more deeper. Villi has become stunted. And the third thing you will see is intraepithelial lymphocytes. So inside the epithelium there is lymphocytic invasion. These findings are not specific, but we will see them if you have celiac disease. Okay. Now coming to this Oslo definition. In classical celiac disease, you will have all the findings. There will be clinical features, there will be antibodies, and there will be biopsy evidence of celiac disease, right? But the clinical features in classical present, and they are intestinal. They are intestinal features. Serology is going to be positive. Biopsy is also going to be positive for celiac disease. Okay. Now, what is non-classical? Non-classical clinical features are extra-intestinal, like iron deficiency anemia, osteoporosis, all those extra-intestinal manifestations that we listed. Serology will be positive. Biopsy will be positive. Okay. Now coming to subclinical celiac disease. The name says subclinical. That means clinical symptoms will not be there, right? No symptoms, but serology will be positive, and you do biopsy, that will also show. That means intestine is affected. Biopsy is positive. It is showing villus atrophy, crypt hyperplasia, and intraepithelial lymphocytes, but patient doesn't have any clinical symptoms. That is subclinical. The last one is probable, where there are no clinical features. Patient doesn't have any clinical symptoms. Okay, biopsy is also not showing any changes, but he has antibodies. So it's like probably he might have celiac disease. Later in the course of time, we might see that this patient develops biopsy changes and clinical symptoms. Right now, we can say probable. So there are no clinical features. Serology is positive. Biopsy is negative. Only antibodies are there. That is probable. Okay, I hope this basic point is clear. Now coming back to the question. I forgot to ask you one important point. Between these four categories that we discussed, which one is most common? Classical, non-classical, subclinical, or probable? Which one is most common? Tarun Tushar Bansal, the iron absorption, when you take food and it is rich with iron, the absorption occurs at the duodenum, and duodenum is the most commonly affected part in the celiac disease. Because see, when we take gluten-rich food has a lot of gluten. It gets converted into deamidated peptides, against which antibodies are produced, and we have this immune injury. The maximum antigen exposure occurs. The antigens are occupied here. So the less antigens go to different distal parts of the bowel. So maximum antigen concentration is in the duodenum. So maximum injury is to the duodenum. And unfortunately, duodenum is the part from where the iron absorption occurs. So if the duodenum is affected, iron absorption goes low and you have iron deficiency anemia. Okay. No, the most common is non-classical. Right? So I want you to remember this. Most common is non-classical. And because of that, it is a bit of a diagnostic challenge, right? If a patient presents with diarrhea and intestinal symptoms, we will suspect celiac disease हो सकता है. He will tell that okay, चपाती खाया, wheat खाया, उसके बाद में stomach में दर्द होता है, हमेशा ऐसा ही होता है. We can suspect. But this non-classical, patient presenting with iron deficiency anemia or osteoporosis, we don't think of this. Iron deficiency anemia, या खाने में iron कम होगा, give iron supplementation, and then we will see. Osteoporosis, ना calcium नहीं खा रहे हो, ले लो calcium, then we will see. So this is most difficult to diagnose case, non-classical. That is most common, right? And also remember that classical is more common in children under 2 to 4 years of age, and non-classical is more common in adults. So adults are the ones which are most likely to present with non-classical. So it is even more difficult, right? Okay, so now going back to the question. Does this patient have classical or non-classical? Does this patient have classical or non-classical? Classical or non-classical? See, he has classical manifestations also, non-classical manifestations also, right? This patient is actually making a transition. I told you one statement, right? It is the pediatric age group patients who are most likely to have classical, and adults are most likely to have non-classical. They are more likely to present with extra-intestinal manifestation. This patient is making a transition from classical to non-classical. So that's why she has started showing these extra-intestinal manifestation, iron deficiency anemia and osteoporosis. So this story is suggestive of celiac disease, and it is a worthwhile investigation to consider TTG, anti-TTG antibody. That is the starting investigation that we would be doing. If it is positive, we'll also go ahead with the biopsy, and then if the biopsy is also positive, then the diagnosis is established that this patient has celiac disease. Okay. In a real world scenario, remember that if you have diagnosed someone, adult, as having iron deficiency anemia, you give them iron replacement, oral replacement, and you ensure that they are compliant to treatment, and despite that their iron deficiency is not improving, you have to consider celiac disease as a very important differential diagnosis. And it is so common. Trust me, you take 20 iron deficiency anemia patients, give them all the prescriptions, make sure all of them are following. 2 or 3 of them will come back to you with same hemoglobin level, not improved iron profile, right? And those patients, simplest thing you can do is switch to parenteral iron treatment, and their iron deficiency anemia improves like anything, because the duodenum is becoming a part of hindrance for iron absorption. Parenterally they start improving. Now that is a case which you should investigate for celiac disease. Okay, now we'll move to the next question. Okay, this should be a very simple and easy cakewalk for all of you. Identify the metabolic abnormality in a 59-year-old male presenting with tachypnea and mental confusion, with lab reports of blood sugar 350, pH 7.2, bicarb 10, PCO2 30, right? Okay, we have learned about ABG, so let us directly quickly dissect it. pH 7.2, right? It is decreased. pH is going down. Next we are seeing is PCO2. PCO2 normal is 35 to 45, it is 30, so this is also going down. Both are in the same direction, right? So what is it? Metabolic or respiratory? Respiratory opposite, metabolic same side, ROMS. So it is metabolic. Whatever is the pathology, it is metabolic. It is metabolic. And the second thing is pH is on the acidotic side, 7.2, right? So it is metabolic acidosis. Now the next question is whether it is fully compensated or partially compensated. Fully compensated or partially compensated? We will call it as fully compensated if the pH comes back to the normal range, right? Whatever is the compensatory mechanism, it has not put the pH back to the range of 7.35 to 7.45. It is not in the normal range. So it is, if there is a compensatory mechanism involved, it is partially compensated. Yes, it is metabolic acidosis and it is partially compensated. Good. Okay, we will move to the next question. We'll not spend much time here. Yeah, it is a partially compensated metabolic acidosis. Okay. Next question. After hip replacement surgery, patient presents with swelling of the legs in association with pain on palpation. So there is leg swelling. They have used the word legs. Okay. So whether it was a typographical error or whether the question had this legs, I don't know. But swelling of the legs with pain on palpation. Pulse rate is 70 beats per minute. There is no history of hemoptysis or significant weight loss. No previous history of pulmonary embolism. Based on Wells score, what is the risk of development of pulmonary embolism? Low risk, moderate risk, high risk, or cannot comment without D-dimer values. Okay, this is a very common scenario for recent examinations, right? The pre-test probability and risk assessment, and then interpretation post-test results. Okay, tell me, what do you think this patient's risk of thing? So we need to know about Wells score, right? Can anybody tell me, do we still follow Wells score, or we have moved on from Wells score and we follow something else for assessing the risk of pulmonary embolism? Okay, there are two Wells score. There is Wells score for probability of DVT. There is Wells score for probability of pulmonary embolism. Two Wells scores are there. Okay, for DVT we still follow the Wells score. For predicting the probability of DVT, we still follow the Wells score, but most of the recent guidelines for pulmonary embolism, they follow Geneva score, right? We follow Geneva score. So for DVT, we have Wells score for DVT, right? And for pulmonary embolism, right, for probability assessment, whether this patient has probably pulmonary embolism or not, we have Wells score for PE, and we also have another thing called as Geneva score. Okay, so most of us currently follow the Geneva score. Okay. Apart from that, I want you to remember two more points for pulmonary embolism for assessing the severity of pulmonary embolism. Severity assessment, we have a PESI score. Pulmonary embolism severity index, simple, right? Easy to remember. They can ask these questions, so I am just listing them out. Okay, so for severity assessment, we have PESI score for pulmonary embolism, severity assessment of pulmonary embolism. Easy to remember, no? Pulmonary embolism severity index, right? But for the assessment of probability of pulmonary embolism, currently we follow Geneva score, not Well score. But this question is based on Well score, so we will look at the Well score only. Okay, so what are the components of Well score for pulmonary embolism? For DVT, it is different. For pulmonary embolism, it is different. So you should be aware about that. The components are, first one, clinical signs and symptoms of DVT, whether they are present or not. Okay. In this patient, they mentioned that there is swelling of the leg. DVT occurring in both limbs simultaneously is extremely rare. So I don't know if the legs is a typographical error or they meant that there is unilateral. But with a pinch of salt, let us consider that this, we will take it as a evidence of DVT or signs and symptoms suggestive of DVT, because there is also pain on palpation, right? There is also pain on palpation. So in that case, these 3 points I will give to the patient with that, taking with little pinch of salt. Okay. No alternative diagnosis is possible other than pulmonary embolism for the patient. Like we can't think of any other diagnosis. I won't take that as a scenario here, right? Patient has bilateral leg swelling. Patient has nothing else makes me think that only possible diagnosis is DVT, right? Other possible diagnoses are possible. So I'm not going to give any score for this. Heart rate more than 700. No, this patient has 70, right? So I'm not going to give any score for this. Immobilization for more than 3 days or surgery in the previous 4 weeks. This is a valid point, right? This patient has undergone a hip replacement surgery. So I have to give score for this patient, right? So I will give this 1.5. They have told that there is no previous history of DVT in the question, right? They have told that there is no previous history of DVT or pulmonary embolism in the question. So I'm not giving any points to this, right? They have not mentioned about any malignancy being present, so no points. They have mentioned that there is no hemoptysis, no points. No history of malignancy, no point. So now we are left with 2 points which have got active scores. So our score is 4.5, right? So by definition, 4 or less than 4, pulmonary embolism is unlikely, and 4 or like 4 plus 4.5, 5 or anything more than that, pulmonary embolism is highly likely. Okay, clear? So now going back to the question. What do you think is the likelihood of pulmonary embolism in this case? The risk assessment using the Well score doesn't take into account the D-dimer values, so that option is out, right? The score is definitely more than 4, so this option is also out. There is a likelihood of pulmonary embolism, right? Okay, now this Well score, the traditional classification doesn't differentiate into moderate or high risk or low risk. There's nothing called in between moderate, so I would go with the high risk of DVT in this case. Okay, so this patient has high probability of having a pulmonary embolism. Okay, now few important points about pulmonary embolism. Okay, pulmonary embolism can be typically because there is a DVT developed, and DVT occurs because of this triad, right? What are those triad? Endothelial injury, stasis, right? What you call it as varicose triad. So the 3 components: hypercoagulability, endothelial injury, and stasis. Right? When those 3 things come together, we will call it as DVT. What this is called? Varicose triad. Hypercoagulability, endothelial injury, and stasis. Right? So I want you to give one examples. Tell me a condition where endothelial injury occurs and that can lead to DVT as well as pulmonary embolism. We experienced recently a lot of these patients. Example is COVID. Right? In COVID, there is endothelial injury that contributes to development of disseminated intravascular coagulation, and a lot of COVID patients on autopsy had pulmonary embolism. So makes sense, right? Stasis, after a prolonged flight, that too traveling in the economy class, not much of leg room, minimal movement of the legs, lot of people have developed DVT. So stasis, venous stasis can cause hypercoagulability. Use of oral contraceptives increases the coagulability, can cause DVT. OCP is an important risk. Okay. And there are genetic conditions which are called as thrombophilic states, inherited conditions where there is hypercoagulability, that can also cause DVT. The reason I'm talking about is there is an MCQ. What is the most common inherited hypercoagulable state responsible for DVT and pulmonary embolism? Most common inherited. Most common inherited. Most common inherited hypercoagulable state responsible for DVT and pulmonary embolism. That is your factor 5 Leiden mutation. Factor 5 Leiden mutation. Right, Limo, right. Second most common is prothrombin mutation. First most common is factor 5 Leiden mutation. Okay. Now we know that surgery and immobilization is an important risk factor. So they might ask you, what surgery carries the highest risk? Right? So remember, surgeries involving the lower limbs and pelvis carry the higher risk. So in this patient, he has undergone a hip replacement. Compared to general surgery, orthopedic surgeries carry the higher risk. The surgeries which involve lower limb and the pelvis or hip carry the higher risk. So this patient had indeed undergone a high risk surgery, which is as such high risk for development of DVT and thus pulmonary embolism. Okay. Now we'll move to the next question. The recommended temperature of water bath for a patient with frostbite is? Yeah, total hip replacement and total knee replacement are the high risk conditions. One more point I forgot to tell you. Now pulmonary embolism, we classify them into massive, submassive and mild. Pulmonary embolism is classified into massive, submassive and mild. Based on what parameters you classify so? When do you call it as massive pulmonary embolism, submassive pulmonary embolism and mild pulmonary embolism? It is not based on the load of the thrombus. Okay, it is based on the hemodynamic parameters. And whenever you develop pulmonary embolism, what happens? Pulmonary embolism means pulmonary artery has developed a clot, right? So what is happening to the right ventricle? It is under enormous stress. It will start failing. So we are only looking at what is happening to the BP and what is happening to the right ventricle. Why BP gets affected in pulmonary embolism? So just think of this. This is your right ventricle. This is your left ventricle. From the right ventricle, you have a pulmonary artery, right, which will go to lungs. And from there, you have the blood coming to your left atrium. Okay, if you have a clot in the pulmonary artery, right, the amount of blood that is reaching the lungs from the right ventricle is reduced, right? In other words, right ventricular output is reduced. So the amount of blood that is coming to left atrium is reduced. So the amount of blood that comes to left ventricle is reduced. So the left ventricular output into the aorta is also reduced. So the cardiac output gets reduced because RV to lung flow is affected. So that is why they can develop hypotension. Hypotension means that more and more severe reduction in the flow of blood across the pulmonary artery is happening. So that can be indirect marker of the amount of clot that is there, right? And second, when right ventricle is struggling hard to pass the blood through this clot, right, it is also suffering the impact of it. So it starts failing. So it starts developing strain. These two things we are looking at, BP and RV strain. So if the patient, regardless of the clot size, if the BP is less than 90/60, we will consider it as massive pulmonary embolism. Clot may be small, but the BP is low, it is massive pulmonary embolism. Okay. If the BP is normal, but there is evidence of right ventricular dysfunction on the echo, that is submassive. Mild is where BP is normal and RV dysfunction is not there. That we will call it as mild. So you have diagnosed pulmonary embolism, you do echo, you look at BP. BP is normal, echo shows RV function is normal, that is mild. Okay, I diagnose pulmonary embolism, BP is normal, but echo there is evidence of right ventricular dysfunction, that is submassive. I have a patient of pulmonary embolism with a BP less than 90/60. It is massive, regardless of whether RV dysfunction is there or not. It is called as massive. Okay, and massive is the one which calls for thrombolysis, emergent thrombolysis. Mild one is managed with anticoagulation. The submassive, anticoagulation plus or minus thrombolysis. You need to decide whether you want to go ahead with thrombolysis or not in case of submassive. Massive, definitely you need to thrombolize, and mild, you don't need to thrombolize, just give anticoagulation. That's how we manage these patients. Okay. Now coming to this question. The recommended temperature of water bath for patient with frostbite. What is frostbite? You go to extreme cold temperatures. The exposed parts, especially the digits, are suffering the cold injury. Right? That is what we call as frostbite. Your tissues are frozen and they eventually start suffering because of the closure. The tissue cells start dying. So you want to slowly rewarm them back to the normal temperature so that you are recovering that frostbite tissue. Right? What temperature you should give and how much time you should take. See, every different tissue in the body has different threshold of tolerance for cold. Okay. Have you heard of this concept called as cryolipolysis? Cryolipolysis. Lipo means fat, na? Cryolipolysis is a technique which plastic surgeons and dermatologists follow for fat reduction. Now, it has been observed that when you subject the tissues, like adipose tissue, to sub-zero temperatures, adipose cells get frozen and by apoptosis they get cleared. So repeated cycles of this cryolipolysis can be an alternative to liposuction for those who want to lose fat. That is one therapeutic application of cold exposure. But frostbite is something not acceptable because you will lose the digits to ischemia and gangrene. But rapid warming can be more catastrophic. So we have to warm it slow at appropriate temperature. So what is recommended is 100 to 105 degrees Celsius is the temperature, or which transforms into Celsius in the form of 40 to 43, I guess, if my calculation is correct. So I will be going with the option D as the right temperature. 42 makes a sensible temperature. So if you don't have a thermometer to check the temperature of the water, how do you get to know that you are following the appropriate temperature for rewarming of a patient suffering from frostbite? Where does frostbite happen? If you think from India's perspective, on the mountains, you're going to some Spiti Valley or Himachal or Himalayas, you're doing mountaineering and you're most likely exposed to extreme cold, you develop frostbite. There, like on the mountains and all, probably you're not carrying a thermometer to check the water temperature. And so how would you do that? So their simple thing is touch the water. It should feel not cold, not hot. It should be warm. Right? If you're feeling it as warm, most likely it will be in this temperature range only. But if you have a thermometer, check how much hot it is. 40 to 43 or 100 to 105 Fahrenheit or 40 to 43 degrees Celsius. Okay, so from the option this makes sense. But what duration you should warm? Right? So temperature we know now. The duration is 15 to 30 minutes. So this time they have asked about temperature. Next time they might ask about the duration. 15 to 30 minutes you should warm. Mostly it's like adequate rewarming and they would recover back to normalcy. Okay, cool. We'll go to the next question now. Which of the following conditions occurs due to mutation in the gene of aquaporin channels? Options are cystic fibrosis, nephrogenic diabetes insipidus, Liddle syndrome and Bartter syndrome. What they are asking for? Mutation in the aquaporin channels. Okay. What is the mutation responsible for cystic fibrosis? Cystic fibrosis transmembrane conductance regulator, or CFTR gene, right? CFTR gene mutations are responsible for cystic fibrosis. That's not going to be the answer, right? Okay. The genes which are mutated in Liddle syndrome and Bartter syndrome are not so easily that we can remember, right? The channels we can remember, but the gene names are a bit complex, like SCNN1B or SCNN1G for Liddle, or SLC12A1 KCNJ or CLCNKB for Bartter. Okay, so the one that is causing, which is occurring because of the aquaporin mutation, is Nephrogenic diabetes insipidus. That's a correct answer. I'll tell you what the aquaporins do. Aquaporins, as the name suggests, water porins. So these are pores which allow the movement of water, right? So in the kidney, when the blood reaches, right, like you have a glomerulus, right, when the blood reaches, there is a glomerular filtrate. Good amount of water is filtered out. But once that is filtered out, now water should be reabsorbed. You can't be like whatever blood came to kidney, you will clear all the water out of it and only send RBCs and WBCs back and proteins back and clear all the water. No, we need that water back. So it gets reabsorbed. The reabsorption of water at the level of kidney after the glomerular filtration can be classified into two things. One is obligatory reabsorption and facultative reabsorption. So obligatory reabsorption means compulsory. No matter what is your fluid status, whether you are fluid overloaded, whether you are dehydrated, irrespective of that, obligatory water absorption will occur, right? So that occurs in the proximal convoluted tubule. In PCT, 90% of water reabsorption occurs. And this is obligatory. You're dehydrated or you're overloaded, 90% water will be reabsorbed. Okay. From there, right, your loop of Henle and all, then water eventually go to collecting ducts, right? DCT and collecting ducts. In the collecting ducts, 10% reabsorption occurs. In the collecting ducts, 10% reabsorption occurs, and this is facultative. Means it's not compulsory. Body decides how much of it to reabsorb. 10% is capable. All 10% to absorb, or 5%, 3%, 7% to be absorbed. It is decided. And what is the influencing factor? It is ADH dependent. So it is the antidiuretic hormone that is deciding how much to absorb. ADH dependent. Okay. So how ADH decides whether I should absorb all the water, all this 10%, or let go of all this 10%, or in between? What is the role of ADH? ADH's primary role is to regulate serum osmolality. Serum osmolality. So how does posterior pituitary get to know that serum osmolality is altered? There are osmoreceptors. Where are the osmoreceptors present? Osmoreceptors are present in hypothalamus. To be more precise, there is a structure called as organum vasculosum of lamina terminalis, which is a circumventricular organ. What is circumventricular organ? A structure where there is no blood-brain barrier. Brain mostly has blood-brain barrier except some areas. One of them is organum vasculosum of lamina terminalis. Right? So this has osmoreceptors. So if the serum osmolality is going low, means what? There is more fluid in the serum. That is why the things are getting diluted, osmolality is going low. So it will sense, right? Then it will tell the pituitary gland to either increase or decrease the ADH production as required, right? So tell me, if serum osmolality is going down, what should happen to ADH levels? Yeah, area postrema also is a circumventricular organ. Okay. If serum osmolality is going down, decreasing, what will happen to the ADH levels? What is the job of ADH? Name says antidiuretic hormone. That means diuresis means losing more in urine, more water in urine. Antidiuretic action means it should increase absorption, right? So if the serum osmolality is going low, that means there is more water and less solutes. So should renal absorption should be increased or decreased? It should be decreased, right? So that you pass more water in urine and the serum osmolality is set back to normalcy. So simplest way to remember is serum osmolality follows, or the ADH levels follow the direction of serum osmolality. Osmolality going down, ADH goes down. Osmolality going up, that means the plasma or serum is getting more concentrated, there is less water. So ADH goes up, absorbs more water and dilutes the plasma to bring it back to the normal osmolality, right? So the statement is very clear. The ADH follows the direction of serum osmolality. So in this case, serum osmolality going down, that means ADH will go down. If serum osmolality is increasing, that means ADH will increase. Okay, but how ADH causes the absorption of water? ADH has its receptors, right? There are different types of ADH receptors, V1, V2, V3. Which ADH receptors are present in the kidney collecting ducts? ADH receptors in the kidney. It is the V2 receptors, right? V2 receptors. V2 receptors are the one, or vasopressin 2 receptors are the one which are present in the kidney. Okay, right now I'm not wasting time on discussing where is V1 and where V3 present. Just remember V2 is the most important receptor which is present on the kidney. Okay, so once ADH goes and binds the V2 receptors, V2 receptors will stimulate. So if this is a kidney tubular cell, collecting duct cell, this is your V2 receptor, right? ADH comes and binds this. Once it is bound, right, it will stimulate production of aquaporin 2. Vasopressin 2 receptor stimulating aquaporin 2 production. So increase production of aquaporin 2, and this aquaporin will go and get inserted into the opposite side, and it will cause more absorption of water. So aquaporins are involved in absorption of water here. So in the PCT that we were talking, right, where the obligatory absorption occurs, it is aquaporin 1 which is involved. So here it is aquaporin 2 in the collecting ducts for absorption, and whatever water that is absorbed into the cell, it will go to the blood through aquaporin 3 and aquaporin 4. Okay, but the 2 is what I want to remember. Now if there is a mutation in this vasopressin gene, again ADH will not be able to work, right? So antidiuretic hormone is not working and they lose a lot of water, they develop diabetes insipidus. Similarly, even if the V2 receptor is fine, if they have a defect in aquaporin channels, no matter how much vasopressin is coming, there is no water absorption, they will lose a lot of water in urine. That is what we call as diabetes insipidus. So what is the correct answer for this question? Mutation in the aquaporin channels can lead to nephrogenic diabetes insipidus. Diabetes insipidus we classify as hypothalamic, pituitary or central, where the pituitary gland is not able to produce adequate vasopressin, or nephrogenic, where the pituitary is producing good amount of vasopressin but your kidneys are not able to respond because of the defect in the vasopressin 2 receptors or the aquaporin channels, right? So this patient has nephrogenic DI. If they had also added pituitary or hypothalamic diabetes insipidus also as an option, still our answer would be nephrogenic because aquaporins are at the level of kidney. Okay, let's move to the next question. All of the following are radiological findings in a patient with left heart failure except MBBS synapse and tropical Capricorn, right? V2 aquaporin 2, it's like 2. All of the following are radiological findings in a patient with left heart failure except. Some things are very much familiar to us, right? We have curly B lines. We know that. That is seen in left heart failure. Okay. Before even the pulmonary edema occurs, I was earlier also telling when the left heart fails, left atrial pressure increases, pulmonary venous flow gets stagnated or slowed down. So lungs have more blood at any given point of time, what we call as pulmonary venous congestion. So there is increased blood in the lungs. True, it is seen in left heart failure. Change in the upper lobe circulation. Okay, I don't have an X-ray image, but I'll show you in one of the subsequent sessions that there is pruning or cephalization of blood vessels. So blood vessels are now more directed towards the upper lobe. So this change you do see in heart failure. Focal oligemia is the one that we will not see. Where do we see focal oligemia? In what condition we see focal oligemia? Oligemia means reduced blood supply, right? The aeration is normal, but the blood flow of a area is reduced. Limo, right. So if there is nephrogenic, if you give desmopressin, which is a structural analog or a slightly modified vasopressin, if the kidney has receptor defect or aquaporin channels are not there, no matter how much desmopressin you will give, kidneys will not be able to respond because their mechanism is only disturbed. It's like I'm giving more petrol but car chal nahi raha hai kyunki punctured hai. It's like that, right? After desmopressin, if the function improves, that means the pituitary was not producing adequate vasopressin. We gave its derivative and it started responding, right? So focal oligemia we see in pulmonary embolism. Say like, okay, right side of the lung, right pulmonary artery, one of its branch has got a clot. So wherever the sub tributaries of that branch are there, there is no blood flow. So there will be like an abrupt cutoff of that blood vessel on the X-ray. Rest of the part looks like all those vascular pattern is there, but not in that area, focal oligemia. So you see that in pulmonary embolism, and that's going to be our correct answer. Okay. Yeah, you have Pallas sign, then Westermarck sign. Okay. It is very difficult to diagnose pulmonary embolism based on X-ray. That's why we are dependent on all these scoring systems and probability assessments, because all those classically described things like in ECG we describe this S1 Q3 T3 pattern. Very rare to see that. I have diagnosed at least 50 plus pulmonary embolism cases and have not seen a single ECG of S1 Q3 T3. I have seen it only from the internet. But all the cases of suspected pulmonary embolism, right, when we followed well score and now when we follow Geneva score, Hestia questionnaire, or we follow the PESI, I think it makes sense to use all of them because it helps us in diagnosing. Those all Pallas sign and all are more of interest for exams, right, not for the practice. Okay, now let's move to the next question. A 59-year-old man was brought to emergency department with an episode of acute onset dizziness and loss of consciousness, which lasted for a few seconds, followed by a regain of full consciousness. Short duration of dizziness and loss of consciousness. Lasted for only few seconds. And he regained full consciousness. No similar episodes in the past. True statement regarding this scenario is many patients will have normal chest X-ray. Many patients will have normal chest X-ray. It's like, I don't really remember when did I last see an abnormal chest X-ray of a pulmonary embolism patient. It's only the story that makes a lot of sense. Patient's history, that recent hospitalization or the surgery or having been on oral contraceptive pills for a long time or a flight travel, those things make more sense than the abnormal X-ray finding. Okay, what do you think this patient we should do? Okay, let us go from the bottom up. Can this be a case of vestibular neuritis? Okay, there are no strong pointers for me to think of this case as vestibular neuritis. What typically vestibular neuritis patients can experience dizziness. Full loss of consciousness episode is unlikely. They can experience dizziness, but apart from that, they will have other signs like the hearing defect, right, and the tinnitus. Those pointers are not there. There is no tinnitus, there is no hearing defect. So I'm not considering option D. Okay, now let me go to option B. If the ECG is normal, should we go for a CT scan? Should we go for a CT scan? Can we call this episode? What are the differential diagnoses for this episode? Right? Can this be a syncope? Can this be a syncope? Can this be a transient ischemic attack? Can this be an episode of seizure? Syncope is quite possible. TIA is also possible. But seizure, according to me, is less likely. Why? One is there is no witness seizure, right? There is no abnormal movements being described here. It can be an absent attack. I'm not saying that. Many patients with seizure, right? They have a post-ictal phase. After seizure, they will take quite some time to recover to full normal state. I don't mean that after seizure they will remain unresponsive only, but they are fatigued, exhausted, because when they go through seizures, when the muscles are contracting, all the muscle glycogen store is utilized, right? So they feel very much tired and fatigued. So they have a post-ictal phase. We are not seeing a post-ictal phase because he regained full consciousness and the description looks like he's perfectly normal soon after that. So which is a bit unlikely. Except absent seizures, it is difficult to explain the same thing to occur with other seizures. So seizure is something I'm not strongly considering. Okay. TIA is a possibility, but before the onset of TIA, development of dizziness is a bit unlikely. And TIA also, right? Mostly whenever TIA occurs, it occurs in the form of a clear motor deficit like hemiplegia, hemiparetic changes, then hemiparetic changes reverting. So they are not talking about any motor weakness here as such. So TIA also is less likely. So I'll be thinking more of syncope here, right? So when I think of syncope, What are the possible causes? The syncope can occur because of a vasovagal event. It can be occurring because of the postural hypotension, right? Or it can be occurring because of arrhythmias, cardiac syncope, or because of arrhythmias. Okay, because of arrhythmias. Now, so I will not be considering vestibular neuritis because other pointers are not there to think of vestibular neuritis. Tinnitus and all is not there. Hearing loss they're not talking about, so I'm not thinking of it. Okay. Then syncope, I gave you three important scenarios: postural hypotension, or like the cardiogenic syncope because of arrhythmias, or because of the vasovagal syncope. Right? Vasovagal syncope we cannot diagnose easily by any simple investigation. We need to have a good history that something's triggered a vagal nerve activation and that caused syncope. Arrhythmias we can think of diagnosing based on the ECG. Okay. Now, if the patient after a syncopal episode doesn't have focal neurological deficit, or he did not have focal neurological deficits during the syncopal episode, CT is not going to add much information to your management, because syncope is most likely cardiogenic or vagal than neurogenic. This patient description does not show that he had a focal deficit during the episode nor after the episode. So CT is uncalled for. If you keep on doing CT for all syncope patients, someone will sue you for doing unnecessary investigation. So CT scan should be done. I'm not buying it into it right now. If I don't find any other suitable option, I'll come to it. Right now I'm ruling it out. Okay. Now comes the tilt table testing. Tilt table testing is basically a maneuver to identify poor cardiac response to tilting of the table and abruptly making it upright. That happens, poor response happens when you have either increased vagal tone and issues related to that, or you have postural hypotension or autonomic nervous system dysfunction. But please remember, tilt table testing is only indicated if repeated episodes of syncope unexplained by other causes. So if you have direct explanation for what could be the cause, you don't go for tilt table. So it is one of the last resorts. In this case, there are no history of previous episodes, right? This is the first episode. So this is not the time for me to go for tilt table test. So my next important initial step would be, right, vasovagal depends on history, right? But arrhythmias is something that I need to rule out. So I would go with the ECG first. ECG, no arrhythmias, focal deficits present, then only I will do CT. Otherwise, I will not go for CT immediately. Right? I will probably assume it as vasovagal and then counsel the patient and send home. If he comes back to me with repeated episodes of syncope, then I will go ahead with tilt table. Anytime I notice focal deficits, I'll go ahead with CT scan. So the correct answer for this question is ECG to rule out atrial fibrillation. This is the right answer. Okay, cool. So many of you picked it up. Good. Possible, right? It could be possible. Hypoglycemia is a possibility. And in this case, right, in the emergency room, even before we start thinking of ECG and all, a blood glucose level should have been done. Yeah. In the question, they have not mentioned, so that means it was like we presume that it was normal. It can be a hypoglycemic episode. Yeah. Okay. I think we will take up this as the last question. We will continue with one more session. I will ask them to add one more session. A known case of type 1 diabetes mellitus teenager was brought to emergency department with confusion and drowsiness. On examination, breathing very fast, mucous membranes are dry, and blood pressure is 70 by 50 millimeters of mercury. RBS is 415 milligrams per deciliter and ketone bodies in the urine of 4 plus on dipstick. What is the next line of management? So what is this case? This case looks like it is a typical case of diabetic ketoacidosis. What is the next best step in the management? 2 to 3 liters of normal saline over 1 to 3 hours. Arterial blood gas. Insulin infusion at 0.1 unit per kg per hour, or insulin bolus of 0.1 unit per kg IV. So what do you think we should be doing here? Okay, what are the problems in patients with diabetic ketoacidosis? Problems in patients with diabetic ketoacidosis. Okay, number one, they have fluid deficit. They've lost a lot of fluids. Why do they lose? They lose because when you have diabetes mellitus, your sugars are going high and high, right? Because your insulin level is very low, your glucose is going high. Now glucose is a osmotically active substance. So when this glucose gets filtered into glomerular filtrate, it will not go alone. It will with it drag a lot of water. That's how you have polyuria in patients with diabetes mellitus. So they were losing a lot of fluid in urine. So there is fluid loss, right? So there is fluid deficit. First thing we should know is how much fluid deficit a typical diabetic ketoacidosis patient will have at the time of presentation. And we have another condition, right? Hyperglycemic non-ketotic state, or HONK, hyperosmolar non-ketotic state. Something similar to DKA. DKA is classically described with type 1 diabetes mellitus. HONK or HNK, hyperosmolar non-ketotic state, occurs. HHS is also what they write as hyperglycemic hyperosmolar state, that classically described with type 2 diabetes mellitus. Both of them will have fluid deficits, right? Who is more likely to have a higher fluid deficit? Is it DKA patient or is it HHS patient? So remember, it is the patient with HHS who is more likely to have severe fluid deficit in comparison to DKA. Okay, so there are two things: DKA, diabetic ketoacidosis, hyperglycemic hyperosmolar state. The main difference between these two is in diabetic ketoacidosis, there is ketoacidosis present, or ketone body formation is present. In HHS, right, no ketosis. Why ketosis occurs in diabetic ketoacidosis? Diabetic ketoacidosis is typically seen in type 1 DM. So in type 1 DM, there is absolute insulin deficiency, right? So your metabolism is totally shifted because you need insulin for the tissues to utilize glucose. You don't have insulin at all, so tissues will not be able to use glucose for metabolism. So they're dependent on fat as the source of energy. So when they're metabolizing fat, they're generating these ketone bodies, right? So there are ketone bodies present, but ketone bodies will cause symptoms. They are causing your pH to go towards acidosis. So you start developing acidotic breathing. When you have acidosis, respiratory system is compensating. You have hyperventilation, right? And then in that acidotic milieu, right, your muscle metabolism is getting affected. So you have myalgia and severe symptoms. You have this acidotic ketone breath. So all of this makes you come to the hospital much earlier than a patient with HHS. In HHS also sugar levels are very high, but it is type 2 diabetes mellitus, more commonly seen in type 2 diabetes mellitus, where you have some amount of insulin production still happening. You don't have zero insulin, you have some amount of insulin production. So that little bit of insulin production is sufficient for you to keep using glucose as the metabolism. So you're not producing too many ketone bodies. So because of that, you don't have ketone bodies, your sugars are going high, you're losing a lot of water in urine, but you're not having ketotic symptoms. So you present late to the hospital. So because of that, at the time of presentation, right, patient with HHS is more likely to have severe fluid deficit in comparison to DKA. Severe fluid deficit, much higher blood glucose level more than 900 to 1200 milligrams per deciliter at the time of presentation. On the other hand, DKA, because they have ketone body formation, that makes them symptomatic earlier, they present earlier. So at the time of presentation, they do have fluid deficit, which is also severe, but not as bad as what you would see with HHS. So fluid deficit here is approximately around 6 liters. They would have lost 6 liters of fluid from their body by the time they present to you with DKA. The fluid deficit here is usually 12 liters, 9 to 12 liters in patients with HHS. Okay. And the blood glucose levels at presentation in DKA is usually more than 250, in the range of 250 to 600. Yeah, HHS coma occurs. In DKA, coma chances are less. In HSS, it occurs very frequently because they're presenting quite late. Blood glucose level is shot up like anything. They have compensatory hyponatremia, cerebral edema, all those manifestations are happening. So which patient is more likely to have poor prognosis between these two? DKA versus HHS. Which patient is more likely to have poor prognosis? Right? So we all know it is the HHS patient, because they are presenting late, by the time they present, they have lost a lot more fluid than a DKA patient. Their sugars are much more higher. Their internal organs, renal functions may already be affected. They might have developed the cerebral edema and they can go into coma. So previously the naming of HSS also included coma, right? So the prognosis is bad for HHS, poor prognosis for HHS. Because these DKA patients, though they are ketotic, they present early. Their ketotic symptoms make them come to us early. So they have less fluid deficit. So it is little more easier for us to replace that fluid. The blood glucose level is lower at the time of presentation. So for us, it is easier to get it to the control in comparison to HHS. Okay, so HHS has poor prognosis. So I am more scared of a patient with sugar in the range of 800, 900 and not having ketosis than a patient who presented with DKA. But anyway, patients with DKA have significant fluid deficit, right? So they have around 6 liters of fluid deficit. So we need to replace that. What guidelines recommend is, right, we need to give replacement is in the form of 1 to 1.5 liter as bolus, 1 to 1.5 liter bolus. Okay, after that 250 to 500 ml per hour till ketosis resolves, after that you can use maintenance. Okay, so that is what we need to do. Fluids first we need to give 1 to 1.5 liters. 6 liters to deficit hai. All 6 liters we cannot just load. So first we will, at maximum possible pace, we will give 1 to 1.5 liter. After that 250 to 500 ml per hour till the ketone bodies disappear. After that around 100 to 150 ml, what is the maintenance required dose, we will give as long as patient is still having hyperglycemia. We start with normal saline, later we can switch down to half normal saline depending on parameters. Okay, then the second problem is they have hyperglycemia, right? The second problem they have is hyperglycemia. How do we treat hyperglycemia? We will treat by giving insulin. Insulin is also given in two phases. First is we give a insulin bolus. After that we give infusion, right? Because if you just start infusion, enough dose to go into circulation, it's going to take 1 hour. So we give first bolus and then maintain with infusion. The insulin of choice is always a short acting insulin, right? Most commonly we use regular insulin. So insulin used is regular insulin. Okay, what you call as actrapid. Okay, now there is a short acting insulin. Now there we give 0.1 unit per kg as bolus. So it's a 60 kg person, 6 units. 0.1 per kg, 10 kg के लिए 1 unit, 60 kg के लिए 6 units. That is the initial bolus. Bolus is 0.1 unit per kg. After that, right, we will give 0.1 unit per kg per hour as infusion. After the bolus, 0.1 unit per kg per hour infusion. And this infusion you can titrate according to the blood glucose level. You can increase or decrease. If your blood glucose level is not coming down despite giving this, you can up titrate. Okay, but that's the starting point. Okay, so now all these statements make sense, right? Like insulin we will give bolus, that is the important step. Infusion we need to start after the bolus, that's also an important step. Right? Do we need an ABG? ABG we will do, but it's not a paramount importance, because we know, like looking at the parameter, this patient will have metabolic acidosis on the ABG. The only reason we will be doing ABG is to see if we need to give bicarbonate replacement. So bicarb replacement is indicated if pH is less than 7.1. Right? You will give bicarbonate only if pH is less than 7.1. I don't give even at 7.1 if it is less than 6.9. There are different guidelines, some recommending 6.9, some recommending 7.1. Anyway, this question will not be asked to you. But remember, bicarbonate replacement may be required if severe metabolic acidosis, when the pH is very low. So just to know that whether I should do it or not, you need an ABG. Otherwise, it is not going to influence the management in any way. Okay. Now, giving 2 to 3 liters of fluid in 1 to 3 hours logically makes sense. Right? What did I tell you? First, we will be giving a bolus of 1 to 1.5 liters. So let me take it as a bolus of 1.5 5 liter. We gave 1.5 liter bolus, right? To give that 1.5 liter bolus, it might take 30 minutes or 40 minutes for me, right? Let me say I took 30 minutes. Next, the follow-up is 250 to 500 ml per hour till the ketone bodies are positive. So let me say that I gave 500. So for next 2 hours, I gave 500. So I accumulated, or I gave 1 more liter in next 2 hours. So cumulatively in 3 hours, how much I gave? Roughly 2 to 3 liters only, right? So this statement makes sense, right? This is also a sensible statement. Now, what is the priority here? Look at this. Patient has hypotension, right? I know if you give insulin, the blood glucose will start coming down, okay, but it will take its own sweet time. You will not be able to bring this blood glucose level down, even if you give a large dose of insulin and bring the blood glucose level quickly down to 200. It will not alter the hemodynamic instability and other parameters he's experiencing. For all of that to naturally set back, it is going to take time, right? At this high glucose level, patient has lost a lot of fluids in urine. If you get the glucose level back to normalcy, right, whatever is urinated, he is not going to reabsorb from his toilet. No, right? So it is important, but more important here is to first achieve the hemodynamic stability. So you need to give fluids here first. So among the steps, if you ask me what is the priority, priority is to give fluids. So that is our correct answer. 2 to 3 liters of normal saline over 1 to 3 hours. That is a priority. After that, if you ask me what is the next important priority is to give insulin bolus. Third important priority is to continue insulin infusion. After that, ABG, for me to decide whether to give bicarb or not, I will do it. Clear? Okay. So that's about diabetic ketoacidosis. Yeah, this seems to be a simple question. We will take that up for now and then we will connect again with the next session. Okay. A woman in her early 40s taking analgesics regularly for headaches for past 6 months. Now she presented with the intensity of headache which is increased in severity in last 3 days and reduced when she stopped taking the analgesic. What is the likely diagnosis? Tropical Capricorn and Joseph, right? Fluid replacement in any case of hemodynamic instability will be a priority because everything else can wait. If the BP goes down, multi-organ failure, kidneys are going down, acute kidney injury, that is all going to mess up whole things, reduce perfusion of the brain, ischemic encephalopathy. You will lose the patient. After that, what will you do with corrected sugars? Right? So priority is always fluids. Right. So this is a very typical story. Patient taking analgesics, worsening headaches, like take more analgesic, headache gets more worsened. When that stopped, it gets reduced. Right. So this is what is known as analgesic or medication overuse headache. So this is a very typical case. No doubt or confusion there, right? This is a medication overuse headache. Why this is not cluster headache? Cluster headache, they will give history of clustering, unilateral headache, right, of persisting for a few minutes to up to 4 hours. All that history is not there. They have not mentioned also alcohol. I told you that generally they mention that alcohol precipitates conjunctival redness and all, or the autonomic cephalgia kind of features they have not mentioned. Tension headache, a possibility in this scenario, but they are telling that tension headache responds well to analgesics, responds even more better to the tricyclic antidepressant. If you give them amitriptyline, they respond better because tension kam kar do, headache better ho jayega. But in this case, stopping NSAID is giving a result, so it is unlikely to be tension type of headache. To call it as migraine, the migraine episode should last for 4 to 72 hours, unilateral, throbbing, with or without aura, prodromal phase, postdromal phase. All that typical description is not there, so I cannot call it as migraine. I'm left with only medication overuse headache, and to support that there is history of improvement with stopping of medication, right? Okay, so guys, I think we will wind up for today. We are already past midnight. I am going to ask the PW team for giving me one more session so that we can continue with the remaining questions. We'll try to complete it before your upcoming examination. And once I'm done with the next session, we will start discussing individual systems and individual topics through the YouTube live streams. Thank you all guys. Thank you for connecting. And you have any suggestions for topics, you can definitely put it down to me on the Telegram or on the Facebook group. See you all guys. Have a good night and stay connected. All the best guys. Thank you all. Thank you.